Okay, good morning. People are still coming in slowly, but we already have 60 people on the Zoom, so we are just going to start. Yesterday was a good day. Today is acute support day, so to speak. First 2 hours we'll focus on cardiogenic shock, and then we talk transplantation and new methods of donor preservation, which is going to be really interesting with one of our other guest faculty, whom I will introduce later. But let's just get a background on cardiogenic shock. Omar Saeed, who is now the director of our heart transplant program, also has led the ECMO program for the past 3 or 4 years, I think, will give us an overview and state-of-the-art management and diagnosis of cardiogenic shock. Thanks, Omar.
Thank you, Uli. Always great to speak at the symposium.
Let's keep going. I did that yesterday.
Okay. Here are a few of my disclosures. Of course, I'm a heart failure cardiologist. That's ought to be one of the disclosures as well. So before we start, there's a couple of ARS questions. If you could respond to this one. So what is the in-hospital mortality for patients admitted with cardiogenic shock? Is it 10 to 20, 25 to 35, 40 to 50, or even more, 60 to 80%? So I see some responses coming in. Give it a few more seconds here. Okay, maybe people are a bit more optimistic, but it will become more clear what this is. And the second question, so in the danger shock trial, what percentage of patients received durable LVADs? Was it just 4%, 6%, 8%, or a tenth of the patients? Okay, so A and B are, I guess A wins out. All right, let's move forward. So as we get into this topic, I just want to define it for us as we see it clinically. So it's a shock state. It's defined by low blood pressure. In this case, it's the systolic of less than 90, and a diastolic around 60. There are situations, though, where that's not the case. The patient is already on drips. They're on pressors and inotropes. Their pressure may actually be higher, over 90 systolic, but they still may be in cardiogenic shock. That's important to keep in mind. And there is an entity of normotensive cardiogenic shock, where the blood pressure is not low, but the perfusion is not great. And that's important to recognize. And if those patients are missed, they won't do well. So blood pressure is not everything, but it's a simple metric we can use to start thinking about it. And then there's perfusion. So perfusion is defined by low urine output, less than 30 an hour, or a higher lactic acid over 2. These parameters start to be met. The patient is not only in shock, they're actually hypoperfusing. It's very important, especially when we get into how to restore that perfusion. Very important to recognize. Then we move on to these more higher defined metrics which require Swan-Ganz monitoring, such as elevated intracardiac pressures, a higher CVP, 10 to 15 range, or higher wedge pressure, 15 to 20. Again, this requires Swan placement, but you can get an early idea just by central lines if their pressures are high in the heart. Finally, a low cardiac index, of course. We cannot necessarily have cardiogenic shock, most phenotypes, when the cardiac index is not low. So we want an index of less than 2.2. But what is the pathophysiologic problem, once it is recognized? And this has been worked on for many decades. And when the heart is dysfunctional, there's reduced cardiac output, right? And there's some etiology that's causing this, ischemic or non-ischemic. But as the output is low throughout the body, there's also reduced coronary perfusion, and the intracardiac pressures are higher because heart is so dysfunctional. There's higher pressures inside the heart. Ultimately, all these things lead to more and more cardiac dysfunction, right? Lower coronary perfusion, higher wall stress, and this is a feed-forward process. The other part of it is, though, noted on the right box, is there's this whole issue with vasodilation in cardiogenic shock. It's not only just low perfusion. If time goes on long enough and it's not recognized, it's going to get into this whole process of reduced perfusion and vasodilation. This happens because as the end organs get damaged, there's a lot of these cytokines that are released, and they have an effect of vasodilating the system, so the SVR then drops eventually. And once that starts to happen at the organ level, the end organs start to release even more cytokines. And then the process becomes out of control. And this is how we see a lot of patients present, or at least when we recognize them, they're in this mixed cardiogenic vasodilatory situation. And that's much more difficult to manage, yet very common. Part of this mixed shock phenotype is this idea of damage to the microcirculation. We can't see the microcirculation. We see the labs come back, the creatinine is elevated, the LFTs are elevated. But what's going on is the organs are becoming damaged. These are some pictures. These are a control of the sublingual small vessels. You can see at the normal state. And then in cardiogenic shock, there's disarray. There's a lot of edema. There's damage to the microvessels. And that is something we don't want to get into. And this happens as the process is recognized later, or there's an initial large insult. The problem is that in the beginning, when there is macrocirculatory dysfunction, we can restore that, right? We can give inotropes, you can put in a temporary device, the hemodynamics get restored, the perfusion gets restored, great. But if that happens too late, and there is a lot of malperfusion, and we recognize it late, even if you restore the perfusion and the cardiac index, the patients won't do well because their end organs have been damaged, possibly to the point of no return. So time is very important in recognizing this early on to prevent this downstream process. Quick slides on epidemiology. This is a major issue, right? This is the issue of our time in cardiology. The incidence of cardiogenic shock is on the rise. In both non-ischemic and ischemic etiologies are on the rise. And in STEMI, which is a common etiology of cardiogenic shock, patients that present with STEMI, they are more often also presenting cardiogenic shock. So it's very important to know this as we tackle the problem. Now, it's not so straightforward. We talk about cardiogenic shock, but this thing exists in various domains that have some overlap. There's acute MI cardiogenic shock in the cath lab. Then there's a whole different domain of post-cardiotomy cardiogenic shock. After open heart surgery, long bypass time, patients come out and they require MCS. Those patients usually tend to have even worse prognosis. There are patients that have either new heart failure or very often acute or chronic heart failure that then deteriorate into cardiogenic shock. And there are other secondary etiologies such as valvular, arrhythmic, or pericardial disease that can then lead to cardiogenic shock. And of course, right in the center, there is cardiac arrest. So many of these can then lead to cardiac arrest, or that could be the initial presentation. And so there's some overlap. But this issue of cardiac arrest is really its own separate entity, because with the downtime, when the patient's perfusion is restored, a lot of times there's end organ damage happening. So those patients really have a very poor prognosis. There's some modifiers, specific diseases that need to be recognized early on because they have their own specific therapies, such as myocarditis, Takotsubo syndrome, which is exclusionary diagnosis, amyloid, and peripartum cardiogenic shock. Mixed shock we discussed. So there are some early studies about reperfusion during cardiogenic shock. This was a shock trial done many years ago now. This basically, patients were randomized, they presented with acute MI cardiogenic shock, randomized to revascularization or medical therapy. And for these patients, revascularization in the cath lab had an improvement in survival in the short term and also in the long term. You can see the second graph is over 10 years. So important if the patients, maybe if they're not very revascularized early on, if they stay in shock, it's important to address the culprit lesion and revascularize it. This was a more recent culprit shock trial. This just gets into, in the situation of cardiogenic shock, it's important to just go after the culprit, not try to fix every lesion in there. Really focus on what's causing the acute problem and revascularize that. And that had a better survival outcome than multivessel PCI. But the issue is this, right? Even after revascularization for acute MI cardiogenic shock, and in all types of cardiogenic shock, the mortality is stagnant. We haven't really reversed this problem yet. And this has been true for many decades, as noted here. And it's high, right? This was that first ARS question. About half of these patients are not going to live. So this is a meta-analysis of 2.5 million patients. It was published in the New England Journal of Evidence. And this gets into the risk factors of death in cardiogenic shock. Some of these are intuitive, right? Older patients, those with higher comorbidities. But this does hone into the higher risk characteristics, right? If you have these patients in cardiogenic shock, they should have a target on them. They're not going to survive. So we have to be aware of that. And then moving downward there, you can see women. I'm going to show that next slide some more. Women that are at greater risk of dying than men when they have cardiogenic shock. And of course, presentation. This is, again, this cardiac arrest issue. Patients that present post-arrest have a much higher mortality. And of course, those with end organ injury. This is a study from the Cardiogenic Shock Working Group. This is a retrospective registry of multicenter. This is in 5,000 patients. And again, noticed here, the bar graph, women in red have a worse mortality, lower hospital discharge when they present with cardiogenic shock. And aside from mortality, the side effects, the problems from side of cardiogenic shock, vascular problems, bleeding requiring surgery, and limb ischemia happen more often in women. So more bleeding, more vascular complications. Maybe these mediate the lower survival, perhaps. But also what's a little bit disturbing in something that's a bit more controllable is the use of durable therapies such as LVAD and transplantation is lower in women if they're presenting with acute MI or heart failure cardiogenic shock. So this is something we have to be aware of and needs to be investigated more, is why is this the case? Why are women being implanted less with durable LVADs and transplanted less than men? This is another something we see day to day, right? Transfer. As systems expand, this hub and spoke model, a lot of patients are transferred into our center, but the patients that are transferred in tend to have a higher mortality for cardiogenic shock. So we can bring the patient in, but we really have to be aware of this, that they're going to do worse than the patients that were in here already. Now, this has many reasons. Maybe, the transfer process, it takes time. We were catching them by the time they get here too late, or where they're coming from, the process was recognized a little bit late. But these patients really do worse that are transferred over to tertiary care centers. They also have a lower rate of HRT, which is heart replacement therapy. Now, that may be the mediator of lower mortality, of greater mortality, but they are at greater risk. This was a study done to find out again how can we make some headway, recognition of who is at the higher risk. Now this was again this cardiogenic shock working group registry as well as a couple other cohorts. What they did was took the patients and used AI to define 3 different phenotypes. One was the non-congested phenotype, so really early on in the disease, then a cardiorenal phenotype, and finally the cardiometabolic. As you can imagine, the later on in the disease process, the mortality was greater, and that was true across all 3 cohorts. This again just goes into this idea of early recognition of patients that are falling into cardiogenic shock, because they're going to do better than the ones that we capture late. So to stratify and identify these patients, there's a classification system that's now being used more often, and this doesn't require Swan-Ganz monitoring. This is the SKY classification, right? So what we want to do again is recognize early. So this is a 5-tier system is listed here. So A patients are those that are at risk for cardiogenic shock, and then B is the beginning of this process where there is some hemodynamic instability, low blood pressure, but not low perfusion yet. And then C is when the organs are now starting to be malperfused, and then so on, D and E, which are very high risk and higher mortality. Now, when patients are classified in this scheme, they do stratify, as you can see here, with higher and higher mortality. So the system works. If we can label them very early on, we can at least know where they stand and recognize that the process is starting to happen. But the thing is, you may be able to recognize it up front, but things change. And this is very much true in cardiogenic shock. We can make a plan, but then things will all of a sudden change, and we have to be ready to respond to that. So in the real world, there's a lot of flux. Patient comes in, there's a multidisciplinary discussion, we make a plan, we execute it. In the CCU, everything changes. Maybe they have an arrhythmia or bleeding or some complication. So this requires reassessment over and over and over again. This is not the type of disease where we just make a plan in the beginning and then just let it see through. It doesn't work that way. It really requires reassessment in the CCU over and over again. And this is recent guidelines that were published for cardiogenic shock management. And one of the things that was highlighted was this reassessment thing. We have to look at the patient over and over again. And this is the way it's done, right? This is basic medicine, but it really requires somebody paying attention and checking all these things over and over again. So clinical exam, vital signs, the laboratory parameters, imaging, echo and chest imaging, invasive monitoring, and understanding how to use that information is very important. You can't just have a swan and it's running on the monitor, nobody's looking at it and using that. So very important. And of course, the shock team is definitely important in the beginning, but then it has to remain in communication as the process is changing. I think this is vital as we try to improve the prognosis for this disease state. This is some more data from the cardiogenic shock registry. And again, just really shows the flux in disease. So there are the group of patients, that may present early on with SKY stage B, which is just the beginning, just initial hemodynamic instability, no malperfusion, but many of them will progress into worsening SKY stages. And how will we know that? We have to do the repeat assessments. We can't just look at them in the beginning and forget about it, and the patient starts to deteriorate. Nobody knows until it's too late. So this is not a static problem, it's dynamic. This was the early diagram, how we used to, categorize these patients. Very simple rubric here. And you can see, I'll go through it, there's much more than meets the eye, it turns out, especially as patients go from decompensated heart failure into cardiogenic shock. This is, again, an initial system, but we can no longer just categorize them in this way. I think it has to be much more in depth to really recognize what types of therapy are tailored for a specific patient. And I'll try to demonstrate that here. Basically, what I'm talking about is the hemodynamic phenotype of a patient in cardiogenic shock. You can see here, there's 4 scenarios. All these patients have the same blood pressure, right? But as we delve more into it, they may have completely different hemodynamics within the heart, which will require different sorts of therapies. So this patient here on the left, if they have a Swan-Ganz in, the RA pressure is 10, PA pressure is elevated, wedge pressure is elevated, with low cardiac index. Next patient, the RA pressure is elevated, they have low PA pressure, low wedge pressure, same cardiac index. Third patient has elevated biventricular filling pressures, PA pressures in the intermediate range, and again, a low cardiac index. And finally, this last patient is actually on 2 drips, norepinephrine and dobutamine, and they have elevated biventricular filling pressures. Now, all of them have the same blood pressure. So we have to put this PA catheter in. Without that, we're not going to get this additional information, and it will remain a black box. Now, this is important because these are, as will become more clear, may require different sorts of therapy. So the first scenario is predominant LV failure, then RV failure. The third case is biventricular failure. And finally, there's this mixed vasodilatory cardiogenic shock picture. So to deal with these different phenotypes of shock, there's been greater use of MCS. There's data here that shows, this published in JAMA, that in the more recent era, there's more and more use of MCS devices, especially the microaxial device, based on some of the data that's accumulated. So this is a lot of the tools that we use day to day as we manage cardiogenic shock, and we recognize that hemodynamic phenotype. One thing that's important to note here is there is 2 sides of this equation, right? We focus a lot on the restoring perfusion through MCS, but the other side of it is decongestion. So we can't just put the device in or put the patient on inotropes and not decongest them. These things go together. So decongestion is very important. This can be done through diuretics, renal replacement therapies, and so it's very important to do that. And then as we move forward, of course, we have to think about restoring perfusion and perfusing those end organs. This can be done simply with inotropes, but if the inotropic requirement is high or if there are side effects happening, then we move forward into this other MCS devices such as balloon pumps, the Impella device, and right-sided devices such as the ProTac, biventricular devices, and finally ECMO. So how do we pick which device to use? There's so many of them, right? So first, like I said, it's important to know that hemodynamic phenotype. That's going to guide a lot of that decision making. But more intuitively, how much support is needed? We don't want to put somebody, that only needs a little bit of support on VA ECMO. That's just too much. Maybe they'll be okay with a balloon pump. So it's important to recognize where we stand with that. Vascular disease is critical. These devices have large cannula. If the patient has severe peripheral vascular disease, they're going to have limb ischemic complications when those large cannula are inserted. It's important to get an assessment of that. LV thrombus is important. A lot of stuff is going on in the beginning. The patient presents with cardiogenic shock, cardiac index is low, somebody wants to put an Impella in, and then the patient has a stroke. So we have to know if there's an LV thrombus present. I think this is a factor that's sometimes missed. Mechanical aortic valve is important to be aware of. It's going to be not possible to put an Impella through the mechanical valve. It will cause more issues. We talked about the phenotype. And finally, the entire patient, right? This is tough to do in an acute setting, but we should try. And as time goes on, we need to know what the comorbidities are of this patient. It's not going to make a difference if they have end-stage problems from other reasons, such as malignancy or whatever. So that's very important. We got to take the entire patient into the picture. And finally, the exit strategy. ECMO, I'll get into this. There's a lot of ECMO use, but the mortality is not great. And much of this has to do with patient selection. We cannot use devices in patients whose prognosis is not going to change by MCS because they have other comorbidities. And what is the exit, right? We can get the device in. This is temporary. These are not durable devices. So we have to know what is the durable strategy up front. Are there candidates? Recovery is sometimes an option too, but we have to also be aware of what the final option would be. The patient did not recover. So now moving forward, what are the data for these devices? And so this was the IABP Shock 2 study done over 10 years ago. These were patients that were presented with acute myocardiogenic shock. They were randomized to balloon pump or control. Important to note that in this study, close to half of the patients had cardiac arrest, and the lactic acid was around 4.5. But the findings of the study were neutral. So for acute MICS, balloon pump didn't make much of a difference. They are used in day-to-day practice, but this study told us that they don't make a difference clinically, at least when studied in a randomized fashion. This was a study that was published more recently. This is the ALL-SHOCK 2 study. In this study, patients were in non-ischemic cardiogenic shock. So this was not acute MI patients, but the whole heart failure cardiogenic shock group of patients. And those were studied to see if balloon pump makes a difference. So a lot of patients were screened, about close to 800 patients. Many were excluded. So this was a highly selected group of patients that finally were randomized, you can see that 87% were excluded, and none of the patients had cardiac arrest in this study. And perfusion was also not that bad compared to the prior. The lactic acid was less than 2.5 the patients. Finally, though, once they were selected, they were randomized to pharmacologic care or balloon pump. And you can see there was some crossover and they were analyzed. And the curves are noticed here. Now, this trial actually was stopped early for futility. There was an interim analysis, and the DSMB felt that they had to stop it because it wouldn't make a difference if they enrolled all their sample size. But it was a neutral study. So even in heart failure cardiogenic shock, as far as this study shows, there was no difference with use of balloon pump. One thing that was striking to me is the use of durable therapies. And this is the theme of this talk. In this study, the use of durable therapies is very high compared to what we see in other studies of cardiogenic shock. 40% of the patients either had a heart transplant or durable LVADs placed. Now, these are a little bit different types of patients. They're more selected than the acute MI patients, but 40% is high. And you can see in either curve at the end, 75% of the patients survived. So they were salvaged with these durable methods. And I think that's an important thing when it comes to cardiogenic shock, is the use of these durable therapies. Now, balloon pump, of course, is used, I showed you two neutral trials, but we use it all the time because there is some data, the first graph on the left there is a sub-study of the shock trial where there was some group of responders. Some people, you put the balloon pump in, they have good restoration of hemodynamics. And if you are one of those people, one of those patients, you're going to do better. And then in our own group, Francesco Castana has studied this, longitudinally, what are the patient factors that can predict response to balloon pump? And some of those are shown there. And we're going to try to figure more of this out. So we can't really throw it away here. We all know from our own clinical practice, there are certain cases balloon pump really makes a difference. Now I'm going to move forward into the dangerous shock trial. This is going to be debated by the experts in the room. I'm just going to introduce it. This was a big splash trial in the field last year. This was done in Europe. It took 10 years to complete it. And these were STEMI patients that had presented in cardiogenic shock. So you can see a lot of the patients were excluded, 2/3 of them. And that's similar to real world registries. So the patients that were finally included in the study for randomization, only about 1/3 of them are the ones we see in day-to-day practice. But once that randomized cohort was set, they got the Impella CP device for standard of care, and then the patients were analyzed. So at the 6-month time point, there was an improvement. You can see in the yellow line there in the primary endpoint from the patients that had a microaxial flow device compared to standard of care. Now, I've been highlighting, it's always important to know which patients were in the study and how sick they were. So in this study, about 20% of the patients had cardiac arrest, and the lactic acid was around 4.5. So, the very first IABP shock study, about 40% had cardiac arrest. So the authors here purposefully excluded patients, many patients that had cardiac arrest, because it's felt, I think, that it's its own entity. What leads to death after cardiac arrest may not be hemodynamic related. There's a lot of brain injury, and those mechanisms are different. So that was something that's been learned over time. But one thing I'll highlight here, even in this study, the use of durable LVAD is extremely low, right? This was one of the ARS questions, about 4%, compared to 40%, which is what we saw for heart failure cardiogenic shock. Here is 4%. And then you can see with both of the curves end up, although Impella improved things a little bit, but ultimately close to half the patients died in both arms. I think some of the limitations of the study are going to be highlighted in the debate. One quick thing to mention, there was a high fragility where 4 patients, if they had a different outcome in the control, the trial will become neutral. This is considered a highly fragile study. Another important thing to highlight here, and this is a bit counterintuitive, there were more side effects, right, with the Impella in place. There was more renal replacement therapy, more stroke, and yet the survival was better. I think this requires more study. Perhaps the impact of Impella early on, obviously is greater than what happens with these side effects. Maybe the renal replacement therapy is short-lived, but something that was a bit counterintuitive. Now, there was a parallel trial that was planned here in the US, the RECOVER-4 study. This trial is canceled now because now, it's difficult, I guess, the equipoise is not as much. Like we have positive findings with all their limitations, now it becomes difficult to consent patients. So unfortunately, after I think a lot of planning, and these authors, did an incredible job getting things off the ground. It's very difficult to consent these patients, but ultimately it was canceled. Moving forward from the Impella CP to the 5.5 device, this is the data from the cardiogenic shock registry. This is about 750 patients. What happens with patients in cardiogenic shock that get the Impella 5.5? Now that's put in through the axillary artery. It's not in the groin anymore like the CP. It's more durable than the CP. And in this registry, the survival outcome is greater. About 2/3 of the patients survive. So this is higher, right, than the 50% number we were talking about. But most of these patients are probably listed for heart transplantation. Close to half of them got heart replacement therapy. But there was recovery in 20% of them. I think one other important thing that was useful in this study to see is what happens when there's two devices in place. So across all these different side effects, right, there's higher burden when there's two things in place. We talk about this more and more with ECMO and venting, but there's a price to be paid. There's not a freebie. There's more limb ischemia, they're likely sicker patients, but all the other complications happen more often with two devices. There's an ongoing study, the IMPACT trial. This is in the cardiac surgery area. It's a single-arm study where one of the sites here, patients have high-risk cardiac surgery, have a reduced EF, they have Impella 5.5 supported, and the findings of this study hopefully will be available in the near future. Now, moving forward from Impella to ECMO, this is all over. A lot of hospitals using a lot of VA ECMO for cardiogenic shock. The numbers have skyrocketed, right? It's an exponential rise. Unfortunately, though, notice at the bottom there, the mortality is no good, right? So way more than half the patients that receive VA ECMO for cardiogenic shock die. So this is multifactorial. It has a lot to do with patient selection and side effects on ECMO and lack of an exit strategy, but we're using it. It's in vogue these days. So there was a randomized study for ECMO, the ECLS shock trial. This was the largest study. And patients were randomized in the cath lab to ECMO, no ECMO. Ultimately, it was a neutral study in 30 days. One thing I'll note here, and it's pointed to, the duration of ECMO support was just 2.7 days. This is not what we see. This was done in Europe, the study. In the US, I would be surprised if the patient is supported for only 2.5, 2.7 days. It's a very low support time. And the people that were enrolled in the study, 3/4 of them have had cardiac arrest. So that is, again, this whole other domain of cardiogenic shock, which may have a different mechanism of death, but 3/4 of them were post-cardiac arrest. They were malperfused, the lactic acids were elevated. But once again, the use of durable LVAD support is very low, less than 1%. Durable LVAD therapy, of course, is a field that's been highly explored, and we know that outcomes improve with that. But the use of this in this population was very low. Important to note the safety issues with ECMO, and this was shown in this study. There was quite a bit of bleeding and stroke, twice as much as the control arm, and these contribute to greater mortality as well. The side effects, we just saw in the ECLS study, that prior slide, but these are happening quite often during VA ECMO, and there's quite a bit of work being done in how to mitigate these side effects and reduce them, because that may improve outcomes on VA ECMO. This is a lot of cannula site complications, bleeding, patients are on anticoagulation, they have coagulopathy, so we struggle with that, and a lot of them tend to have bleeding problems. There's hemolysis going on, and stroke remains an issue. If patients have these events, of course, they have a higher mortality. While ECMO, this is a schematic of a patient on ECMO, and I think it highlights an important point here. As preload is reduced, so the ECMO circuit removes volume from the left side, it goes through the circuit, gets oxygenated, put back into the system, which increases afterload in front of the aortic valve, right? So this leads to aortic valve closure. And this is an important thing because once that happens, there's stasis around that area, which could lead to clot formation, even on anticoagulation. And also backward rising pressures in the native circulation in the lungs, leading to more complications. Important to recognize, if we can pick up that the aortic valve is closed and there's stasis going on, we need to do something about that. Albeit venting or other methods, get them off via ECMO or use inotropic support, but very important to recognize that the aortic valve is closed. Venting is one method to relieve the stasis around the aortic valve. And this was the data that shows, venting is being used more and more often. And the way it's being used is through, again, that second device. the Impella 5, although we saw that with 2 devices in place, there's also issues with that, but it is being used more often. This was an association study where a lower mortality was noted with venting in place, but again, it's an association. We don't know if there's cause there, but clearly greater side effects though when 2 devices are in place again. Here, we don't vent all the patients on VA ECMO. It's more of a selective strategy. Once it's placed, we try to assess the patient. Again, that reassessment thing. Is there aortic valve opening? And this can be quickly assessed at the bedside with a focused echo. Is the pulse pressure low? Is there a high wedge pressure? If those things are happening, you can put a patient on low-dose dobutamine. If that doesn't change things, then it makes a bit more sense to go ahead and vent the patient. So we're not doing a priori venting of all patients on VA ECMO. I'm going to move forward a little bit on what are the possible high-risk features on VA ECMO and possible therapeutic targets, right? This is something I think where the field is going to move to for cardiogenic shock. So we talked about how hypoperfusion leads to greater inflammation in the end organs, and ECMO itself creates inflammation. This is a heightened inflammatory state. So a marker of inflammation that's readily available is this neutrophil to lymphocyte ratio. The higher it is, the more inflammation is happening in the system. So we looked at our own data and we saw that, this marker, which is readily available, actually does stratify patients' outcomes. So those patients that had an increase in this marker while on VA ECMO versus those where it did not go up tended to have a worse prognosis and reduced survival. There are other therapies that are under development. So one of those things is this cytosorb system, which is connected in parallel to the circuit. And this can actually remove those cytokines. The idea is that will reduce inflammation, vasodilation. And there's some very, very early data that with usage of this parallel circuit, there's reduction in the inotropic use. One exciting area is this compound dipeptidyl peptidase. Now, this is a marker of vasodilation. It actually is a peptidase, right? So it cleaves proteins. What it does is it cleaves angiotensin. It's sort of like an ACE inhibitor in that way. And the last thing we would want is somebody that's in shock to have less angiotensin. But this is produced, our body, if a patient is in shock, they will produce this peptide and it will cleave that angiotensin. Now, so it's a marker, of course, of worse disease state. So it's associated with prognosis, right? The non-survivors in cardiogenic shock have higher levels of this compound. But now an antibody has been developed. So in vitro mouse model studies show is if the setup receives an antibody, there's reduced oxidative stress, that last box there. So all the red is the oxidative stress. But when it's added with the antibody to this compound and it's blocked, there's a reduced oxidative stress. And I think eventually the investigators may try to do more higher phase studies. One other study that's going on right now is this COCA study, which takes into account this whole idea of adrenal insufficiency during cardiogenic shock. This is a randomized study that's happening, and the patients, after they meet the inclusion criteria, randomized to placebo or hydrocortisone or fluorocortisone, and then the endpoint is days free of catecholamine support, and we'll see if this makes a difference. To end here, I think the data does show that there is a rising burden of this disease, right? With a high mortality. Half the patients are not going to live. Timing is critical. If you recognize it too late, the end organs have been damaged. There is that discordance between the macrocirculatory hemodynamics and the microcirculation. We may be at a point of return, so you got to catch it early. The phenotype is very important to define. You got to put the PA catheter in to define the hemodynamics, to pick the right device. Now, this other point, which is kind of near and dear to me, is that this is not a snapshot problem. We can have a multidisciplinary discussion in the beginning, which is incredibly important. Make a plan, but it's going to change. And reassessment is vital. And I think this is where the heart failure cardiologists actually have a major role, because this thing does not execute itself on its own. Things change all the time, many times, even in the same day. So we all have to have repeat meetings, repeat discussions, and there's a plan that will change, and we have to adapt to that. The use of durable therapies, such as durable LVADs or heart transplant, is, I believe, underutilized in this state. Now, it's not easy to place these therapies, but we really have to think about them. And I think the studies show that this is one area that's changeable, as long as the candidate is appropriate. Now, this is tough because there is a drop in our field, right? Less people are going into heart failure and transplant training, and so this is going to become difficult. But I think this is a way out of this. We need only a small percentage are going to recover, and somebody needs to understand these therapies and drive that from the beginning. So the field is going to have to grow in some way. And finally, I think there's a big room here to improve things through pharmacologic management. I showed some of the studies, like the COCA study, and there's other focused, targeted anti-inflammatory therapies that are under development. I believe that's going to at least be investigated. We'll see how much of a difference that makes. Thank you so much.
Have to. Great. I just have to make a few comments. So I'm listening to Omar, leaving peptides, association analysis, large bore cannula, and Omar actually understands the detail of all of this, the statistics, the basic science. And there are many people like that when you go to university programs that will give totally polished talks like this one. But I'm going to say 80% of them are not going to be able to now go upstairs and manage a patient who is critically ill and dying as an expert clinician. And that's really the role model, I think, for Montefiore and all heart failure cardiologists. So thank you. I'm going to talk more about you. Omar, has just received a $2.3 million grant from the NIH, which is an incredible achievement, and actually was not here yesterday because he was at the Gordon conference in Spain. It is by invitation only, and gave a presentation on vascular dysfunction in other cases, which we could pull off now and just play, but we don't have time for that. So thanks, Omar. I do want to make two quick things. You mentioned gender in the beginning, right? Dr. Mera and I were just in Stockholm where Holger Thiele, the shock author, actually, they've done an analysis about gender, and I'm going to put Mandeep also on the mic in a minute, but I was left with that, yes, of course, there is a difference between outcomes in men and women, but women, of course, are generally smaller, so to speak, body size or all cannular issues. And second, women, just like with myocardial infarction, present much later. So I think it's somewhat of an unresolved issue whether the sex difference actually makes the difference, or whether it's just a smaller patient coming much later and doesn't come early enough. So it's just something I learned last week. And then the microcirculatory, and I know that Mandeep is into that. I'm looking at the picture. Somebody comes in shock, and I can look at the vessels and mucosa, of course, that can. But what do you think we can do about that? Because vasodilation would probably be the answer, but you can't do vasodilate a patient that has a compensatory vasoconstriction. So I'm going to also want to hear what Mandeep thinks about the microcirculatory after you answer.
Sure. Thank you, Lee. I have to say also that, from all the things I've had the opportunity to do, you've been there along the way, all the way. I have to give all credit to you, and without you, I don't think any of that would be possible. So thank you so much. This issue with the microcirculation, I think this is an opportunity to identify downstream targets. Part of it is catching the patient early on before it happens, right? But the other part of it is it's an opportunity to identify, what anti-inflammatory targets we can focus on to reduce the microcirculatory damage. So it's timing and development of new targets.
Mandeep, you want to give your take on this?
Sure. So first of all, it's such a pleasure to see both of you standing together, because you exemplify the sacred bond in scholarly activity of a mentor and a mentee. And congratulations for all your success, Omar. We're so proud of you, and thanks for leading the field. So the points that have been made are great. So I'll attend to the microcirculatory issue. So by the time, it's not just women who arrive late, it's also patients in cardiogenic shock who arrive late. And we often don't act on it. And our only attention in cardiogenic shock focuses on the hemodynamic model at this time point. And I made this point last week at the Karolinska, and I said that perhaps the real pivot point for us in cardiogenic shock will come when we pivot in the same manner in which we pivoted in heart failure in the 1980s, which is that for years and years and a few decades, we basically had our entire attention on the hemodynamic model because that's what we did. We had dopamine and isoproterenol and things like that. And that's what we're doing now, and perhaps to the detriment of the disease and its understanding. And that unless we partner therapies that are attentive to the periphery, as we did in heart failure, we may not make further inroads beyond the 50% block that we have. So that's point number one. Point number two is, Uli asked, what can you do? So, for example, I will tell you that if you start looking for things, you will find them. And one of the things that you will find in patients with cardiogenic shock, particularly those who present to us, is what's also referred in the literature as CIRCI, which is critical illness related corticosteroid insufficiency. If you start to investigate a group of these patients, and I hope you do that, you will find that about 40% of patients actually have adrenocortical axis deficiency. Now, maybe those are the targeted patients for such therapies, such as steroids, and not just generically anyone with, say, in the COCA trial and others. We're doing a trial at the Brigham now called CortiShock, but very similar to this, but with some changes. In terms of what targets we can actually hit, DPP3 now has an inhibitor. There is early data in animals that suggests that this inhibitor can in fact improve hemodynamics. I don't know if tackling that will make a difference, but certainly it is another way of basically, instead of giving DPP3 inhibitors, you could just give angiotensin 2. Right? So I'm not sure that that's going to work. I think corticosteroids are an important target to investigate. I think that anti-complement inhibition drugs are probably another area that needs to be redusted from over 20 years ago. So there's a whole slew of microcirculatory opportunity here in targeting. But really, we need to think about what's the best way that we restore central hemodynamics without worsening peripheral hemodynamics, which is what the challenge is in the field at this time point.
No, well said.
Thank you.
Thank you. Question
Excellent.
to the expert.
Yeah, stay here, Omar. You are the expert.
Omar, so I mean, for those of us who, you guys take this to a whole different level. I understand half of what you said, because I'm just a plumber who puts devices into patients.
He's setting me up for the debate.
But seriously, I mean, because again, for those of us who are not in heart failure, we're treating patients, we're in the cath lab. I love your talk, but practically, I mean, what is the current role still for a balloon pump? I mean, because it's more and more, it seems, and I struggle with this because I still use balloon pumps despite the conflicting evidence. But a lot of my team, my colleagues, challenge me and say, but Azim, there's no data for it. Why are we still using it? Right? Is the only role for it in a patient that I cannot put on ECMO or invalid if the access is so bad? Is that the only role for it?
It's clearly used still, right? So that's the question. I think there's two answers. One is there are responders. We've seen it's hard to identify them up front, but some patients are going to respond to it. The randomized studies don't distinguish between that, right? It's all comers, is irrespective, but there are some responders. Number two, the side effect profile is much more friendlier for a balloon pump. So I think those two reasons continue to drive the use of it.
And then maybe one last question, just on the ECMO side.
Let me just also, I want to weigh in on that. And there's one, it's related, one question in the chat about whether we have integrated the SKY stages into our Epic EMR to have pop-ups that the patient is sick. So the answer to the person on Zoom, is there like 85 people on Zoom right now? Thank you, is that we're working on that. But I also want to address the balloon pump because don't walk away thinking that the balloon pump clearly does not do anything in AMI shock in that patient population. Clear. Also notable, as Omar alluded to, the serious adverse event profile in shock 2 between patients that got a balloon pump and did not was exactly the same. Okay, so the balloon pump had really no negative impact. Alt shock 2, the heart failure and cardiogenic shock, that's why the SCAI stages are important, included patients in SCAI stage B. And for those of you who don't study this every night, SCAI stage B means you may not have evidence of hypoperfusion. So if you instrument somebody with a balloon pump who doesn't have evidence of hypoperfusion because you're going to complete your trial, that of course is bad. This is a very bad study, and in heart failure and cardiogenic shock, we don't know if balloon pumps work. In clinical practice, and we just together published this case report, my sense is, for example, patients with MR, severe MR, are those where you should first try, but we've done this together many times. So I think we have to find the phenotype, and because the price that we pay for in para and ECMO is so high, we owe it to the patients. I'm going to say it's 20% of shock patients that will have a good response to balloon pump, certainly those who are not AMI.
So Yuli, just to comment on that, because at another place, they actually summarized what the responders, LV dominant failure, heart failure cardiogenic shock, as opposed to AMI cardiogenic shock, preserved right ventricular function, SDR greater than 1300, favorable RA to wedge ratio, and they do respond. Susie Joseph and I wrote this up with balloon pumps for rehab, and the dominant feature, if you're going to take something away, is if your RV works, and you have a high SDR, you probably will respond. But I will point out something in the shock 2 trial and the others, that the adverse events with balloons, bleeding and limb ischemia was the same as it was in subsequent events, such as the Impella, the danger shock trial. If you look at the complication rate for shock patients, it's the same no matter what the active intervention is. Surprisingly, in ECMO, it's the same as it is in Impella, as it is in balloon pump. But if you put them up across the board, they all have complications because it's the patients, not the intervention.
Okay, we'll put a pin in that because that's kind of part of the debate. But you had a second question, Azim? Yeah.
I had a second ECMO question. So, in the cath lab now, we're doing procedures that have become more and more complex, right? Again, we have patients where we're tearing apart their leaflets, we cutting the leaflets, we're destroying leaflets, creating severe aortic regurgitation while we try to get a new valve in. And one of the challenges for me has been how to support those patients during intra-procedure, because a patient with severe aortic regurgitation doesn't do well with ECMO. I can't put any pellets, I'm trying to put a valve in. And there's been a lot of interest now in the literature of left atrial VA ECMO. Do you think that has any role? I mean, we're not doing that here in Monte. Should we be looking at doing more, putting the cannula across the left atrium so I can decompress the LV?
Yeah, I believe it does. I think aortic insufficiency is a difficult situation, right, for routine ECMO. So unloading the LA, like you described, does have a role. And I think the more of it we do, the better we'll get at it. It's not a common situation, but that is one of the ways to deal with it.
With the lava strategy, which is intuitively easy, requires a septal transeptal approach, of course, which can be challenging for some folks. The problem with that strategy is that it's not controllable to recovery. So as a bridge to let's say you want to bridge someone to a surgery, then it works really well. But it's not a good bridge to recovery because there's no way to control the multi-stage in terms of recovery. Right?
So I'm really thinking about using it to support a procedure. It's a bridge to a procedure, right? So putting it in, and then I'm going to destroy the patient's aortic valve leaflets, and then put another valve in. So there's going to be this period of 10 minutes where they have no aortic valve, basically. And without some sort of support, they're going to die.
Well,
There you think it may make sense?
100%.
Okay.
That was the CAN device, which is basically fallen out of favor completely.
Yeah.
Not used anymore. For a longer sense, you go to cannula, something, go back into our eight, and put this, that's the disaster. A lot of the tubes start very quickly.
Okay,
Makes sense.
terrific. This was the first debate that was not on the program yet. So thank you, Omar. That was really amazing. Okay, I just wanted to, before we move on, not forget to thank our whole team that helped prepare this event. We had, as of last evening, 423 registration. I want to thank the CME team that's outside that has done a great job here, and Gabriella Blasetti, who's our manager, who put a great event together last night. I also really appreciate, our guest faculty. They could be anywhere, Dr. Mera was in Stockholm last week. I don't know where he's going to be next week. Dr. Netuka, they all travel globally, and for you to be here, I really want to say thank you from all of us. We know that. Let me just click this here. We know that this is really hard work, and I also want to say Dr. Silvestri arrived today. He's in the picture now. He's from Tucson, Arizona. They're not just really internationally renowned speakers, but they're also down to earth. Here last night, took a picture with their driver who was shown with his glasses. And we had a great event last night. Again, I want to thank everybody who showed up. And we're ready now, I think, to dive in to our next session. That will start with explosion of new devices in cardiogenic shock, and then we have the hotly awaited debate between Dr. Mera and Dr. Latif.
All right. Good morning, everyone. Thank you for the opportunity to present here today on a fascinating topic. My name is Louis Véro-Julien. I'm an interventional cardiologist here at the MonteHeart Medical Center. And as Dr. Jordi said, I'll be presenting on the next generation of mechanical circulatory support devices that are in the pipeline. Here are my disclosures. So first off, why is it important to have good devices? Well, cardiogenic shock patients are not going anywhere. In fact, it's quite the opposite. In the last, between 2004 and 2018, the incidence rate of cardiogenic shock patients increased by about fourfold. And this is true both for AMI cardiogenic shock patients and heart failure cardiogenic shock patients. The treatment of patients with AMI CS also changed quite a bit in terms of support. We mentioned the SHOCK 2 trial in 2011 after its publication. The use of IABP decreased drastically, almost to none. And this was counterbalanced by an increase in the use of other devices such as the Impella CP and VA ECMO. In the context of high-risk PCI, we observe a similar trend. IABP is still used from time to time, but clearly other mechanical circulatory support devices took over, and we're talking mainly about the Impella CP nowadays. And now, why do we use devices? Before danger shock, it was because we believed in it. Since danger shock, it's because we know it works. So danger shock showed a decrease in mortality at 6 months by about 13%. However, it was met by an increase in complication by about 18%. So 24% complication rate in the Impella device group. And what were those complications? We're not talking about benign complications. As Dr. Said said, it's major complications: severe bleeding, limb ischemia, hemolysis, the worsening of aortic regurgitation, things that we really want to avoid. So there is a need for better devices. That's pretty clear. So what would the ideal device look like? So keep in mind that the flow of a device is proportional to the RPM of the device times the square of the radius of the cannula. So we want more flow, we want more support. However, the RPM is limited by shear stress and blood compatibility, aka hemolysis. So the higher the RPM, the higher the risk of hemolysis. So we need an increase in the radius of the cannula. However, this would come at the expense of a large sheath, which would cause more bleeding events, which is something we also want to avoid. So the next generation of devices is really going to aim at a larger cannula with a smaller access sheath. So the first device that should be available in the next few years is the Impella ECP from Johnson & Johnson. It is introduced through a 9 French introducer sheath. And it expands to 21 French in the ventricle. The motor is external with the drive trained to the impeller, which is located in the left ventricle. It is delivered wirelessly, as you can see on the video on the right, into the left ventricle across the aortic valve, and the cannula is soft, and it opens only when the pump is flowing. In terms of support, it offers 2.7 to 3.8 liters per minute average flow at P9 level, which is the maximum level of the device, and it goes up to 5.5 liters per minute at peak flow in systole. It is currently indicated for up to 6 hours because it was studied for high-risk PCI patients in the pivotal studies, which included 256 patients, and it was presented at TCT 2024. They met their performance goal of 24.4% 30-day MACE rate. They actually had much lower MACE rate, 9.5%, which included death, stroke, MI, and target vessel revascularization. It's currently ongoing continued access protocol, and the FDA PMA has been submitted. The next device is the Vitalis device from Boston Scientific. There's a very limited technical data on this device, but it sounds like it's going to be a 14 French pump with a 6 to 7 French drive line for reduced indwelling footprint. The motor will be in aortic position using a novel magnetic drive. The purge line is eliminated from this device. There's also a double bend designed to improve the stability in the ventricle. And there's also a novel inflow and outflow design for reduced hemolysis. In terms of support, it's going to offer over 4 liters per minute at lower RPM than the Impella CP. The early feasibility study, including 15 patients, was presented at THT 2025, and they had pretty good outcomes, no stroke, hemolysis, or device-related complication, and they had 3 BARC3 bleeding events during the study period. The Supera device from Supera Medical is introduced through a 10 French introducer sheath, and the pump expands up to 22 French in the ventricle. And the impeller is in aortic position, and this device is delivered over an 018 wire into the left ventricle. It offers flow up to 5.5 liters per minute, and it has the advantage of a single platform designed to address both high-risk PCI and cardiogenic shock. We had the opportunity to participate in the early feasibility study here at Montefiore. This included high-risk PCI patients, 15 patients in total. The study was presented at SCAI 2025 in May. In total, we had 1 death, which occurred almost 1 month post-PCI and was completely unrelated to the device. And we had 2 BARC3 to 5 bleeding events. And there was no sustained hypotension requiring additional treatment during the study period. We will also have the opportunity here to participate in the Support 2 trial, which will be the pivotal study for Supera, and hopefully we'll get started in the next few months. The last device I want to discuss is the Elevate from Magenta, another very promising device. It is introduced through a 10 French commercial introducer sheath. The pump is self-expanding in the left ventricle, and it is unsheathed directly in the left ventricle. The cannula expands from 8 French to 30 French, which is why it has to be unsheathed in the left ventricle. The impeller is in ventricular position, and it is delivered over an 018 wire. It offers a good flow, 5.4 liters per minute of mean flow, at a maximum RPM of 21,000. As a comparison, the Impella 5.5, which we like for its low hemolysis rate, has a maximum RPM of 33,000. The early feasibility study, which was also presented this year at THT, included 18 patients undergoing high-risk PCI, and there was no hypotensive episode, no major device-related adverse events, no clinically meaningful hemolysis, and no death at 30 days. So this is a summary of all the devices that's going to hit the market. They all have their pros and cons, but they all aim at offering more support with a lower introducer sheath. In terms of size of the device, the Elevate will have the largest cannula at 30 French, and the smallest insertion sheath will be the Impella ECP at 9 French, just a little bit smaller than the Supera and the Elevate at 10 French. In conclusion, current devices, which is essentially the Impella CP, have limitations. They do reduce death at 6 months in AMI cardiogenic shock patients, but it comes at the expense of major complications like vascular complications, hemolysis. The new devices will aim at having expandable cannulas for increased flow at lower RPM and a smaller insertion sheath to lower the vascular complications. I think the future is bright for mechanical circulatory support, and it's going to be very exciting. Thank you.
Yeah, that was great. Any questions for Julien? Thank you so much. Also, last minute, you prepared this, and the field is going to change dramatically in the last 5 years. But we have shock patients today, and so the big debate right now is how should we carry the danger shock results into our clinical practice. So Azim Latif and Mandeep Mehra will take the respective positions.
Do you have the gloves, right?
No gloves. Of course, everybody has a plan. Mike Tyson.
So maybe we're going to start with a question. Is that right?
Yes.
Yeah. So let's start with a question. We'll do it at the beginning of the debate and at the end of the debate, just to see what people think, and we'll try and see if we actually can change their opinions in any way, Mandeep. Because I think in the end, even though debates are not about, in my opinion, being aggressive with each other, I took out all the pictures I had of you running around naked that I made with ChatGPT as a frustrated interventional cardiologist, because I think debates about us trying to understand how best to apply knowledge, right? Because every study has pros and cons. So here's the question. If you guys could answer, I'm going to give you another couple of minutes. Should danger shock, the results of danger shock change our clinical practice? Yes, it's time to act. Let's do it. Let's put impellers in all these patients. No, I'm not convinced, or unsure. Let's listen to the debate. And good, we have 25 people, so let's move on. How do I show the results here?
30. Let's go next.
Next. Okay. Yes, time to act. Okay. Start with this. No, stop voting. I like the 48%. Okay. So let's get started. So AMI-related cardiogenic shock, why we care? Well, I mean, for all of us here who look after patients who come in with acute MI, those who come in with cardiogenic shock still remain some of the most complex groups of patients we treat, where their mortality still remains extremely high. So it's estimated 1 in 10 patients who come in with a STEMI will have cardiogenic shock. And despite everything we've done, the mortality has not changed over the last 15 years. Essentially, half will not survive. And our goal when I see these patients in the cath lab is to try and restore perfusion as much as possible, get blood to their heart, decrease their ischemic time, and hopefully try to interrupt this entire very complex spiral of what happens in shock. And I have to admit, maybe it's a little bit of a simplistic approach. I open the artery and I try and get their blood pressure up, and that's really all I can do in the cath lab. I can't really change some of the biochemical processes that are happening at that time. So I do have this tool, which is an impeller. It's a temporary VAD that most of you know, a microaxial VAD that gives microaxial flow, up to 3.5, maybe sometimes up to 4 liters, depending on how you measure this. And clearly has beneficial effects on cardiac output, on mean arterial pressure, on unloading the left ventricle. And when you look at what the evidence has been for this group of patients with cardiogenic shock before 2024, it really is, since the shock trial, there's really been very, very little else. The shock trial, as you know, was the first trial to show, it's right on the left, that intervention, that actually opening up the artery decreases mortality. That's really been the only study we had. We then had culprit shock, which is more a strategy trial, which was really looking at, do you just treat the culprit versus do you do full revascularization? And treating the culprit was just as good as full revascularization. And then we had a couple of negative trials. We had negative trials for intra-aortic balloon pump. We had a negative trial for ECMO in cardiogenic shock. And that's where danger becomes exciting, because finally we potentially have a positive study. But it's important to know, when we look at clinical studies, the data and the results of those studies apply to the patients who were enrolled in the clinical study. They don't apply across the board. And I think in interventional cardiology, we're very good at doing that. We really do take, and I think it's across cardiology, trying to understand who are the patients that were enrolled, and those are the patients that are going to benefit. So again, those of us in the cath lab who are now using this to impact our practice, we're not putting in impellers on everybody. We're trying to figure out, are these the best patients? And so who was included in danger shock? There were patients with STEMIs who required urgent PCI. The ejection fractions had to be less than 45%, either on a ventriculogram or an echo done in the lab or in the ICU, in the ED. They had to have evidence of hypotension, hypoperfusion, so sky shock stages C, D, and E. Most of the patients were C and D. They had to have a blood pressure was below 100 or need vasopressor support. And importantly, they also had to have their lactate up. So they had to have already evidence of hypoperfusion. Patient randomization happened when the shock was diagnosed. Majority of the patients were randomized actually before they got their PCI. There were some were randomized after. Major exclusion criteria, and I think the first one is probably the most important, that shows maybe why this study outcomes were a little different to some of the other studies. So patients who were out of hospital cardiac arrest and were still comatose were excluded. If your Glasgow Coma scale was less than 8 after cardiac arrest, you got excluded. And I think that drove a lot of why there was positive outcomes. And I think we heard earlier from one of our colleagues, probably one of the most important predictors of patients who do well is having RV, or do poorly, sorry, is RV dysfunction. So patients with overt RV failure, biventricular shock were excluded, and obviously patients with mechanical complications. You saw the slides, you'll see them multiple times today, but essentially this is the primary endpoint published in New England Journal of Medicine, looking at death from any cause at 6 months. And the mortality in the impeller group was 45.8% versus 58.5%, with 26% reduction in all-cause mortality. That's the numbers needed to treat of 8. That number needed to treat actually becomes 5 when you take only younger patients in, but also an absolute risk reduction of 13%, right? That's pretty dramatic. When you look at what the cause of death was, in the conservative arm, so in the control arm, majority of the death was actually cardiac in nature. So when patients died, they died from a cardiac cause, 71%, versus half the patients who died from a cardiac cause in the impeller group. So they died from different reasons as well. The composite cardiac endpoint also favored impeller, and there was benefit consistent across most of the pre-specified age groups. There's some discussion about geographical differences, which I'm sure we'll talk about, and Mandeep will mention, and as well as maybe patients who are older than 80 don't benefit as much. So it's definitely effective, but it did come at a price. And the price was, as we've seen in every study with large bore devices, in this complex group of patients, there's a price to pay. The price is bleeding, the price is limb ischemia, and here there was also a price to pay around renal replacement therapy. So these devices do come at a price. And because they come at a price, does that mean we shouldn't use them? I would argue not. I think it emphasizes that we need to be better at using them. One of the things you can't find in the paper is how were these devices actually placed? Do they use modern techniques? In my lab, we now use ultrasound guided access in 100% of our patients. We use distal perfusion catheters. No patient leaves the room without a check. Do they have perfusion of their leg? And if they don't, they'll get a distal perfusion catheter done by us in the cath lab, not 6 hours later when their legs are ischemic in the ICU, right? So I think there are many really important things that you can do to improve outcomes. The use of vascular closure devices is another. This has really impacted bleeding in our patients. And I think what's really going to be important are new PVADs. So there are a lot of counterpoints and objections to the data from danger shock. The bleeding and limb ischemia is too high. And I agree, absolutely. Those kind of outcomes are not acceptable nowadays, and they're not acceptable in my lab, where we want better outcomes. And I think you can have better outcomes. Better outcomes comes from better use of ultrasound guided access, better use of distal perfusion catheters, use of closure devices, and important experience, right? So sites who are not using these pumps on a regular basis have more complications and they have worse outcomes. So expert centers and expert shock centers have better outcomes. Was the trial too selective? Is Impella maybe too costly? I think for each of these, I can find a counter argument. ECMO, IABP may be safer. Well, show me the data, I would say, because really there hasn't been any data, randomized data, to show that we do have better outcomes. As regards to the bleeding, I really think this can be impacted by technique. It's interesting when you look at the bleeding, when it occurred in these patients, a lot of the bleeding occurred late, not in the cath lab. 50% of the bleeding occurred after removal of the circulatory support. Again, just highlighting, we're doing one thing, putting in a pump in to raise a patient's blood pressure and improve perfusion. These are sick patients who often go into multi-organ failure and are at risk for multiple complications. Because of the data, there is now a class 2A indication in the guidelines because of Deja shock. But as you'll see, it's very specific, right? It doesn't say we should use Impella in every patient with acute MI and cardiogenic shock. It's very specific about in selected patients with STEMI who have severe or refractory cardiogenic shock. Insertion of a microaxial pump is reasonable to reduce death. So there is now a 2A guideline indication. But I do want to highlight something, is that when we think about applying this, the number of patients who actually this study applies to is actually pretty small. So this is an interesting analysis done out of the shock working group that looked at 9,000 patients with shock. 12% had STEMI cardiogenic shock. Of those, close to 1,200 patients, of those, only 98 patients met all the criteria to be included in danger shock. So when you look at how many patients this actually applies to, we're talking about probably 8% of STEMI cardiogenic shock patients, probably only 1% of patients who present to a hospital in cardiogenic shock. So it's really a small group of patients, but it's somewhere to start. Well, where do we need to go from here? I'm the first, and I am one of the first to talk to about, I think we need better devices. I think there's really a issue with the current devices. So I remember I've been very involved in developing one of the devices, which I'm going to show you as part of my declaration of conflicts of interest. But I remember sitting at TCT Denver in 2017 with a couple of engineers, and we sat down and they said to me, Azim, what's missing for you in Impella? And I said, well, there's a lot of things missing, but I want a 10 French device or less. I want a pump that can give me over 5.5 liters, or over 5 liters, so that I don't have to have Impella 5.5s anymore, and I can place them percutaneously. I want minimal hemolysis, and I want sensors to tell me both the ventricular pressure and the aortic pressure, because an Impella only tells me aortic pressures, but I think to really manage a cardiogenic shock patient, knowing what their EDP is super important as well, and will help me win those patients. And part of why I wanted that was because when you look at the data for Impella across the board, but not just Impella, you look at the data for, as someone mentioned, as well for balloon pumps and ECMO, and you could argue there's a huge selection bias in this data because the sicker patients got the pumps or got support. There continues to be an increase and a very high rate of vascular complications that's not coming down with time, right? And that's where really, I got involved with Superior. These engineers designed the device I asked for, and we've been working on this for the last 8 years. We have just finished our early feasibility study, and we're now doing a randomized study against Impella to get FDA approval, and at the same time, hopefully doing some cardiogenic shock work to really understand long duration with this. So the first study we'll do will be high-risk PCI, just because that's the easiest way really to get FDA approval for a new device. But I wanted to show those of you who don't understand when we talk about large bore, what 10 French means, all right? So if you look at those 3 little circles in the bottom left, the 23 French, that's what a 5.5 is. That's the size, that's the diameter of it. Next to it is the 14 French Impella CP, and next to it is 10 French. So you see what a big difference that makes in being able to decrease the size of the hole that we put into patients and that arteriotomy. So the Superior device, which I'm very conflicted with and I'm being open about, will give us 5.5 liters. And one of the other things I really like about it is we've put two sensors on. So we have direct sensors of both aortic and LV pressures. So imagine how you can now use AI in the future to help wean patients off the impeller, because you can immediately see what's happening to not just the aortic pressures, but also the LV EDP. So how do I put the danger shock into clinical practice? This is sort of the algorithm that many of us are now using post-danger shock, which I hope most of you will agree with. If the patient has a mechanical complication, I call Danny and beg him to do something. If he, and hopefully most times he will. If the patient's comatose with out of hospital cardiac arrest, I also then I'm going to, probably not going to do anything. But if not, if they don't have out of hospital cardiac arrest and the GCS is high, if they have a low cardiac output, a low blood pressure, and the lactate's up, that's the kind of patient I'm thinking about mechanical support. And then my question is, do they have RV failure? Yes, they need ECMO then. If they don't, that's where I'm going to be thinking of putting an impeller 5.5 in STEMI. If they do have an out-of-hospital cardiac arrest, I may still consider revascularizing them. And then I'm going to use vasopressors, inotropes, and optimize their fluid status to try and help them improve. If they do improve, great. If they don't, and the patient shows signs of neurological recovery, then maybe I will again consider whether I'm going to use a pump in them. So I'm going to stop here with my take-home messages. I think danger shock is important for us because really it's the first randomized trial to show a survival signal for using mechanical circulatory support in STEMI cardiogenic shock. I think the benefit, though, needs to be weighed against significant bleeding and renal complications. I think a lot of the bleeding and ischemia complications are manageable with patient selection, modern techniques of ultrasound-guided access, vascular closure devices, excellent peri-procedural care, and they don't erase the mortality benefit. Part of my concern is that those kind of outcomes are only reproducible in centers with expertise and with high volume, because the center who doesn't do this regularly is going to have a higher rate of complications. I think device innovation is on the way, and I can't wait to be able to have better devices. And lastly, an important point, I think, in interventional cardiology and cardiology in general is the concern that a device may cause a complication shouldn't be the main reason for denying a patient a life-saving therapy, because that's often what we say, oh, this device can cause complications, and so we shouldn't use it. If it's used well, we can save lives, and that's what we should be doing. Thank you.
Thank you so much. First of all, Azim, that was great. I think that rather than choose to debate, you have chosen to really reflect on the trials in a very scholarly manner. And so I think we won't be very far apart in what we say, because it seemed to me that you are not currently changing your practice. Your practice is still the same that it was before, and your team's practice appears to be the same. So let's reflect on that for a moment. Now, the real point that I'd like to make in the next 10 minutes or so is that we must be careful when we're looking at a clinical trial. After about 20 years, we had a positive trial in cardiogenic shock. The problem with trials like this are that we latch on to a trial that's positive, and then we choose to extrapolate from that trial because we have nothing else. And we somehow convince ourselves that we can't do other trials and that we can't reproduce these trials. We have to choose what we know from these trials to really create clinical practice. And so the real danger of danger shock lies in the extrapolation from danger shock into other subsets, and a change in practice that is not currently supported. So I'd like to focus on that for a moment. I also want to point out that a clinical trial is not an oracle. A clinical trial is not something that veers towards absolute truth. A clinical trial is really a mirror. And a mirror should be one where you stand in front of it and reflect and think through how to use the evidence that is generated from the clinical trial. So of course, danger shock has some very, very unique trial nuances, and many of them have already been expressed by you, Azim. And I will try to express a few others from this trial that should cause important erudite self-reflection. We saw that the number needed to treat to save one life was about 8. It's outstanding. It's an excellent number needed to treat for saving a life. This is not just for the primary endpoint. But we also heard that the trial was fragile. What does that mean? What's fragile? What's the fragility index? The classic heart failure trial has a fragility index somewhere between 8 to around 20. Our trials in the LVAD space have been much luckier. Our fragility indices have been well in the 20s and very, very high, and so more convincing. If you look at the fragility index of danger shock, fragility index is defined as the number of events that would need to change from one group to another to render the trial null and statistically invalid. And so in this case, the fragility index was somewhere between 3 to 4 for the danger shock trial. There was a very unique element in this trial that occurred. In fact, the trial itself showed the evidence of fragility. There is a analysis in the trial where you can not only look at the intent to treat arm of the trial, which is how the primary results were presented, but if you look very carefully, the as treated trial analysis was also presented within the framework of this trial. What does that mean? What the as treated trial analysis is to only take those patients who actually were targeted for the intervention versus control. And so it turns out that 9 cases in the microaxial flow pump group, 9 cases actually never received the impeller device. And 3 cases in the control group actually received the impeller device. So if you remove these patients from the clinical trial, the statistics actually turn null in the trial, which reflects and proves the fragility of the trial almost instantly. And this is a very, very awkward situation because an as-treated analysis for a device trial should almost always show you a stronger difference, not a weaker difference. And so this is a very important trial distinction that is worth reflecting upon. Now, the next issue that I want to point out is that there was a very interesting geographic difference in the trial. So if you look at this trial started in 2013 and the trial basically ended in 2023. So the trial took 10 years. Midway into the trial started in the Danish population. That's why it was originally Danish shock. And then it moved to Germany and the UK. That's how it became Danger, which is Danish and Germany. And that change occurred in about 2018. So midway into the trial. Now, from 2013 to 2023, there were so many changes that have occurred, both in intervention. So people have gotten smarter with large bore access, I think. Azim, you would agree with that. People have changed so many things in the way in which management of patients. Some shock teams have been introduced, as Omar suggested. PA catheters are used much more liberally in cardiogenic shock now. The LVAD world has changed significantly from 2018 to 2023, where we have a device that has been shown by people in this room, like Uli, that even in critical cardiogenic shock, if you transition patients to a HeartMate 3 pump, the mortality difference is preserved in a very, very reasonable manner. So let's just reflect on that geographic difference and whether there is evidence from the clinical trial that time and era make a difference. So now this is straight from the manuscript and it doesn't reflect here properly. I'm not sure why, perhaps because I use a Macintosh. But this is actually from the supplementary file of the paper. Now you can't read this, and neither can I. But I will just point this out for you, and just believe me, I'm not lying about these numbers. So If you look at the hazard ratio, most of the benefit was seen only in Denmark. And in fact, when you look at the population enrolled from Germany and the UK, there was no difference whatsoever. In fact, the confidence intervals, which you can't read, range from 0.53 to 1.42. What that means is that there is as much of a chance that there was a 47% improvement or a 42% worsening in Germany and the UK. What that means is it's a classic representation of an absolute null effect. And why did that happen? What is so strange about this data is the following. If you look at those numbers, and were they in fact readable, and if I had been smart enough to put in a proper slide, you would have noticed that the improvement in the Impella arm in Denmark, the mortality at 6 months was 48%. Look at the control group standard of care mortality in Germany. It was 48%. There is absolutely no difference between, if you were actually doing the statistics between Denmark and Germany, you would find no difference whatsoever in this trial. So it turns out that there is something about either geography or there's something about the era effect that has to be kept in mind as you reflect on what this trial has actually shown us. And what is unique is that there was, of course, also a significant difference in the number of LVADs that were used in this open label trial. So in the control group, there were only 4 LVADs, and in the microaxial flow pump group, there were 10. Now, why have I numbered them for you? If you look at the difference in LVADs, is 6. A trial that has a fragility index of 3 to 6, if there is a difference in a durable technology that has a 90% survival at 6 months, you can imagine that simply the use of that technology could have accounted for the difference. Now, one could argue that maybe the use of the Impella pump helps you transition to a durable LVAD. But I point out that this trial is an extremely interesting trial, and that as you think about dissecting this trial, you have to look into these details very, very carefully. And I am mostly guided by the fact that in the most current era, the control group mortality in Germany and the UK is identical to the benefit observed from Denmark from 2013 to 2023. Okay, so what this means is that there are some patients who, despite meeting the danger shock trial, do not benefit. So who are these patients? What were the differences in the patients enrolled from Germany, and what were the differences in the patients from Denmark? Turns out the patients from Germany had a much higher ejection fraction, so they were 30 compared to 20. Turns out that the systolic blood pressure was 80 in Denmark and 90 in Germany and UK. The lactate was much lower in Germany and the UK, of less than 4. And so these differences might not only have accounted for the lower mortality in the control group, but may give us insight into how we should be thinking about which patients should actually receive this therapy and who should not. The second point is that the approach to care across different payer systems and across different countries is different. And so one has to think through that in a much more scholarly manner as to whether our practice in the United States is more like Denmark or more like Germany, or maybe none of the two. And maybe it might be completely different than anywhere else. Okay. Now, we've talked a bit about the fact that the number needed to treat for complications in this trial was actually 6, meaning that the number needed to benefit is much larger than the number needed to harm in this trial. Now, naturally, the benefit is on mortality, so those are not equivalent, but you do have increased severe complications with this, and I want to make some points about this in some greater detail. So if if in any therapy the harm appears to be substantial, the question that you have to ask is whether we should avoid those that may not benefit. That's the key. So are we good enough in looking at this data and reflecting on the fact that there is a subgroup of patients who do not benefit, whether they're from Germany or what those characteristics are? Can we cull that information out from this trial? Who are these patients? So the greatest conversation has been about the out-of-hospital cardiogenic shock patients, the comatose patients. And Omar, you made this point very well, that these might be different patients, that they're not really cardiogenic shock patients. They're patients who resemble and mimic cardiogenic shock simply because they present with very high lactates. And their prognosis is much, much better than classical shock. So if you actually look at clinical trials, these patients have a better prognosis than traditional cardiogenic shock patients. Their lactate rise is not reflective of the microcirculatory stress that is experienced in cardiogenic shock. It is actually from hypoxic stress during the arrest. And so their lactates actually clear very, very rapidly. Their initial ejection fraction may be because of the cardiac arrest related to stunning, and recovery is much more possible in these patients. And alternatively, if you have grossly neurologically compromised arrest patients, these are unlikely to recover. So you actually have two groups of patients in this. And we as a team need to understand that and be able to reflect on that carefully. So what's the point? The point is that is there a subgroup of patients enrolled in the trial with a prognostic advantage? How do we figure that out? Who are these patients? And is the trial representative? I'm not going to spend too much time on this because Azim, you already mentioned the fact that the screen to randomization ratio was about 30%. That means this represents only about 30% of screened patients with cardiogenic shock. Most of the people excluded were comatose with out-of-hospital cardiac arrest. And perhaps the most important argument against generalization of this invasive therapy to all patients is right here, and I'll show you this. The Intershock folks published a secondary analysis. Now, this secondary analysis was purportedly to show that the vasoactive inotropic score and lactate clearance is a little bit better with the Impella pump. And this shows that on this slide. So that was the primary intent of this JAMA Cardiology secondary analysis. But what's hidden in this paper is something very, very remarkable. And what's hidden in this paper is this, that there were 30% of individuals in the standard care group who were stabilized and discharged from the ICU within 72 hours. Uli, you'll remember that I asked this question of Christian Hassiger, the senior author of the paper. And this was almost twice the number of patients in the microaxial flow pump group. These patients in the control group, these 30% of patients, had a 30-day mortality of 4%. Now imagine if you did not know who these patients were and simply used the danger shock trial results and put in a device that has a 5-fold increased risk of limb ischemia, a 4-fold increased risk of renal replacement therapy, a bleeding risk that is 3-fold higher, a 2.5-fold higher risk of stroke. What are you actually doing for these patients? Is that the right thing to do? I would say no. Now, of course, we know very well that the selection criteria was so strict in this trial that they should not be extrapolated to shock states from other phenotypes, particularly heart failure shock. And I worry that in the general community, that the results are being extrapolated beyond STEMI. And we need to be very careful, not at Monte, not at the Brigham, but in the general community. And I just want to make a plea that cardiogenic shock from heart failure is a very different process. It's a backward process. Cardiogenic shock in heart failure begins from congestion leading to shock. It's a much more chronic process, whereas STEMI shock is a primary LV failure shock without initial congestion. And these are two completely separate phenotypes who may have completely different results when you actually implant a microaxial flow pump device. Okay, then I'm just finishing this up very quickly, and now I'll just turn this over to you. You've heard what I've said to you, and so now I'd like to discuss the facts for sense making in a scientific situation with you. A difficult study gets done. This is excellent. It's laudatory. Agreed. But it takes over 10 years, two distinctly different eras, distinct geographic regions with different outcomes. The study barely meets significance. Okay. The number needed to treat is 8. The number needed to treat to harm is 6. The fragility is about 3 to 4. If the actual allocation is tested, the significance goes away. If the significance disappears, a patient is managed in a different, when a patient is managed in a different resource available location, like Germany or the UK. Okay, that's a challenge. The study enrolls a population that is not representative of most patients that you see. 5% of the patients that you see with cardiogenic shock will actually qualify for danger shock, according to most of the clinical criteria. Okay. And so if it doesn't represent 95% of your contemporary cohort, what practice change are we talking about at this time point? Let's further test your sense making a bit. How many of you would conclude that the intervention tested in this study should be applied to all patients with the disease of interest? How can that be? Let's further test this. A 50% residual risk of death at 6 months is no laughing matter. I agree with that. That should not be the reason to change your practice. Standardized use of shock teams with advanced heart failure as a core team member, reflecting on the durable opportunity for transition, is important. Hemodynamic monitoring is useful in determining futility, lack of need, or to facilitate protocolized escalation and de-escalation of therapy. Alternatively, if you agree with Azim and you agree with the danger shock result, well, just stop your shock team at Monte. Why? Just use the inclusion and exclusion criteria of danger shock. What's the reason for a discussion? You can actually abandon this approach, simply apply these criteria and sleep when on call. Why do you want to be woken up in the middle of the night? Okay. So I'm just going to end here and just point out that we are not very much different than similar. We are mostly similar in our approach. My only point is that at centers like Brigham, at centers like Monte, we were already doing this. We were already engaging in scholarly debate in the middle of the night, deciding what best to do for our patients. I don't think that the danger shock trial has provided any incremental evidence whatsoever in that, other than providing us reassurance that the directionality of what we were doing is appropriate. And I would say that it is incumbent on the shock teams and our group to ensure that we do not apply therapy that could be harmful in those patients who do not need the therapy. And we still do not have enough information from the danger shock trial to extrapolate that, except by virtue of some data. Now, much of what I've said is actually in this paper in JACC Heart Failure, which is online at this current time point. You'll notice the first author is actually from your group. It's Francesco Castegna, who happened to somehow have a year of expenditure of time with me. We wrote this together, hopefully you'll enjoy reading this paper, because all of what I've said is fully encapsulated in this and appears to be a Monte author as a perspective. So I hope you enjoy that. Thanks so much for yours.
Yeah, Mandeep, Azim, that was great. I probably listened to maybe 7 or 8 debates on danger shock, and this is by wide margin the best, and really fulfilled the purpose of everybody in the room and on the Zoom really understanding this trial, rather than fighting over what to do. You really shone a light on it, and I think there are no questions that are unanswered here, unless somebody has a question. I don't think so. I think what we really agree on is 2 things. We need better devices, but at this moment we don't have them. So what we have to do is use the device in the right patient and then don't stop in the cath lab, but have and Omar already talked about this, and then have better management of the device, better insertion, better management, and then better outcomes. And so on that note, I've invited Danny Sims, who is the director of our CCU, and regardless of what you guys end up, actually we have to do the question first, I think. Regardless of what the debate ends up, he's going to be running the CCU and supervising all of us, and then he has to deal with it anyway, whether you decide to use it or not. So let's just do another audience poll here to see. At the beginning, it was, you know, eerily reflective of the United States election with like 1 percentage point different. And, you know, participation in elections is very important. So please vote. Please rehearse for the next election. Let's see if where we are now. I have to say, maybe I'm more uncertain than before. I know we have to do good clinical care, that's for sure. And we hit our target 24. We need an uneven number, 26. Okay. Not yet convincing. Okay, very good. Danny, you still have to manage the patients in the ICU, so thanks for giving the next talk. Just like this. Is that yours? No.
Okay, good morning, everybody. Uli, thanks for inviting me to speak. So talk about Impella after the cath lab, although really could be for any mechanical circulatory support device for the first 48 hours or so. Disclosure, I'm a New York Mets fan who works here in the Bronx. That is important to disclose. I'm partial to Star Wars. Otherwise, there's really none for the purposes of this talk. So before the patient gets up to us in the cardiac intensive care unit, while they're still down in the cath lab, before the Impella goes in, you need to realize when the Impella needs to go in. And this is data from Babar Basir out at Henry Ford in Detroit. And he looked at a group of patients, every single one of them got an Impella pump. And you can see what vasoactive support they were on, how many ionotropes, when the Impella went in. And so you don't want to implant the Impella when there's 2, 3, or even 4 ionotropes already going, because their mortality is so much worse. You want to implant the Impella earlier on. So for these cardiogenic shock patients, you want to maintain perfusion, and that's systemic perfusion first, followed by coronary perfusion. You want to prevent or reverse end organ dysfunction. You know, in trauma, we talk about the golden hour that you have to take care of the patient. In septic shock, we talk about early goal-directed therapy. And in cardiogenic shock, I like to talk about early hemodynamic goal-directed therapy, where you raise the cardiac output, raise the MAP or the cardiac power output if you want to combine the two, to get adequate urine output, to improve mental status, and to lower the lactate. So this is our friend, the pulmonary artery catheter, and I mean that. It is our friend. It is not our enemy. It is not bad. You know, the PAC over the last many years has become a 4-letter word, although it's really only 3 letters. So why did it become a 4-letter word? Well, it goes back 20 years now to the ESCAPE trial, which randomized patients with acutely decompensated heart failure to treatment guided by expert clinical assessment or clinical assessment with a PA catheter. And what you can see here, even if you don't have a background in statistics, is that for the primary outcome, days alive outside the hospital at 180 days, no difference whatsoever. And in fact, the PA catheter group had a few more complications, a few more line infections, and a few more ICD shocks. So the take-home became from this trial, PA catheters are bad, they don't save lives, they kill people, you should never use them. And I put it to you, that's not the take-home from this trial. So what should the take-home from the trial be? Well, first you have to look at the exclusion criteria. Who wasn't in the study? Anyone who had ever been on dobutamine or dopamine at a dose of greater than 3. Any prior use of milrinone during that hospitalization. If the creatinine was greater than 3.5. Any patients where the PA catheter was thought to be required for heart failure management. Remember, these were clinical experts in heart failure management who said, I can't take care of the patient unless I have a PA catheter. Oh, and by the way, there were no shock patients in this study. So what do we know at this point in time or that point in time? PA catheters don't save lives in the average acute decompensated heart failure patient in the ESCAPE trial. And that's not what we're talking about. We're talking about shock here. PA catheters are critical in post-MI shock. because you want to know what is the problem causing the hypotension and specifically the hypoperfusion. Is it pump failure? Is it a mechanical complication like a VSD or MR or RV failure, very importantly? Do they actually have hypovolumia because they're having a retroperitoneal bleed? Remember, these are emergency procedures. Complications happen, never in our cath lab, but high sticks happen and patients can have an RP bleed. Is it vasodilation from SIRS? PA catheters are also critical in other etiologies of cardiogenic shock, so you can give the lowest dose necessary of vasoactive medications. We have some of our fellows sitting in the audience, and if this was 10 years ago, I would give this talk to them and say, hey, you just got to take my word for this. We are, you need a PA catheter to take care of the patient, the shock patient. But now we actually have data that supports this. So let's go over some of this data, which I think is pretty good. So this is data from Joanne Lindenfield's group at Vanderbilt, looking at the national inpatient sample. And what you see here is that starting in 2004, 2005, when the ESCAPE data was coming out, there's a marked decline in the use of PA catheters in cardiogenic shock, as well as in heart failure. But the mortality for cardiogenic shock back then was going down. Great. But then it leveled off in 2008, 2009. And in fact, for the group that with cardiogenic shock that did not have a PA catheter, their survival actually worsened, mortality increased. While the group that did have the PA catheter, the survival continued to improve a little bit. So a purely diagnostic tool actually was helping in this era now of temporary mechanical circulatory support to help with mortality. So other data. This is from Bill O'Neill, again at Henry Ford. He presented this at ACC many years ago. It's since been published, but I just like the way that this slide shows the graphic better, so I like to still show it. So he looked at two registries. These are the IQ database, the CVAD registry. Every single patient got an Impella. So IQ database, 14,000 patients. And the group that didn't have a PA catheter, 49% survival versus 63% in the group that got the PA catheter. Again, everybody had the Impella. CVAD registry, similarly, 1,100 patients, 8% improvement in survival if you had the PA catheter in to help you manage the patient and know what's going on with them while the Impella is in place. We heard a little bit about SCAI staging already, A, B, C, D, E, so I won't belabor that. This is data here on the right from my colleague and friend, Rashad Garan, who's the director of transplant at BI in Boston. And he looked at the cardiogenic shock working group patients who had cardiogenic shock and had a PA catheter in place or didn't have a PA catheter, which is the blue group over here. And so what you see is that we have a red group where they had incomplete assessment of hemodynamics. So some of the numbers were looked at from the PA catheter, and then this black group over here where they had a complete assessment of the hemodynamic state. And what you can see is that for all comers with shock, if you had a complete assessment, there was less mortality. For some reason, I see that the mouse isn't pointing up there. Okay, but in the middle over here, the SCAI stage D, as well as the SCAI stage E, you get decreasing mortality as you go from no hemodynamic data to just some of the hemodynamic data to complete hemodynamic assessment. Similar data from Critical Care Cardiology Trial Network, the C3TN. This is a group of academic CCUs across the United States and Canada, and they looked at all their patients who had cardiogenic shock and said, well, who got a pulmonary catheter, who didn't? And what you see here is that there's an odds ratio of 0.79, so 21% improvement in survival by having a PA catheter. So a moment again about SCAI staging. So data from Jake Genser at the Mayo Clinic, you see as you go from stage A to stage E, huge increase in mortality. And then when you add on the red bars, which is the cardiac arrest, you get an even bigger increase in mortality. So we talk about cardiac arrest being a risk factor. I like to call it a risk multiplier because it's so substantial, particularly in the early stages, that these patients are dying from that brain injury in addition to the cardiogenic shock. So we know at the time of admission that the SCAI staging is important, but this is more recent data from Van Quay Khan, again, looking at the cardiogenic shock working group data, and she looks at this over 3 days. So what you can see here is that in the first 24 hours, there's a lot of changing of the sky staging. And she calls these patients the sky walker, as they walk from stage B to stage C, or stage C to stage D, which is where most of the patients were changing. Fortunately, there were some patients going from stage E extremis to stage D or B, but not so many. And most of it was happening in the first 24 hours. So maybe this was that time period when you need to make a change and do something to save a life. They drilled down on this even more and looking at this question again with the PA catheters. And so looking at the cardiogenic shock working group data, what you see is for the patients who got PA catheters, the earlier the better. So if you put the PA catheter in within the first 6 hours, that's when you made the most dramatic effect in the management of the patient and in their survival. So early hemodynamic goal-directed therapy. All right, so medicine is frequently compared to the airline industry, right? So I like to talk about the PA catheter being the control panel for flying the plane. So if you have no PA catheter, well, you're relying on just a few of the gauges over here, a few of the controls. And so it's more like a World War I era aircraft. And my son, Jack, a few years ago at the Cradle of Aviation Museum of Long Island, okay, he's able to fly that plane. But when you have a PA catheter, now you've got all of these readouts, you've got all of these gauges, all of these controls. So you really can know what's going on. And so this is really what's necessary to take care of these patients. Unless, of course, you're this man, Luke Skywalker, who he is so good, he can just use the force and doesn't need all those gauges or controls to take care of the patient. Skip this slide in the interest of time. But how are we doing now that we know about the importance of cardiogenic shock management and pulmonary catheters? So again, data from the C3TN, and so acute MI cardiogenic shock. So only 30% of patients down here in that first column had a pulmonary artery catheter, and that's despite 61% of patients having a mechanical circulatory support device. So we're not doing that great. And when you look at the heart failure cardiogenic shock and the mixed shock patients, again, only 31 to 36% or 38% of the patients had a PA catheter. So we could do a lot better. So that's the PA catheter that hopefully they're going to come up from the cath lab with. But you got to move the patients with the Impella in. You got to get them from the cath lab to the CCU. You got to get them from your spoke hospital to the hub. And you got to get that Impella console going with the patient, okay? As we all know who have taken care of these patients, these Impellas move. So you got to be able to know where it's going and know where it is. So just very briefly about the different parts of the Impella. There's an inlet right over here, underneath the, again, that first red line there, which the mouse was showing. And then there's an outlet that will sit, by the motor. So with Impella positioning, the chest X-ray is not so useful. We rely on fluoroscopy, we rely on echocardiography. We also rely on the Smart Assist of the Impella console. So the Impella inlet should be about 3.5 centimeters below the aortic valve. For the Impella, that's for the CP. For the Impella 5.5, about 5 centimeters. And the outlet should be above the aortic valve. And color flow can be helpful to actually know just where it is. So you can see on the left, the outlet is above the aortic valve. So all of the confetti-like turbulence flow is above the valve. But when the Impella is in too far, now that turbulent flow is also under the valve in the LV. And so you're just ejecting blood into the LV and not completely into the aorta. So this is a patient that you can see already has a PA catheter in. They're in shock. There's a huge thrombus in the LAD. The Impella is going in under fluoroscopic guidance. But it turns out the Impella is in too far. It's in 5.5 centimeters. And again, you're seeing that confetti flow involving also the aortic valve. So you need to reposition the Impella. This is another patient where the Impella is in too far. It's sort of caught up in the mitral apparatus, the papillary muscle. And here's a sort of a cartoon that shows that also. So you want to make sure you have everything positioned correctly because ideally, you want the patient ambulatory. You don't want the complications from having them in bed, bed sores, losing their physical performance status. This is a patient who got an Impella 5.5 rehabbed quite well and was up within a day or two and walking the hallway, waiting for his transplant. So the Smart Assist console. So this is where what you want to see on the left there, you see an LV tracing, and in the red, you see the aortic tracing. Then when it's not in far enough in the middle, they both become an aortic tracing. When it's in too deep, again, you see that it's an LV tracing on both of them. So there's sensors that allow the Impella to figure out to some extent how far in it is, or is it in not in far enough. Okay, so there's other metrics that you want to pay attention to. The motor current, the purge pressure, the purge flow, those are found on the console. You want to look at your LDH, it's still very important, as well as the color of the urine. You want to be able to understand, you know, is the patient having a thrombus? Is there hemolysis going on? And speaking of hemolysis, this is what you don't want to see. You don't want to see urine that looks like this. It's all Coca-Cola color, very, very dark. This patient had their Impella, it was in too deep in the pap muscle. So it was repositioned under fluoroscopy and echo. And now you still see that there's some of that dark urine that was left when we emptied the Foley bag, but now the urine's clearing. It's not hemolyzing nearly as much. And when you look higher up on the Foley, you see that the urine's clear now. So the positioning is very important for hemolysis. It's not just shove it in across the valve any old way. You have to really get it positioned right. And if it's not, they need to go back down to the lab with fluoro and echo to get it that way. We talked a lot about already the adverse events. Again, the bleeding, the limb ischemia, the need for dialysis. But an Impella patient in shock is a patient who's in the cardiac intensive care unit. And what's very important is to prevent complications in the cardiac intensive care unit. So this is an AHA scientific statement we wrote 5 years ago now. And what you can see here is from this area on the right is some of the areas that we really wanted people to focus on: preventing infections, healthcare associated infections, using bundles, that you treat the patient's pain, that you manage the ventilator appropriately, adjusting the tidal volume, adjusting the PEEP depending on the hemodynamics and the comorbidities, that you use non-invasive positive pressure ventilation to help and decrease the need for mechanical intubation, that you get the patient up, you mobilize them, that you feed the patient, use stress ulcer prophylaxis when important, when appropriate. Medications, you want to manage the drug-drug interactions. You want to take into account the renal function. You want to take into account the hepatic function. I see our pharmacist, Daryl, sitting there, who plays a huge part on our multidisciplinary team helping out with this. You want to look at these devices and when can we get these devices out? Don't leave them in for any longer than you need them. And again, it needs to be multidisciplinary with pharmacy, with your surgeons, with your shock team, with your palliative care team. Now, you need to take into account what's the ultimate destination for the patient. Is the patient going to be someone that you can recover? Is the patient going to be someone who needs to get a transplant or an intermediate or durable mechanical circulatory support device? Or is the patient heading for palliation? So you need to figure out, to try to recover them and do all these things, who are the patients who you hold tight? Who are the patients where we need to escalate therapy? And who are the patients who are ready for de-escalation? So again, this is an AHA scientific statement where we attempted to address this issue 3 years ago. And we decided that you need to look at a lot of different things. There's a lot of different data points that you need to integrate. You had to look at your non-invasive monitoring. You had to look at your echocardiography. You had to look at your Impella console. You wanted to still do a physical examination, look at the limbs, look at the ventilator, look and see what the laboratories were, particularly the lactate, and then look at the Foley, look at the urine output. What's the color of the urine? And obviously you want to look at your invasive hemodynamic metrics to know how the patient is doing, how the RV is doing. So who is looking at this? Who is making these decisions? Well, we want to make sure you involve the shock team. So this is data from the C3TN, and the shock team was made up of critical care cardiology. It was made up of heart failure cardiology, interventional cardiology, CT surgery, and depending on the institution, how they incorporated ECMO into the team. And what you see is that in the hospitals, the CCUs that had a shock team, there was more use of pulmonary artery catheters, but actually less use of mechanical circulatory support devices. But when they were used, there was more of the advanced MCS devices, Impella, Tandem Heart, VA ECMO. And this led to a decrease in mortality in the groups that had a shock team. So the MonteHeart shock team is led by the attending in the cardiac intensive care unit. And here at MonteHeart, 365 days a year, that attending is a heart failure trained cardiologist. Okay, and we're talking with these patients in real time, with our interventional colleagues, with our surgical colleagues about how best to take care of these patients. And this is our data here. So about 11 years ago, we transitioned from an open unit, any attending taking care of a patient, to a closed unit run by a heart failure cardiologist. We had 2,900 patients. 12% of the patients were admitted with cardiogenic shock. In both eras that we looked at, we were a balloon pump centric unit. So about 85 to 91% of the patients who got an MCS device got a balloon pump. So it wasn't like we were suddenly using higher powered pumps. And what did we find when we looked at our data? We had a 2.1% absolute risk reduction, survival advantage when cared for by a heart failure cardiologist. And this is actually something that's very difficult to show because it's not just the cardiogenic shock patients. These are the all-comers. These are the patients who had a STEMI and were not in shock. These were the patients who had an AFib ablation and needed monitoring. These are the patients who had an ICD extraction and needed monitoring. And yet we found all-comer mortality improvement. But then when you drill down to the cardiogenic shock patients, where we think we can be of most help and the most advantage, the cardiogenic shock patient mortality decreased from 37% to 25% when cared for by the heart failure cardiologist. And then when you drill down even further to the patients with cardiogenic shock and an MCS device, the odds of death, odds ratio, 0.6, so 40% improvement in survival when cared for by a heart failure specialist. And we're very proud of this data, and other centers are beginning to look at this and adopt this as well. So we have the PA catheter being the control panel, okay, being your gauges. Again, getting back to this idea of who's flying the plane, the airline industry. So is it this gentleman who maybe he's just flying the plane on Sundays? Maybe he's just doing his 2 weeks out of the year covering the CCU and covering a weekend just because it happened to be the weekend to even out the call schedule. Does he know how to use these gauges? Well, might be better to have Luke Skywalker and use the Force, but I would prefer that he used his targeting computer to target the Death Star to blow it up. But I actually put it to you, I'd want this person over here flying the plane. This person with these steely eyes that are looking at all these gauges, looking at these monitors, and who really knows how to react to it and to do the things that are necessary to take care of that plane, as well as to take care of all the patients in cardiogenic shock. And for those who don't know, this is Captain Chelsea Sullenberger, Sully, the hero of the Miracle on the Hudson. So I like him flying any plane that I would be on, and I'd like someone like him, a heart failure cardiologist, so to speak, to be caring for these patients in the cardiac intensive care unit. So putting it all together to take care of the patient, because that's what it's all about. So these are what our patients look like. This is what the hospital rooms look like, all the technology. So we got our PA catheter. We got to look at it. We've got our vasoactive meds. We've got our Impella console. We need to know how to look at it. We've got VA ECMO. We need to know how to escalate to that or when to get it out. We've got our CRRT machine, our inhaled nitric, our ventilator. But most importantly, we have our cardiac intensive care unit team that's outside the room and then going into the room and going in frequently and talking about the patients frequently, led by a heart failure cardiologist who's taking care of these patients. So I'm going to stop here and thank you all for your attention.
Thank you, Danny. That was amazing. Yeah, really great representation of the care that we provide under Danny's leadership in our CCU. Any question, Omar? Okay.
Thank you, Danny. It was a great talk. Quick question, you said that our CCU here is staffed by all those heart failure cardiologists. As the specialty is declining, less and less people are going into this. How is this model going to continue, or will it be replaced by the cardiac intensive care fellowship? Can it be replaced?
Yeah, so that's a great question. So I just got back last month before ACC. We had a program directors meeting. So the other hat I wear is I direct the cardiology fellowship. So if you look at the decline in the number of people who are going into heart failure, it's matched by the increase in the number of people going into cardiac intensive care. And a lot of that is wanting shift work and wanting to sign in, sign out, and to not be on. But these patients really require somebody who knows them and someone knows what happened during the day and can really respond to it at night and which way they're going, and who is part of the multidisciplinary team to know now's the time for LVAD, now is the time for transplant. The blood transfusion is actually a big deal if it's going to be a sensitizing event. The RV performance as they head to the operating room the next day, it's not just look at the RA pressure once at night, but multiple phone calls, multiple check-ins to make sure it's okay, so that we're hopefully not going to need an RVAD the next day. There's a lot of potential things that can be done to increase the viability of the field, such as, taking in cardiac oncology, such as all the other changes in cardiomyopathy management. But I really think that cardiac intensive care and shock is a big thing for a lot of people who want to go into advanced heart failure. So I'm hopeful that as heart failure shifts in a lot of places from a consultant model to a model of taking care of the patients, being the primary doctor in the cardiac intensive care unit, that'll help with getting people to go into heart failure.
That was great. What I haven't heard about is the whole idea of not letting the sun rise on an LCP. So can you comment on that? Because to me, that device is purely a PCI device. And here, Sim told us that most of the technologies are journey to a PCI high risk first, and then the cardiogenic shock models for approval. My sense is the device should not ever be used for shock. And it's because of the incident hemolysis is so high. And perhaps the next day, use people, if it's needed, the PAC is telling us, and the clinician is telling us they're going to shot, it should be transitioned quicker to a 5.5, where it can be ambulated, be rotated, etc. What are your thoughts on that?
Yep. So I think if the Impella CP is working, if there's no hemolysis or significant hemolysis, I should say, if you're meeting your hemometabolic goals, if the patient has stabilized and is improving, you may be able to get it out, in which case you don't need to transition them the next day. But if it's not supplying adequate support, then you want to get it out. Now, if it's not supplying adequate support because there's terrible hemolysis, because there's terrible placement, they got to go back to the lab and get it adjusted. And if it can't be salvaged and supply adequate support, yes, transition earlier. Get the patient the adequate hemodynamic support that they need, get the patient ambulatory.
I wanted to challenge Daniel a little bit about this, because I agree with you that hemolysis is more on the CP compared to a 5.5. It's size matters. The bigger the device, the less hemolysis. But what is this rate of hemolysis we're talking about? Because you look at danger shock, in that setting where you stayed in for longer periods, it was, I think, maximum 12%, right? And it's not 100%, it's not 90%, right? And I agree, when it happens, it can potentially contribute to the increased risk of renal replacement therapy in that group of patients. But I do think, to say because every patient who gets a CP needs to be transitioned is maybe not appropriate. There are a lot of patients where we in the middle of the night will put them on a CP, and by the next day or or 48 hours later, they get out because they've recovered. In the setting of, semi-acute myocardial, very different to having heart failure, cardiogenic shock patients, where we don't really put impellers in that. I think those patients should never get a CP because that patient's going to stay with an impeller much longer. And a 5.5 is, the video you show of your patient walking around with a 5.5, that's what that patient should have.
Right, the comment is mostly on people who are clearly not ready to have the device out, 48 hours. How long do you wait before immobilized?
Yeah.
So that's the comment.
I agree with you. I want to add somewhere in between. So whatever the percentage is, 12%, probably clinical trials usually is a plasma for hemoglobin over 40, which is sky high and much above what's clinically relevant. And Omar has published this in ECMO and other devices that a low level hemolysis, is associated with stroke. So I think the wise thing between interventional surgery and heart failure is you watch whether the patient is developing a complication and act early. So if you have hemolysis that cannot be corrected with repositioning, which often can be, then your thought should be to switch the device.
But what if they don't,
We can all agree.
what if they don't have hemolysis? Scott, what do you comment on this?
Yeah, he's very much.
Also, it's actually interesting because one of the questions, one of the areas I think that we need to have a zone of agreement is weaning devices. So is 48 hours the time when if you're on ECMO or you're on a CP, and there are different escalation strategies going up and going down. You have to think about having a trajectory towards ambulation. We know from the trauma literature that you take a 25-year-old who had a non-immobilizing injury who's been immobilized for 3 days, and it takes 2 weeks of physical therapy to get them back and they're debilitated. You take a 70-year-old who's had an MI, and you put them in bed 48 hours or 96 hours, and all of a sudden they're not going to be a viable transplant candidate. They've lost all their ability to recover in Q7. I think that number one, in terms of hemolysis with the CP, position is very important, and that's something that's not necessarily franchisable. We know that you can put it in and give support, but then with both ECMO and flow rates and CP, that technique does matter, and it's heterogeneous throughout the United States, and that can be a challenge. And it also depends on strategy. Some places are partial flow and eject, and other places are full flow and turn it up and decompress completely, and also inotrope. So I think there's a heterogeneity in practice that leads to the outcomes that we see, which is one of the reasons why the data is so hard to interpret.
Yeah, excellent. Great. Thanks, guys. Really excellent discussion. We're going to take a break now and do the case later, about 20 minutes. And you saw the picture of the French size. The devices are outside if you want to go in the exhibit and take a look at them, touch them, get a better idea. Really good. What are you doing? On left?
I'm all for it.
For Dr. Mohan. I saw.
Oh,
Yeah, and he showed me that. So he texted him. Hey,
It's perfect. They need to borrow you for 30 seconds.
okay.
It's my honor to give you on behalf of the house staff, outstanding subspecialist of the year award.
Kidding me.
You told me that you never really get teaching award.
Oh my
And I was
God.
like, this man absolutely is the best teacher I have had. And so,
Thank you. Oh my God, this is amazing.
no, but seriously, it's not just me, everyone, this is a vote. So every year you put to a vote, the whole program votes. But I said that I wanted to give it to you because I do know that you're still there. But it's a poll, it's among
Oh my
critical care,
God.
cardiology, everybody.
Oh my God.
Out of all the programs.
Oh, I'm so moved. Thank you so much.
You deserve it. You're
Yeah, everybody, yeah. Oh my God, they're crying.
And I thought, what a perfect, you're having a great few days, yeah, so.
Yeah, wow. Thank you so much.
No, absolutely. So.
This is great.
No, but it's
slight departure from the program for about 2 minutes. Recording in progress. Whenever I speak, there's either a fire alarm or something else. Have you noticed that?
The message.
The message, yeah, there's a message like, oh.
Trump's AI.
This is strong. So anyway, welcome back to this session. I chose to spend 2 minutes of your time just to laud and herald and acknowledge Uli Yordi for a very particular reason. So we were out in the break, and Uli turns to me and he says, "Look what I got." And I said, "What did you get?" And he hands me, with a blush, he hands me this plaque, which was just handed to him by the house staff at Montefiore. And this is a teaching award. Let me tell you something about mentorship. Whenever we, as senior as we get, as experienced as we get, we always love hearing from our mentees and those that we have taught who we are, what we represent to them. It's a lifelong of companionship. It's a lifelong of teaching. And an award given by the house staff is particularly important because you can get it from your fellows, you can get it from your colleagues, you can get a Lifetime Achievement Award from your peers. But when a house staff award is given, it has great meaning. I received one probably 28 years ago. And for the last 28 years, I've been searching for one and haven't been able to get one until I was able to hold this in my hand today. So I will just read this out to you, and this is a great, great acknowledgement, Uli, of your mentorship, your teaching abilities, your greatness as a scholar. In fact, the Sharon Silbigger Faculty Teaching Award presented by the Montefiore House staff to Uli Yordi for excellence in teaching and in recognition of his outstanding performance as a subspecialist of the year, and from the Albert Einstein College of Medicine. Congratulations, Uli. Thank you.
Stage photo.
You did.
Great. Okay. Back to work. Now, this thanks to the house staff who is on Zoom, hopefully, this really means a lot to me. And I only waited 26 years, Mandeep. It's not too late. Great. We're going to move on to turn on one of the mics. To Sandhya Murthy, who is, has actually received multiple house staff awards already and has been the envy of my life until today.
I'm so glad.
But Sandhya is, I think it's the first person I recruited as an attending physician after she had been a fellow at Columbia while I was there. So 10 years ago. In the interim, another institution who shall go unnamed tried to recruit her. Of course, I squashed that. And Sandhya is, after many house staff awards, also is really an amazing clinician. And about 3 or 6 months ago, she had worked on this new drug, the sotatercept. And Sandhya has incredible clinical experience with all these things. And I said, this is the coolest thing I've seen in a really long time, and probably the coolest thing in pulmonary hypertension. The paper it's accepted pending revision or something like that. So the paper will come out very soon in JHLT, but I'll let Sandhya tell you the story. This is something really shift treatment paradigm for pulmonary hypertension based on her observations also.
Okay, thank you so much, Uli. And thank you guys for giving me the opportunity to share with you something I'm really passionate about. And the last couple of years, I really didn't have anything to talk about with pulmonary hypertension, nothing new for the last 10 years. So I'm very happy to share this with you. And it's been a privilege to work in this field. So we'll start off to kind of shift from shock a little bit and get you start to think about the lungs a little bit. So 52-year-old woman, intermediate risk pulmonary arterial hypertension. What would you recommend as starting therapy? PDE5 inhibitor, tadalafil, sildenafil, PDE5 inhibitor and ERA, which is macitentan and ambrisentan. We have quad therapy too in our field. It's PDE5, ERA, prostacyclin, sotatercept. Or D, why are we talking about this at a MonteHeart conference? Let's get back to the shock.
E.
Come on. Danny, of course. All right. We'll give it a second. Okay. All right. Good, great. You guys know the ambition trial of 2015, which told us that we should be starting Masaten or a PDE5 inhibitor and an ERA, but I want to challenge you a little bit after you see this. You might think a little bit differently. So to directly target the 16% who are not sure why we're talking about this, I'll tell you why I'm involved. So we have the pathophysiology basically is anything that causes a high rise in PA pressures, whether that's heart failure, lung disease, thromboembolism, anything that causes high stress in the pulmonary arteries. What we see is this pointers is that the PA pressures go up, PVR goes up at some point after that. That leads to RV failure, and this is when we're involved. That's when we get the inpatient consult. But really what makes more sense is before this PVR goes up to a point of where now we're struggling is to be involved when we have these first identifying risk factors. So that's really why we're involved as heart failure cardiologists, because ultimately this is an RV failure disease. We can talk about pH in several different ways, but the hemodynamic definition is well accepted. This is recently published in, this is the latest guidelines, 2022 ERS, ESC guidelines, but where you have a mean PA of over 20, which will identify you as having pulmonary hypertension. Now, under the pulmonary hypertension umbrella, we have a couple categories. We have the precapillary pure PAH. We have combined precapillary and postcapillary, which has been the bane of our existence as heart failure cardiologists, where you see this combined phenotype where you have an elevated PVR, elevated wedge, and elevated mean PA, and then the isolated postcapillary pH. This is the easy stuff, the left heart failure. So this is really the only type that's treatable with our traditional vasodilator therapy and our pH therapy. So again, we can also talk about this as broad subgroups in pH, not just hemodynamically, but we have 5 different categories here. And this is, again, this is updated in 2023, where this is the rarest form, but again, this is the only type that should be getting therapy. This is the idiopathic and associated conditions. We'll talk about what those conditions are in a couple slides. We have the isolated left heart disease category. Then we have the lung disease, we have the CTEPH, and we have the rare multifactorial systemic disorders. This is by far the most common, the left heart disease category, then followed by hypoxic lung disease. And then again, rarest is what I'm looking at here. And to me, it's, not as rare as we think, I think. So group 1 associated conditions, to talk about this quickly, because this is really the type we focus on. We have several different categories. The idiopathic, again, this is a female predominant disease, unfortunately, a young woman disease. And then we have the familial type, and there's been a lot of buzz about the BMPR2 receptor and the loss of function mutations here. Congenital diseases, liver diseases, lupus, which is probably the most common thing that I see in the Bronx is lupus and scleroderma as being the predominant phenotypes here of group 1 disease. HIV, and then drugs and toxins. We have all the diet supplements from the 80s and 90s, the Aminorex, the fen-phen. And then as far as toxic drugs, methamphetamines are the big ones, the ecstasy, MDMA, and we see that occasionally. It's far more common out west. And then possible associations is a long and ever expanding list of different things that perhaps could lead to this. So focusing on the timeline before 2024, and this is really why I had nothing to talk about for the last couple of years, is the selexipag was the last thing we had in 2015. And this was a prostacyclin receptor antagonist. I'll show you an agonist rather, and I'll show you in a couple slides why all of these therapies were very limited for us. These are pure vasodilators, starting from 1995, where it was just calcium channel blockers and Coumadin. Epoprostenol really put this disease on the map by finally, first time we have something that actually works to improve mortality and actually decrease PVR and PA pressures effectively. And then over the next 30 years, it was a little bit stagnant as far as the pathophysiologies and the modalities of treatment. So what do our traditional pre-2024 therapies target? Is it endothelial hypertrophy, fibrosis, inflammation, none of the above? What were our therapies really doing? What was the PDE5 inhibitors, ERAs, prostacyclins? Okay, we'll give it a couple seconds. Okay, good. There's something to talk about here. Okay, so a lot of you think it's the endothelial hypertrophy part that our therapies have. So ideally, our therapy should target that, because if we think about the pathophysiology behind pulmonary arterial hypertension, we have three things that we've noticed. One is that you get this medial hyperplasia. That's, again, the hypertrophy of the smooth muscles. You have vascular remodeling, you have fibrosis, and you also have thrombosis in the late stages of the disease. And then there's these so-called plexiform lesions, and this is just the lungs' way to try to increase surface area to improve gas exchange. But what do our therapies do? Do they do endothelial proliferation? Nope, they don't. But do they target fibrosis? That would be nice. No, they actually don't. Smooth muscle hypertrophy? No. Thrombosis? No, we don't really use Coumadin anymore. So what do our therapies do? It's just vasodilation. That's it. That's all we got. So what we're talking about here is to take this pulmonary artery that should be nice and normal, and now we see this big hypertrophied artery with a small lumen size. All we're doing is trying to make this lumen a little bit bigger, but we are not treating any of the underlying pathophysiologies that we know contribute to the disease itself. So of course we're limited. So triple therapy in PH in early 2024, what is that? It is basically you take one from the nitric oxide pathway and one from the ERA pathway and one from the prostacyclin pathway. But if you look at the end result of the smooth muscles, they all do the same thing. They all increase intracellular cGMP, and then what that does in downstream with cytostolic calcium is it causes smooth muscle relaxation. So whatever you give, PDE5 inhibitor, ERA, or prostacyclin, the end result is smooth muscle relaxation. You're just vasodilating. But again, this is what our arteries actually look like in PAH. So vasodilation, you can see the Achilles heel here, and this is why we're very limited with how beneficial, and this is why it still remained a really highly morbid and more high mortality disease. So I don't want to just, blow everything out of the water and say it was all kind of nonsense, but epoprostenol was still the only drug and still is the only drug with any kind of mortality data behind it. And this is from 1996. This is really what put it on the map, where they took 40 patients in each arm, 40 on EPO and 40 on conventional therapy, which at that point was Lasix, digoxin, calcium channel blockers, and basically randomized to epoprostenol versus conventional therapy. And at the end of 12 weeks, almost 100% were alive on epoprostenol, whereas 80% were alive with the conventional arm. So yes, and this holds true even now after the last 40 years. This is the only thing that has any mortality data. So what's the problem with epoprostenol? Everything, because there's epoprostenol receptors, there's prostacyclin receptors on every part of the body. So it's highly fraught with side effects. We have it in the jaw, where you have this kind of strange jaw pain, and there's muscle aches. There's tons in the GI tract, so a lot of nausea and vomiting. People hate it. It's really a terrible medicine to tolerate, but it'll make you live longer. So, this is really the big gun that we've had for many years now, and this is what we reserve for the sickest patients. There's many ways to deliver this. We have sub-Q, we have inhaled, we have IV. There's even this implantable pump version of this, but in general, we're stuck with a terrible side effect profile. So let's talk about March 2024, sotatercept. Okay, what's the big deal? So we'll talk about why this is such a big deal for us. That sotatercept steps away from the traditional vasodilator approach. And what it does is that in a PAH model, what you have is a high signaling for proliferation and a low signaling for apoptosis and anti-proliferative pathways. So what you get is this imbalance of proliferation and apoptosis through BMPR receptors and through complex signaling mechanisms, which I won't go through. So now you have sotatercept come in and restore that balance. So basically, sotatercept promotes apoptosis of these hypertrophied cells and blocks proliferation. So it actually treats one of the underlying pathophysiologies, which is cellular proliferation, hypertrophy, and steps away from the vasodilator approach. So again, actually targeting the disease. So what data do we have from 2021? This is a phase 2 trial, Pulsar trial. And what they saw is that sotatercept, after a period of 6 months, dropped the PVR by about 3 Wood units. That's pretty good. And of course, 6-minute walk distance, everything else increased. As a side note, 57% were on triple therapy, 40% were on IV prostacyclin infusion. So this was a well-treated group to have 40% on IV epoprostenol. So in good background therapy, we still saw a benefit. So that led to the larger phase 3 Stellar trial, which was highly significant for event-free survival, meaning that less patients had to go on to IV prostacyclin therapy, less patients were hospitalized. It was a combined endpoint. And sotatercept was, highly positive in that regard, as well as 6-minute walk distance. And again, a well-treated group with PAH therapy, traditional vasodilator therapy that we had at that point. So that's great. So how do we use that and how do we incorporate that? So I want to take you to 2 examples of what we did with this, and then a novel approach that we're doing here in most of these patients. So we'll take you back to 2019. We have a 48-year-old woman that was admitted with RV failure. This is her index admission, idiopathic. She's the right age, the right gender. She underwent inotrope-assisted diuresis, and this is her right heart cath shown below. So pretty classic pre-capillary profile. You have a mean PA of 46, low wedge, PVR of 12. So what do we do? In 2019, we did what was available at the time, which is IV prostacyclins. And so we put her on IV prostacyclins, repeated the cath a couple months later. So I want to highlight a couple things here from baseline. One, the cardiac index has gone up a little bit. Mean PA, not so impressive, but with that, the PVR calculates out to 10. We see about a 2 Wood unit drops with just IV epoprostenol. So that's not good enough. We stack on the other therapies that we have, PDE5 inhibitor, ERA, and 2 years later, she absolutely was crippled by the IV epoprostenol. We took her off of IV epoprostenol, put her on oral prostacyclin. Unfortunately, she just could not tolerate it. She was, bedbound home. It wasn't a quality of life for a 50-year-old at the time. So on triple therapy of the best we had, what we see is the mean PA of 47, the FIC remains about the same, and the wedge is a little bit higher here. Again, 50-year-old, diastolic, she's obese, she's got some diastolic heart failure risk factors, but her filling pressures are much higher than they were prior to this, but the PVR still calculates out to 8.2. We're not really happy with this, to have a PVR of 8.2 at age 50 on the best stuff we've got, we're running out of options here. So I'm not satisfied. We think about how can we closely monitor her. We don't want to do catheterizations every 6 months to see if our therapies are working, and we don't want to wait for non-invasive mechanisms to up-titrate therapy. So we think about the CardioMEMS. CardioMEMS you've heard about yesterday with Dr. Shin's talk. And it's a PA sensor delivery system that's implanted usually in the left lower lobe, as that's closest to the back. The patients go home with this pillow, they transmit pressures, they press this button, and physicians are able to get this data available on the website at any time. And the information that we get is a systolic PA, diastolic PA, mean PA, and also heart rate. So that we get a lot of information when they transmit, and you can tell them to transmit any point, every day, every week. My patients, I generally tell them to transmit every week. This is not like heart failure where I'm actively titrating Lasix. I just want to know the trend of the PA pressures. So to me, it made sense You didn't need that robust infrastructure of nurse practitioners looking at this every day. This made sense as an application to pulmonary arterial hypertension, not done in, without data behind it. There's been several trials published showing the safety in PAH. These PAs are a little bit larger, and I'm sure Dr. Shin can tell you these are a lot harder to implant because of the dysfunctional pulmonary vasculature, but it's safe in PAH. And to me, it makes the most sense to do this, as we're aggressively titrating therapy in the sickest of patients. So I want to show you her CardioMEMS readings one day prior to sotatercept injection. She was one of my first patients that we put on sotatercept. This is 6/2024, about 2 months after it was FDA approved. And we see her mean PA is 42, and kind of going along with the last right heart cath we had. She's also tachycardic, again, signs that she's not doing so well. She injects herself with sotatercept. This is 1 week after sotatercept injection. We start to see something really interesting that, wow, the PA pressure came down quite dramatically over the course of the week. So we are holding out for any celebrations yet. We say, well, let's just see how it goes. We continue sotatercept, and this is by the way, this is a sub-Q injection given every 3 weeks. The patients give it themselves. It's quite easy to do. It's almost like the Ozempic and the sotatercept. It kind of goes hand in hand here. We follow her out, and sure enough, now over the next year, we continue this quad therapy with sotatercept. That early drop in PA pressure was sustained. This is her reading from last week, 40, 17 with a mean of 27. This is incredible. We've never seen this before. So hold off on celebrating until we see this replicated in other patients. And what's nice about the CardioMEMS system is you get this nice little over time graph of the mean PA pressures. And you see this point. This is sotatercept injection, dramatic drop in mean PA, and we see this sustained over the next year. Okay, so our next 6 patients, what happened? We saw similar results. It was actually really incredible that we started off with an average mean PA of about 42, and within 1 week, we see this trend of going down quite dramatically to the point where at week 12, we see the mean PA go from 42 to 27 after 12 weeks. This is incredible. We've never seen this before. We've been struggling with vasodilator therapy, and finally we have something that actually targets the underlying disease, and it seems quite promising. And we see this now over 44 weeks. The drug has been out for just about a year and change. And we see that this is sustained over time, that the mean PA remains in the mid-20s from high of 40s. So it's been really incredible. We have about 45 patients on sotatercept. And one thing I can say is that there's certain safety considerations. While this is extremely well tolerated compared to everything else that we have, we do see almost everyone, their hemoglobin goes up. Don't know why this happens, but anytime it goes up over 4, we hold a dose, it goes back down. There has been no signaling for increased thrombosis risk. And in fact, it's actually the opposite. Patients actually bleed more from gums, and epistaxis. Occasionally, we have platelet counts that also decrease. I've not seen anybody drop below 50, but this is one consideration. 3 have had to hold the dose for asymptomatic rise in hemoglobin. So I'm not sure what this means. This is still early data, but so far it doesn't seem to have any kind of clinical implications. So another kind of example of where we use the sotatercept. This is a woman that came in last year, index presentation. Again, 47, systemic PA pressures, mean PA of 65, wedge of 10. We started her on epoprostenol, and then go right to dual therapy PDE5 inhibitor ERA, implanted her with a CardioMEMS. At this point, I wasn't waiting to figure out if this is going to respond or not. And we see that a modest benefit, PVR goes from 13 to 10 with our traditional therapies. And then what we do after the CardioMEMS is we do a sotatercept prostacyclin wean. So I want to show you her CardioMEMS data here. We have a PA systolic, PA diastolic, PA mean in the center here. So we go from a PA mean of about 60, sotatercept initiation, and the EPO was started to be weaned. Here we see this nice continued downtrend. Epoprostenol is off about a month later. and she's just maintained on sotatercept and dual oral therapy. And her latest PA pressures, this was last week, I'm sorry if you can't see it, but on sotatercept, PDE5, ERA, and oral prostacyclin, we have a mean PA of about 26. Incredible, from a mean PA of 65 to 26. So final thoughts. All these drug therapies are really only approved for group 1 PAH, so we shouldn't be using it in cases of left heart disease and lung disease and things like that. We have to think about, in our traditional vasodilator therapies, we were worried about flooding the LV when we vasodilate the lungs, that we might cause pulmonary edema. Just to say that sotatercept doesn't work through vasodilation, and perhaps there is some role in these non-group 1 patients, but we need a lot more trials to figure that out. We always worry about the worsening VQ mismatch in group 3 disease when you try it in hypoxic lung disease and ILD. What we see is that delicate VQ balance gets messed up when you indiscriminately vasodilate, so this is really a consideration. Perhaps sotatercept should play an earlier role in therapy, and we're going to see trials in the next year or two that will kind of clarify that further. And then PAH finally is evolving as a treatable disease with real progress over the past few years as we move away from vasodilator therapy and start tackling the underpinnings of the disease. And then finally, something that's kind of unique to us is this use of cardiomems as a useful technology with important applications in pulmonary hypertension and RV failure, not just LV failure. And I find that it's been incredibly helpful for me in the last couple of years to manage these patients without needing this robust infrastructure of nurse practitioners checking, the MEMS every day. And then just to highlight that the right ventricle has few options for advanced therapy. RVAD is temporary. Lung transplants aren't great for a 40-year-old. So we just need continued progress in this realm, and as we move away to more targeted therapies. So with that, I'll end. Thank you very much for your attention. Thanks for getting the questions.
Yes, Sonia, that was great. Are there any questions? I mean, yeah, Mandeep, very good. Let me get you a mic. I don't know. Here's the mic. Okay.
This is a really interesting drug, and as an activin ligand-related drug that acts on SMAD, I wouldn't expect it to exert an effect within days.
Yeah, and that's I think shocked us all as to how and why, and more to come as to but it's never really been shown the rapidity. The trials all looked at 3-month, 6-month hemodynamics, but to see it on a week-to-week, I would think that there's something else rather than to actually change the molecular pathway signals. There's something else to this. I don't know.
It almost has to be a vasodilator, and it has to be a vasodilator by restoration of endothelial function.
Yeah.
Nothing could
Make it that quickly.
As quickly. So somehow, or it is somehow making the other therapies more responsive, which is the only other possibility. Yes.
Yeah. So again, I think this is where it's, as monotherapy trials would be interesting to see, although with what we know about PAH, I'm not sure that can be done with equipoise, but I do have one of those 6 patients that I showed was only on monotherapy, was on tadalafil 20. So because he couldn't tolerate anything else, and similar results. So I'm not, but you're right. I don't know how and why and what's the mechanism, and it must be a vasodilator. I hear that, but I don't know. Yeah.
Yeah, Mandeep, I think you hit the nail on the head about maybe the preconditioning with the other therapies, or the presence of the other therapies is required. So when I saw this, I said, yeah, this looks nice. Then I realized, that she was taking patients off prostacyclin. And that's when I got really excited, because it's the most miserable disease with the most miserable treatment. It's like hepatitis C with interferon and ribavirin, which my father was on, many years ago. And it's just the drugs. You don't know, is it the disease or the drugs that's worse? And that's very exciting. So anyways, I think for me, the most important report out of our center for the past year or two, because it has amazingly clinical relevance for patients that are getting this right now. So fantastic. Thank you, Sandhya. Right, so for those of you who answered, why are we presenting pulmonary hypertension at MonteHeart? I hope you understand now. But also, let's move back to the bread and butter of ischemic heart disease. And Pierre Pasquale Leone, where is he there? Will present the case. And then if Azim, Ivan, and Scott, if you can come up to the podium here.
All right, so good morning. I'm just a vehicle here for what I think is going to be a great discussion with three experts over here and hopefully a few of you guys as well. So we have a 65-year-old male with three vessel disease valve and the ejection fraction 15%. This is the title we were given. And we're going to go forward and just present this case. This is Christmas Day, a male, 65-year-old, hypertensive, hyperlipidemic, BMI is 28. He has had over the past 2 months chest pain overexertion. On the right-hand side, you can see the medications he was on. And he presented outside hospital with chest pain at rest. He was then transferred to our center at Weiler, and he went to the ED. So it was 2 hours of chest pain before that, intermittent, but then once it came to the ED over here, it was persistent chest pain. And over here, so we had already some labs. This is the first EKG. You can appreciate some bottom branch situation with a CK of 2700, troponin 35, hemoglobin 17, and creatinine 1.3. So overall, this is something that was observed at the first time, but rapidly the second point, troponin were done, and 69 was coming up, and 2700 still CK with a persistent chest pain. There's some dynamic EKG changes, and the patient was then promptly taken to the cath lab. So over here, I think you can all appreciate the nastiness of this disease. It's left-hand side. Well, of course, the central picture is the most scary one, but the left-hand side, there's a little picture on the bottom left to try to show a little bit more. This left main is really very tight disease, is 95% distal left main with some osteoproximal disease on the CERT, which is subocclusive. Then, of course, we have some osteoproximal disease in the central image with EV0 flow over there. And on the right-hand side, situation is not that great. So you're going to also see the incident on top right, there's 95% calcified lesion, the RCA. So I think this is a pretty relevant angiogram. And also we did a allogram just to see how the function of the heart was at, and you can appreciate the anterior wall is not really pumped very well. So there's LV depression, EDP was 28, severe three vessel disease, chest pain at rest, patient while on the table starts to complain of very, very severe shortness of breath, starting to get restless a little bit. So there's a clinical picture of compatible pulmonary edema, blood pressure starts to come down, 80 with 40. So over here, I think I just tried to resume a little bit and just highlight the key situation. High risk non-STEMI, persistent chest pain, dynamic EKG changes, cardiogenic shock and pulmonary edema ensuing multivessel CAD. EF was about 25% of what's seen in the allogram, mostly anteriorly hypokinesia, and we have the three vessel disease that was in. So I think this is a great opportunity now, and maybe we'll start to discuss just a little bit of what we can think now in terms of next management. If you guys
I'm first. So I actually did this scan. So what I did after I did the saw this picture, I did the angiogram. I called Dan Goldstein, so I'm not the surgeon. This is a surgical problem.
All right, I did a sign for therapeutic cabbage, which I'm not perfectly aligned with, but provide some arguments on this point. So we are missing data, consistent data. So for supporting conclusively the use of Impella 5.5. Nonetheless, in our clinical practice,
I would probably pursue, this is a pretty young gentleman, so not obese. So the only thing which I'm missing in our decision-making process is bagginess. So we could make it much clearer in the process of decision. Nonetheless, it's a triple vessel disease, the target vessels for full, hopefully arterial revascularization. We would pursue with the first step to stabilize the patient probably is impella 5. So this is a problem, and I'm referring to our clinical practice and try to pursue with the total arterial revascularization of all target vessels. We would pursue with the procedure, and this is something which is relatively new, as an OPCAT procedure, vacillated with impella 5. So there are some limitations to this approach, and there are some caveats and risks related to this procedure. It really requires very, very good collaboration with a cardiographer, because he needs to ensure a correct positioning all the time for the device, as you may either slip it away of the ventricle or on the other side. If it is too deep, you may injure the free wall of the ventricle and create a perforation. So I'm sorry for not providing more conclusive data on untreated cabbage, but probably this would be the case in our scenario.
Well, before we go there, I'm sorry, did you mention what the other hemodynamics were?
So we had a blood pressure of 80/40, and the patient was complaining shortness of breath. It was laying flat still, and situation was getting a little bit more constipated.
No about heart cath?
Not at this one.
Echo?
Echo with the LV gram 25% EF.
Well,
Echo confirmed what you saw there, 25% EF, no MR, no valve.
so, and what was the left ventricular end-diastolic dimension?
It was, if I remember correctly, I think 5.
Yes, my notes are not terribly enlarged. Yeah, so I always find it interesting when people actually do LV grams. I think it's of historic interest. I think it's of billing interest. But I think you can get an LV EVP and get all the information you need and complementary information on echo. I always ask why people actually get that. So the real question is, can you stabilize this patient and then allow significant optimal planning of they need an emergency operation? And vis-a-vis our previous discussion about the utility of balloon pumps, right? And this patient obviously has ongoing ischemia. They had chest pain, so it's not a question of heart failure type of situation. But this may be a patient who could get a balloon pump and stabilize with a resolution of their symptoms and sort of be optimized for the operating room. Where I agree with Ivan that we're going to need a arterial revascularization and some sort of revascularization. These good targets. The dimension is small, so I think surgical therapy is reasonable. I don't think he's terribly high risk, although he's in pulmonary edema currently, and then getting him out of heart failure with diuretics and a tincture of time and stabilization probably has a benefit. And as a non-New Yorker, but a native New Yorker born in the Bronx, I know about the STAR database and the risk profile, and we don't generally want to rush these patients to the operating room, because if you get an outcome, you get dinged. Right, in New York, that's still true, right, Dan? Yeah, you get dinged a lot.
Not for this patient.
Unless they
right?
put a swan document.
Yeah, he has, his blood pressure is less than 90, I think that would do it, right?
No.
You have a swan there,
So if we had a swan and we showed that the output was low, so I would say that I need 3 to 4 hours to make a decision on this patient, and that the window may still be open for either target revascularization with PCI or definitive with cabbage in some way. I don't know. Yeah.
No, I wanted you guys to make comments first, just because I know the patient. So, a bit of the challenge with him when he came in was he was awake, but he was rapidly deteriorating. And honestly, when I see a 95% left main with TIMI2 flow down the LAD and the circumflex, I question then how much time you have to stabilize something like that. I think when he wants to start getting TIMI2 flow from a left main lesion, I think the clock's ticking, and you need to start moving quicker and make some decisions quicker. So either, for me, the decision was, also he wasn't in this hospital, and Daniel was at another hospital. I was over here at most, I was on the other side of the Bronx with this patient. So the question was, do I put an impella in? Will the impella be enough and go ahead and do PCR and save in there? Or do I put some sort of support device in and try and get him straight into the OR and transfer him across the Bronx, which doesn't sound like far, but sometimes that can take 30, 40 minutes.
I'm impressed that Danny take part. I thought he's got people for that.
Well, actually, both meetings at one quarter Christmas Day.
Don't you think that the hemodynamics would help you make that? So to me, the game is open to you to put a CP in and PCI if his hemodynamics indicate that he has ongoing derangements and that, so if he's not hemodynamically unstable, it's hemodynamically tenuous. And that if his hemodynamics are poor, Danny can't get here in time and the OR takes, on Christmas Day, the OR takes time to get in. And so impella plus PCI to revascularize for time to reperfusion seems to be logistically the best thing to do if they're tenuous. But if you pull them back with either a balloon or a CP, you have a moment. Now, how long that moment is to be determined. You have a moment to determine the best therapy.
Scott, what would be your discriminatory threshold for deciding whether to go first for IVP or impella fine? So what would be a trigger?
Well, so I mean, you can look at the hemodynamics, but again, based on the RV, looking at how the heart was moving based on the angiogram, right? So the older surgeons look at those things and say that's an echo. Say that the RV is moving fairly well, the LV isn't, and decompression. So this is one of those high SVR, the low blood pressure balloon pump may be responsive according to the data to ischemia. Diastolic perfusion may be helpful. And, but if you're in a position, again, I'm not going to argue with you. Full disclosure, I'm for JK, so go ahead and put all the emails in there. Ivan, the issue here is.
Hold on, but guys,
So just one thing, I just want
remember to speak.
just add to that.
One sec. You have to speak into the mic because we can hear you, but the Zoom guys cannot.
So just add to the information from the echo, the RV still looked okay, wasn't that? It looked for all LV failure at that moment. Okay, just so as we think of it, Danny.
So Ivan, at least in our situation, impella was not an option because he's at the other institution. We don't have access there. This guy, I mean, that's a very scary angel for them. So the question in terms of MCS, balloon pump or follow to five, CP, so not to five.
You have CP, and already at this other institution as well.
What's that?
You have CP.
We have CP, that institute, and we have
balloon. And
that.
that
Available.
would
We
be
have
all that
all
would
of
be-
that. Well,
all that would be the quick, yeah, five, no.
Well, then if the transfer and logistics on Christmas Day and logistics on transfer are a challenge, then you go with the maximum support. You don't do a stepwise. If you're in your main hospital and you can do stepwise and then see, but so you put a CP in and then get the patient ready to go. And the only question is where they go. But the question for you is, if you put a CP in, do you need to do a PCI at that moment, or do you send them over for stabilization surgery the next day or 2 days later?
Okay, I think that we should, the decision here is, none of you is saying, I know what to do, I want to do it now. Is that fair? You're still talking to each other?
well, I think
Has somebody said no surgery or?
so Michael
everything
said,
is open.
so Michael said, obviously, I was the one in the room, and my concern was he would not survive to seeing the patient with that anatomy, with a 95% stenosis and RCA, his left main 95% stenotic with semi-tube flow. He was not going to survive today anyway, so I was.
EKG back up.
I got confused because it wasn't presented that he's another institution which has no direct access for impella fine.
Even with.
Or cardiac surgery.
Or cardiac surgery.
I'd have to transplant, I'd have to stabilize him and transplant, or I have to stabilize him and fix it. Well, those are kind of the options.
Even if it was here and not on Christmas, it's still a challenge till we get the OR and get the impella and the stuff. That's 3 hours, at best. So I can't, we gotta wait 2-3 hours. I think I was in our conversation about this, not gonna last. He's not gonna last that long.
Indeed.
So what about changing the sequence of stabilize and fix to fix and therefore stabilize?
You mean, can you,
Well,
Yeah, just
a little bit expand what you mean by that?
Well, what
Sorry.
I mean by that is this was clearly a evolving left main infarct.
Yeah.
A TB2 flow. This patient, you can put an unloading device in. All it's going to do is potentially protect the myocardium, but it's not going to change the trigger that's causing the disease. It's a small ventricle. There's no RV failure. This is a classic acute MI. With an acute stunt or you need to fix this. I mean, how can you just stabilize and transfer this patient as the
Good point. And so the one other thing I will just throw into this is when it doesn't reflect this well in the angiogram, but when you actually looked at the angiogram, my impression, concern was that there was also calcium in the left main, that this wasn't just a pure thrombotic lesion. So the minute I start touching him, he's gonna arrest. And so my feeling was he needed some sort of support. So let's show you what we did.
I'm getting chest pain, just waiting. Please do something.
We'll show you what we did.
All right, yeah, great discussion. So what the plan was on the left-hand side of the panel was to get access for VA ECMO. So that's the wires in the right femoral artery and right femoral vein. But then on the right-hand side of the screen, you can see that while this was being done, hemodynamics were getting worse. Pulmonary edema was getting worse, and
What hemodynamics are you talking about, since you don't have swine?
Yeah. So
yeah,
So you're saying hemodynamics and I hear blood pressure.
yeah. I mean, pulmonary edema.
I don't know what you think, Scott, the LVEDP is gonna be if you're seeing pulmonary edema.
But they said the LVDP was 26.
28.
Sorry. 28.
Probably
before
40
you
now.
inject contrast into the LV.
Yeah, so Scott's correct. The semantics of the word the usual semantics are not met here for the word hemodynamics.
So,
Yeah.
but I would also argue that with an LVEP of 28, that anatomy and an echo showing 20% EF.
You don't need to waste the
25.
time.
I mean,
No,
what,
that's fine.
a right heart cath is not gonna change what I'm gonna do in this patient.
No, but by all means.
Right, with an echo already showing me that LV is going down, the patient fraction, my job is to get him, keep him alive. Knowing that his pulmonary pressure is 45 versus 65 is not gonna change anything.
So I'll simply say for this though, when you reach for ECMO, right, which by the way, and I have this often, I'll make this often for this group. Usually in Arizona or Florida, I'll say, if someone can find me a randomized clinical trial that shows ECMO saves lives in this situation, I will buy them dinner. You can say, what do you like, where do you like here? What's the new place here, Danny, that you would offer dinner at? I'll just say Cafe des Artistes or.
Essential by
Union Square, Cafe, right? So.
Essential Microsoft, which should plant on.
Yes, I understand.
So we're not doing that.
I Laser Wolf, I mean, we go to Brooklyn. So, but my point is, you reach for ECMO when you have biventricular failure. You reach for univentricular support when you have it. So the hemodynamic semantics, with my lawyer friends say, let me represent you, you will do something different. And just because it's easy and it takes 4 minutes to put people on ECMO, doesn't mean that you're giving them a survival benefit. That was the whole point of the first session. Now, I ran an ECMO program that was also platinum, would be 250 ECMO runs a year. I believe in the therapy as a bridge to a therapy and life-saving, but I also don't believe in using it indiscriminately because you get paid for it, right? Which is why it's prevalent in the hospital system in the United States across, because it's a very good money maker for hospitals. That's why you have it. That said, I haven't seen anything in here except your impression of fear. Never let the doctor's feelings or fears impact on what therapy you apply. Say that this patient shouldn't get univentricular support in the best way possible.
I do think though that Azim, I think Azim was thinking that this guy is going to arrest. I'm going to need biventricular support very soon.
So it's prophylactic biventricular support.
Oh, access for VA ECMO. He didn't put the
I didn't
VA.
put the VA ECMO,
He just did access. So he was prepared in the case of a cardiac arrest. And then he was cogitating to fix it. I please fix it, Azim, please.
But Azim is also getting chest pain. Yeah, doctors are getting chest pain, guys. No, please don't use the word hemodynamics when a swan is not moving, going forward.
Without pressure arrested, then unloading, right? The native daughter unloading suggests that ischemia goes down, you break the cycle, and then you have the window in the therapeutic comfort to do a left main angioplasty with very facile operators.
Yeah, I will say that this may reflect the difference between US and out of US medical care, but in nature shock, there was no use of pulmonary artery catheters at all. Now, there weren't left main, we don't know how many left mains there were, et cetera, but they did not use PA catheters at all in cardiogenic shock.
So I must admit, my plan was to put a CP in and do PCI. And when I called Danny actually, when he saw the angiogram, said to me, Azim, but I don't think it's gonna be enough to support this patient during PCI. And we talked about ECMO, at least having the ECMO team come on standby. So that's why I had the access. So I could go ECMO team turn solid, but I started putting in the CP with the plan to go into PCI with no right heart. And I love white hot gas, but I'm convinced in this patient, it wasn't gonna change anything I was gonna do. This patient needed his RPO. Yeah. Okay, let's see what we did.
All right, so left-hand side, some furosemide was given, no-RIP was started, and it was very, very crashing situation. So the Impella CP was then placed from the left-hand side, and on the right side of the screen, you can appreciate that there was also some electrical instability as soon as the Impella CP was in. So BT and DT shock times 3. Patient was still at no loss of consciousness, arguably because the Impella CP was through pumping at P9. And lidocaine boludo started, amiodarone started, and
I would also add, so after the BTs, and then he started having BTs and we started shocking him, he was still wide awake within BT with almost no blood pressure because of the Impella. But after that, he lost pulsatility. And so now he's on an Impella with no pulsatility.
So what's his flow?
On the Impella, he was on PAs.
What's his flow? 3.5?
Yeah.
That's his blood pressure.
So he had no pulsatility with a blood pressure, sort of flat line, sort of about nothing.
So, I mean, but this goes to the fact that what happens.
Mike.
What happens when you get VC is now you're killing your right ventricle, right? 3 shocks and now your right ventricle but that's also the discriminatory power of knowing what the PA pressures are. You might have gone to ECMO originally, but if your LVEP is 28, your PAD may be 35, and your systolic may be 60, and that might have argued to go with ECMO up front to unload. However, having said that, we know that ECMO doesn't really unload, right? Doesn't help with ischemia, it just helps with perfusion.
I would just add ECMO was in the room, because when we do what we do outside hospital, we have to call for the ECMO team, and it takes them 40 minutes. So in that 40 minutes, this is like 40 minutes while I'm waiting for them to come to the room.
It's a long 40 minutes.
It's a long 40 minutes.
all right, so yeah, we're getting there.
I mean, today.
A little bit. Good things take a little bit of time. All right. So this is, I promise you, this is the last picture before that. So VA ECMO was then pursued from the right axis, and only after that the patient was intubated, sedated, and paralyzed. In terms of what everybody wants to see, well, of course, that wasn't too easy. So as Dr. Teep said, lots of calcium everywhere, which of course makes and gives us problems. 99% of the problems that we have in interventional cardiology in the coronaries is because we don't have support to push wires down, push catheters down, so we need support. And the only wire that was going down was the wire on the OM, and you can see on the left side of the screen. Took a lot of time to have a wire down the LAD. Lots of wires, I think about 10 wires. But after the wire was down, there was no way that anything was actually tracking through. So you have a wire down, but you cannot put a balloon, you cannot put anything. Microcatheters, 5 or 6 microcatheters we tried, nothing was going through. So this situation was very, very interesting, to say the least. And at this point, there's just a few things that we can do after this. And one of the things is that we can try, there's rotational atherectomy, and the wire that we use for rotational atherectomy, which is a dedicated wire, is really hard to manipulate. So the chances to actually have a free wire, we call it, of lesion and then do rotational atherectomy on that is not as high as with other wires. So it took us so much time on the right-hand side to get that wire down.
I would also add that at this point now he's got no flow down the neck. So now his left main is completely occluded. He's completely dependent on the ECMO, because there's no blood. That was kind of my concern. I'm sorry you couldn't see the angiogram. I knew this wasn't going to be just wired down with the thrombotic lesion. I was pretty concerned that the minute I started working on this, he would lose all flow because the left main would occlude, which it did. So this whole time now for about an hour, there is no left main flow. The left main is 100% occluded with no flow.
So astonishingly enough, over here on the left-hand side, there was indeed the possibility to do free wiring. So already on the left side, you can see the the bar that's burning down the LED. So it took a lot of time, but fortunately, after taking out that Gaia 2, that was the wire that you can see on the right side of the screen on the other slide, where a free wiring with the rotawire was possible, rotational atherectomy was undergone, and that's an IBUS image on the middle of the screen with a lot of calcium, a lot of cracks, which told us that, you know, the job was actually done by rotational atherectomy. And then no further, many details for this, but I'm just going to go ahead. We're going to do some angioplasty. You can see in the middle of the screen, progressively larger balloons, and then the stem that everybody wanted from the left main to the LED. And you can appreciate the flow now. It's TIMI3 flow down the LED, preserved branches, and there's somehow still diagonal disease. I think it's a great result for this vessel, left main to LED. And then since we were there, a lot of support and multi-vessel disease. Forgot to say that, you know, the wire was going down the OM, but I couldn't go down the circ. So we went and chased the RCA. This is the RCA procedure. As you remember, was some very tight lesion on mid segment of the vessel. Angioplasty was enough over here. So cutting balloons and non-compliant balloons, and then 434 stent was then implanted over there. And this is pretty much the procedure. Now the LED is patent, the RCA is patent. The circ has definitely some disease still. And over here is POD number 1. So this is December 26th.
I think just go back to that picture.
Yeah.
And just say for, you know, for the fellows and the audience also, to make them run. So the first angiogram is before we would start, and just look at how briskly the right coronary artery moves, and then watch the picture on the right at the end. And
You can say the same from the prior, look at the prior.
exactly.
Prior
Look how,
slide.
I mean, the heart's not moving at all.
It's all the breast, the diaphragm moving, that's moving the heart, basically.
One has to be aware that the heart is unloaded at this point.
Yeah.
And anesthesia does this all the time. They say the artery gets terrible when you come in with the ECMO, and the artery flows down and load it up. It doesn't look very good. I mean, I don't look very good sitting, but it's actually running in the central part. No, it's not that.
Why did you go for the right?
Because the right was like 95% included, and we wanted to fully revascularize him at that point. Because we felt his circ was not great. We wanted to give him the best chance. I didn't want to have to come back a few days later. You know, he's struggling with the right ventricle, and now I have to do his right. And I didn't think the right was going to be a lot of work. So it added another 20 minutes to the procedure.
I thought that I mean, if you look at culprit shock, for example, then this would be again the ethos of culprit shock. And I guess in this circumstance, if you were convinced that the cause of cardiogenic shock was the left main, you repair that temporarily and then figure out a stage strategy or a bypass strategy down the road for this gentleman who might need, obviously this would not be enough, but right now you need something to save myocardium and stabilize him from cardiogenic shock. That would be my goal rather than complete revascularization.
Right, but remember, he's not going to get bypassed just for a right. So that right is going to have to be fixed at some stage, right? With the 95%.
The carpet shock is not this type of patient,
Yeah.
right? There's ECMO patient. Carpet shock did not include patients like this.
No. I'm just
You're making a point.
I'm just making a point that in general, in an acute crisis situation, going after non-culprit vessels is probably a waste of time.
I mean, normally I would leave in another patient who was not an ECMO or like this, I would leave it alone. I would just do my culprit lesion and come back in a few days. With this guy, I kind of felt, I was there and I needed to give him every possibility to recover, and I didn't want to come back in a couple of days.
I think to invoke carpet shock here could possibly be a dangerous population.
I was gonna say, I saw this great talk earlier today about generalizability extrapolation.
Yes.
And I would say it's fair to say we're probably in the data-free zone. And my favorite quote, of course, is if we have data, let's look at the data. And if we're gonna go with opinions, let's go with mine.
Interventionalist was positioned behind you now, Andy, just for just arrived.
No, I mean, okay, let's assume that there were no trials. And you were just looking at this patient in a completely data-free zone, and this is 1960, and you have all the techniques that you have. I mean, the bottom line is that if there's a very clear lesion with TB2 flaw causing shock, with the EF that's down to 25, it has now resulted in cardiac arrest. Just fix that and stabilize the patient first, right? I mean, I just don't understand why you would go after that, right? Simply for the sake of giving him, under the guise of giving him more complete revascularization, but for what endpoint?
Do you want to respond? One of our interventions also.
Yeah, I do.
I think it's a very good point, but I think I would argue it's still an open question in 2025. Gulfbridge shock was before danger shock.
Forget the trial. I'm just talking about this patient.
Yeah, but
What would you gain by opening the right in an acute crisis situation?
no, but I just want to say in danger shock, in 2025, I think AMI cardiogenic shock it became the standard of care, and in danger shock, about 50% of patients had said to non-doc perfusions. So I think in the future we'll be back to asking this question again: what should we do in AMI cardiogenic shock? Do we vascularize? They have an impella in, or they have support in? Should we change the
Maybe it would be like saying, you know, this patient went to cabbage and didn't come out with a drop on the right coronary artery. I mean, this is a patient who needs full recovery, and I think his recovery will be better knowing all his vessels are revascularized. And we've seen this a number of times. This patient leaves the right coronary artery, then they're having arrhythmias, or the artery is looking crap, and there's all this indecisiveness. Oh, is it the right coronary artery? That's not wasn't the issue or not.
Well,
Also,
I mean, you could argue,
ECMO weaning would facilitate, but not a.
well, I can argue against myself now. And so if you say that this atherosclerosis developed over time, the culprit lesion was probably also collaterally supported by the right, and that by opening and doing a rotoblator on the left, and then revasculating the right, you gave a dual support with opening up those collaterals from the right as well. To secure the circulation. Okay, maybe I could understand that. I just don't see those collaterals for this.
Okay.
We need to transplant another patient in the
But yeah,
Great discussion.
we'll be quick. So yeah, this is PLD number one. VA ECMO was running 4,100, 5.9 liters, and pulse was 1.9. Pressors were on at high dose, and there was really no pulse at that time. So the Buddha was first at 3, then at 5. It was really hemoglobin was 11, free hemoglobin was more than 40. LDH was 1,000. Wasn't possible to start weaning anything in terms of VA ECMO or anything like that. So LVAD and heart transplant evaluation was launched. But then postoperative day 2, considering all the plasma-free hemoglobin, and hemoglobin was then 8 from 11. There wasn't really a lot of bleeding in the access side. There was, concern for some hemolysis, and the decision was then made to proceed on day 2, which is December 27th, for impella 5.5 via the right axillary artery. The Buddha was lowered to 2.5. Unfortunately enough, day after extubation was possible, and also weaning off inotropes. ECMO was then moved down to 4.5, impella to 2.5, and then on PLD 4, ECMO further down, and impella to P6. Managed to do VA ECMO decannulation on 5th day postoperative day, and EF was then 45%. 7th day after procedure, impella 5.5 to P3, and 8th day it was then removed. This is the echo on January 3rd, which was the day 9 after PCI. And then he was then discharged on 13th day after procedure. And this is the latest echo on January 27th. Thank you.
Great discussion, guys. Really good, very educational. I never thought about what you said, Scott. Something you said about patient on checkpoint and then the artery was not really moving as much because there was like around over. Yeah.
The other interesting point for discussion, not today, and I think would be a nice session at a future MonteHeart is it is a belief, not a knowledge, in terms of weaning inotropes on support and going to no inotropes. Right. So in this case, the clinical was you weaned all the inotropes before you came off ECMO, not even on low dose inotropes. And we could say that with a 5.5, the left side is protected, but the right side is probably under some strain. And it's better to leave inotropes in some way. Now, you could argue molecular mechanisms. We want to get the receptors down. You want to start GDMT. No one knows, but it's a point of discussion, I think, and there's not a consensus or really good data to guide us.
Another good point. Great. Thanks, guys, very much. We're going to move on.
Really good case, bread and butter, exciting. So we'll move on to our next speaker, guest speaker, Snehal Patel, who everybody knows here, who has been at Montefiore for 15 years, I think, and over the past 5 years has led our transplant program to #1 in the, I have to say that one more time, to #1 in the United States, and has really been an amazing friend and colleague, expert clinician, and we now invite him for his first, outside of his new institution, Northwell lecture, where he became the director of transplant, MCS, and heart failure, basically my role at Northwell. And he will talk to us about state-of-the-art transplantation that he's leaving behind.
Thanks very much, Uli. It's nice to be a guest speaker here. And I will say, Mandeep, that in 10, 11 years, I've never seen Uli blush. So the fact that you caught him blushing from that award is actually kind of a nice send-off. So here's my talk today. I've been doing some version of this talk for the last 5, 6 years and happy to do it one more time. Hoping really just to provide a brief overview of cardiac transplantation. Then I think the next few talks will be able to dive into some of the new stuff. I don't have any disclosures. This is really how I'd like to approach it, take you through the history, focus on our donor shortage and how we're looking to improve survival, and a few slides about our transplant program. So maybe just to start up a quick raise of hands, how many people here know that Christian Bernard did the first heart transplant? Good. Well, yeah, there you go. You always know the right answer. So I'm going to give you a little bit of a trick. Was that actually the first heart transplant was a xenotransplant. I think not everybody knows that, but some of us do. And it was interesting. This was actually a big ethical debate that James Hardy at the University of Mississippi did the first actual heart transplantation in a man, and he didn't have a donor available. And I think there was 4 surgeons with him, and he asked them to take a vote for a patient that was dying and said, would everybody agree to take one of these chimpanzees that he had sitting in a cage ready for such a scenario? And I guess 1 person abstained and 2 nodded yes and 1 said yes, and they proceeded. Unfortunately, the individual didn't survive. They thought that the smaller heart couldn't accommodate the recipient's venous return, and that patient died after 60 to 90 minutes after transplant. So we're just an interesting story in history. This was published in JAMA in 1964. And it's actually a nice article to read, just to go through the ethics of it and what they actually did. And after him, there were a few further attempts at xenotransplant, but as you can see, none of them really worked, and nobody was surviving more than 1 day. And we clearly didn't understand the immunology at that time to be able to go forward with that. And this is obviously different now. So the actual first successful transplant in terms of allotransplant, so species to species, was Christian Bernard in Cape Town. And he transplanted the heart from a 25-year-old female who died in an auto accident into a 55-year-old with end-stage heart failure. Although that patient died after 18 days from pneumonia, he quickly performed a second transplant, which survived 19 months. And that was really the beginning of the current era of transplant. And while he he gained all the fame for this. Actually, it was Norman Shumway at Stanford who had really worked on a lot of the techniques, and they were in a race to see who would perform the first. But he performed the first US transplant at Stanford in 1968. And like many other fields, the initial years were not a success. In 1968, there were 100 transplants done in the country, and we thought that was going to keep growing. But in the next 2 years, the volume actually decreased. And the reason was that the outcomes weren't good. And it wasn't that they didn't have the surgery down, that the concept wasn't right. It was really just about understanding how to manage these patients medically in terms of infection rejection. And just going to take you through this figure here, which shows the improvement in median survival after transplant over the last 20 to 30 years. So as we pointed out in the 1970s, people were living 1 week to a few months. And a couple of things happened over the next 10 to 15 years. One of the first things was that in 1974, the Supreme Court legalized the definition of brain death. And that allowed us to have actually brain dead donors. So people with working hearts who were legally dead, and we could, in a controlled situation, take that heart and with cold preservation methods, transfer that heart from another hospital and perform transplant. Another important thing was in the mid-1970s, the endomyocardial biopsy was invented, so we could actually distinguish rejection from infection, which allowed us to tailor our therapies correctly. You know, what is recognized as probably the biggest improvement in all of transplant was the introduction of cyclosporin into the immunosuppression regimens. And the clinical trials that were first started in Stanford in the 1980s were widely successful across all of organ transplant. It was really that changed the field. And there were further refinements to immunosuppression. And where that takes us to is current, and this is nice data from the ISHLT, so a registry of over 100,000 patients. You can see that median survival is now 11 years. And it's not just survival, it's quality of life. There are a lot of different ways that we look at this. This is a simple one, but if you look at red in transplant patients at 1, 3, and 5 years after transplant, how many of them have no activity limitations? And over 90%. So incredible therapy for both survival and quality of life when you're talking about patients that have weeks and months to live. The issue, though, is that we're not doing many of them, right? So here's this was switched to a Slido, but we can take a poll here. How many heart transplants are performed in the US yearly? A is 1,000, B is about 4,000, C is 25,000, or D is 100,000. I'll just give this a couple of seconds to come up. So I'm going to just keep going here. Okay, these are changing quickly. All right, so close to half got this right. So here's the change in number of transplants in the United States over time. As you can see, that we've actually doubled the number in the last 20 years, where we're performing low 2,000s for heart transplants in the country in 2008. And actually last year, which was the highest number I don't have on here, there was a little bit more than 4,500 heart transplants. Part of this increase is seen with DCD donors. The issue is that, you know, there's a variety of estimates of how many people could actually benefit from heart transplant. Maybe 250,000 is too high, but clearly there are less heart transplants performed compared to the people that could benefit from it. And this is strictly driven by a donor organ shortage. We just don't have enough donors. It's not because we can't do it or the technology at all. And it brings up the question of how we can expand the donor pool. And there's really 3 different ways that I think we can do this. One is to increase the number of organ donors. Remember, you have to choose on your license in this country whether or not you want to be an organ donor. There are public policy methods that could be performed to change this. I don't want to go into that right now. The second thing that we can do is increase the recovery rate of the organ donors that we have right now. So right now, about 1 in 3 donors that's offered for transplant is actually accepted and used. And this isn't really a science here. This is kind of expert opinion. There's no evidence in this. And one of the things that we've done in Monte over the last 10, 15 years is really try to dig down into this evidence and help increase the number of donors that can be accepted. And something that I just mentioned upon, but is beyond this talk right now, is xenotransplant, which might be coming quicker than we all realize. So work that our group, specifically led by Dr. Madan, who's going to be speaking later, has over the last 10 years tackled a number of different issues on this, looking at reasons that people turn down donor organs, and is it really legitimate? One of them was if they have a high donor troponin. We found that this didn't matter. He also looked at hearts with improving LV systolic dysfunction and found that if the heart looked good, you could take it, and has proposed a recovery protocol that was published in JACC a few years ago. We also looked at hepatitis C donors, both non-viremic and viremic, and found that with appropriate mechanisms, we can transplant these hearts safely. We're going to have a talk on DCD, so I'm not going to go into this too much, but we also looked early on a few years ago, looking at the feasibility of DCD donors, and found that in an early experience with the first 100 or so DCDs done in the country, that there was no difference in survival in the first 6 months. And more importantly in that paper is that we've seen, these are how many DCD donors are actually offered. And if we were able to take about 1/3 of these donors, you could see the impact that this could have. And we're actually recognizing this. Last year, I don't have the slide up here, was actually the first year that the number of DBD donors has gone down in the last 17 years. But we actually saw an increase in total heart transplants because of the increase in DCD donation. So it's really actually something that's taken hold in just a couple of years. I'm going to switch gears a little bit here and talk about something a little bit different. Is that, you know, while we talk about all the great benefits of heart transplantation, the truth is that it doesn't represent a cure. This was a nice editorial that was in the New York Times a couple of years ago from a woman who had had 2 heart transplants but died of a malignancy. And while we talk about all the great things about transplant, we're actually not offering a cure for younger people, you know, 30s, 40s, 50s, 60-year-olds, that where we extend the median survival for 10, 12, 13 years, that doesn't take them up to a normal life expectancy. And if you look at our progress in transplant over the last 40 years, each of these lines shows a different era. So blue is the 1980s, green is the 90s, red is the 2000s, and purple is the current. We're not really changing the mortality curve that much. It's really just a marginal improvement. And I think probably the next challenge in heart transplant is, how are we going to reduce the burden of care to these individuals while improving on the long-term risks? And I'm just going to give you an idea of some of the things that we've thought about over the last couple of years. And it's really just thinking about what are the complications, what are people dying from? There's the early complication, and the main one that we deal with now is primary graft dysfunction. So what's primary graft dysfunction? The definition is either left, right, or biventricular dysfunction in the graft within 24 hours. And its most severe form that requires VA ECMO to support the circulation. And the reason we think this happens is that from every step in the transplant process, from brain death to weaning from a guardian pulmonary bypass on the other end of the surgery, the donor heart is subjected to repeated ischemic insults. And our traditional approach to mitigating this has been static cold storage in an igloo cooler. So basically is what you see here is you have a donor and you have the recipient, and we keep the heart cold in a cold igloo storage box. But some of the exciting stuff that people are going to talk about in the next couple of talks is that there's three new strategies of transport to minimize the ischemic and reperfusion insults. So one is controlling the hypothermia. So we know that on cold ice that the hearts can actually get too cold. The second is using a machine to actually pump oxygenated blood. And the third is hypothermic oxygenated perfusion, which is a third method. We've adopted the first two over the last couple of years. The Sherpa pack, which is controlled hypothermic perfusion, maintains the heart at 4 to 8 degrees. Registry analysis that we have from this right now, looking at a propensity matched group, shows that actually we see a signal towards a survival benefit in these two groups at 2 years. Probably actually the first time that we've ever seen that transport method could actually make a difference. And last year, about 60% of the hearts in the US were done using the Sherpa pack for transport. The other system is the Transmedics organ care system, or the heart in the box. This is what it looks like. And the idea here is that instead of letting the heart be ischemic the whole entire time, why not just perfuse oxygenated blood? Here is a here's a visual of what happens. The heart's actually pumping and getting oxygenated blood. And I just want to show, just to give you an idea of what's happened is that at Montefiore over the last couple of years, as we've adopted these new transport mechanisms, our PGD rate, looking at VA ECMO, has decreased dramatically. And this is kind of where we're staying. I'm going to finish up just with a couple of slides talking about the late complications of heart transplant. The big ones that we see here are renal dysfunction, metabolic disease, malignancy. And we think all of these are due to immunosuppression. And the truth is that I think that we've actually been overly focused on immunosuppression. The rates of rejection have been decreasing year over year. And we actually need to refine our techniques so that we can reduce these risks. Some of the things that we've done is we've transitioned away from invasive biopsies and having continuous monitoring with the liquid biopsy and tailoring our care for each recipient. Christiana Gelai is going to talk about donor-derived cell-free DNA as a monitoring tool soon. But basically, we're looking to see if the fraction increased, and that can be our early sign into rejection. We've decreased the number of biopsies just down to a few, going from 14. And finally, CAV, which is actually, I think, an area of great interest. It's one of the leading causes of late cardiac death. Just in the interest of time, I'm just going to jump into what we're doing here is we're using OCT. So it's similar to IVUS, where we can actually characterize the coronary morphology in CAV to a greater degree. And so what we do is we at baseline take the coronary wall and describe it as normal, homogeneous intimal thickening, which is what the classic definition of CAV is, and then advanced plaque characteristics, which we're finding in more and more of our donors, where we define them as below. Here's kind of the images from representative patients that you can see. And when we looked at our first 30 or 40 patients, what we found was that on baseline imaging, we could actually stratify these patients. And our next step in our process is, can we tailor our therapies? You know, maybe some of these patients need DAPT, maybe they need to be switched to mTOR inhibitor early on. And that's kind of where we are in our next phase. So I'm going to finish up there and just mention a few things about the Montefiore heart transplant program. So this is the average number of transplants different programs do throughout the world. And you can see there's very few programs that are doing more than 30 transplants per year. This is the Montefiore volume year over year. You can see we're a program that does about 30 to 40 transplants per year, which puts us on a medium to large size program in New York, which is an incredibly competitive environment. Proud to say that when you look at our 1 and 3 year survival compared to the regional programs, you can see that we perform extremely well with 98% 1 year observed survival, 89% 3 year survival. And probably most impressively, when you look at these graphs, they're a little bit tricky, but the general idea is when you go left to right, that means you're doing more transplants, and top to bottom means that you're performing better than you would be expected based on the characteristics of the donor and recipients you have. Each circle is a transplant program. As you can see on the left, ours is the blue. So we perform better than expected, actually better than any other transplant program in the country. And this is publicly available data on the 1 year survival and also the 3 year survival. So I'm going to finish up there with just a few conclusions. And the heart transplant has made significant progress over 50 years, offering a median survival of greater than 11 years. But we really need to increase donor availability so we can get this therapy out to more people. And, really, it's just come down to a great team. This is our team. Maybe this is a slightly older picture, but I'm going to be sad to miss these guys. So I'm going to finish up there, okay?
This is great. We're still wearing ties on that picture.
That's a new era has arrived. Fantastic, great overview. And now we're going to dive a little bit deeper in some of these topics. And Christiana Gelai, who was recently promoted to be the clinical director of transplant and VAD, overseeing all our VAD coordinators, and really is the heart of the program, no pun intended, at this moment. So Christiana is going to talk to us about cell-free DNA.
Thanks, everybody. Before I start, since I'm the only nurse practitioner that has spoken over the last 2 days, If anybody has a problem with anything I'm about to say, Dr. Patel has taught me everything that I know, so take it up with him. So what is donor-derived cell-free DNA? So cell-free DNA is released constantly during normal cell turnover. So when healthy and inflamed or diseased tissues from cells undergoing apoptosis or necrosis, they are releasing cell-free DNA into the patient's peripheral blood. So in heart transplant recipients or in any transplant recipients, the allograft releases donor-derived cell-free DNA that you can distinguish from the recipient's DNA. So if there's any damage or injury to the graft, donor-derived cell-free DNA is released, and this is what we're measuring, is a fraction of that DNA that's in the recipient's blood. So in the setting of acute rejection, we see increases in the amount of donor-derived cell-free DNA. So traditionally, we recognize a biopsy as the gold standard for the diagnosis and of rejection. Like Dr. Patel mentioned, this has been around since the 70s. So more accurate and less invasive methods have been sought after for years. And biopsy has a lot of limitations. It's much more invasive, and there's risks associated with the biopsy procedure. There could be sampling error. There's a lack of portability, low sensitivity to detect early rejection, and there's inter-observer variability amongst pathologists. So cell-free DNA testing gives us a simple peripheral blood test. It's a lot easier for our patients, and it allows for earlier detection of rejection, which I'm going to talk about in a little bit. And it also allows for no inter-observer variability that you see with the pathologist looking at the biopsy results. So what have we done at MonteHeart over the past 5 to 6 years? We used to do up to 13, 14 biopsies, and we've been able to cut it down to just 4 post-transplant biopsies. So in the first 4 weeks, our patients undergo a biopsy once weekly. And we've been pretty aggressive with this, and we've been able to eliminate 10 surveillance biopsies for our patients. So it's been great for the patients and also great for the cardiologists that don't have to spend all day in the cath lab. So this brings us to the question, is biopsy still the gold standard for the treatment of rejection, for the diagnosis of rejection? So just going back to the beginning, this is the first prospective study of donor-derived cell-free DNA in heart transplant recipients. This was 161 patients, and they collected blood from donors and recipients, and then they followed it throughout and compared it to biopsy results. And what you can see here is that what they found was initially you have super high levels of donor-derived cell-free DNA in the blood. And this is from ischemia perfusion injury, cold storage, and transport of the organ. So that makes sense that you would have a release of the donor's DNA in the recipient's blood. But then about 2 to 3 days post-transplant, they saw a drastic decrease in the amount of donor-derived cell-free DNA. And then you can see here in this patient with no rejection, that the levels stay stably low throughout the first 12 months. But what else they saw was that in the setting of acute rejection, both cellular and antibody-mediated rejection, there was an increase in donor-derived cell-free DNA. And it was similar, and this makes sense because this is injury to the graft, so you would have a release of the donor's DNA into the blood. They also found that donor-derived cell-free DNA starts to go up weeks to months before the rejection was seen on the biopsy. So by the time we see cell death on biopsy, it's relatively late. And this is showing us that molecular markers are much more sensitive marker of graft injury and rejection than the biopsy. So this could give us the chance to be more proactive clinically in managing our patients. Maybe we can augment immunosuppression or send them for treatment. Sometimes if we see rejection on the biopsy at that point, it could be too late. So does this give us the opportunity to address our management of a patient? This was the Stanford group. They wanted to validate this study. So they did 5 centers, 171 patients, and they again compared cell-free DNA results to biopsy. And what did they find? Again, they found the same thing, that immediately post-transplant, you have these super high levels of cell-free DNA that go down, and you can stop the biopsy as soon as 2 weeks post-transplant. And again, they saw the same thing, cell-free DNA increases in the setting of cellular rejection and antibody-mediated rejection. And on the bottom there, you can see that with severity of graft dysfunction, so the more severe the LVEF drop, the higher the levels of cell-free DNA. And at the most important thing that they concluded was that 28 days post-transplant, the threshold of less than 0.25% had a negative predictive value for acute rejection of 99%. So we might also be getting into an era where we can know which type of rejection you have based off elevations in cell-free DNA. This is really early stuff, but cell-free DNA went up much earlier and higher in cases of AMR. And also right here, you can see that in AMR, the percentage of short cell-free DNA fragments were much higher than in cellular rejection or controls. They were actually measuring the length of the cell-free DNA fragment, and they were able to distinguish between cellular rejection and antibody-mediated rejection, which is exciting because right now there's currently no way to differentiate between the two unless you do a biopsy. This was the Dior registry. It was 24 centers who enrolled patients to assess the validity of AlloSure, which is the first clinical assay to measure cell-free DNA, and it's the one that we use here at MonteHeart. The results, again, were comparable. They showed the elevations of cell-free DNA in setting of rejection. And then most importantly, established a threshold of 0.2% with a negative predictive value of 97%. So if you have a cell-free DNA below that level of 0.2%, you have you're 97% sure that your patient doesn't have rejection. And just quickly, I want to mention the SHORE registry, which MonteHeart was a part of. It was 67 centers, 2,000 patients who underwent non-invasive testing with gene expression profiling, which is AlloMap, and donor-derived cell-free DNA, which is AlloSure. They concluded that both of the tests, using both of the tests combined, or elevations in both gene expression profiling and cell-free DNA, was better at detecting rejection. And there's going to be a lot of future analysis coming out with this data, since it's such a large population of patients. So we now know that, like, with the development of de novo DSA, cell-free DNA increases. This is really important because we often are screening for these DSAs and we don't really know what to do with them. So can cell-free DNA help us to risk stratify the de novo DSAs? So this was a Dior registry analysis. It was an ISHLT abstract, and they showed that cell-free DNA does rise in the setting of de novo DSAs. I want to show just a case of one of our patients where we applied this idea. So this is a 66-year-old male. He had a heart transplant last July. He's had no history of rejection. So we do these cell-free DNA testing monthly, and then at about 6 months, we spread it out to every 2 months. So you can see that in December and January, the patient had a negative cell-free DNA. And then in March, we had an elevation in the patient's cell-free DNA, which is above our threshold of 0.2%. And the patient did have a new de novo DSA with an MFI about 3,700. And then so we decided, since it was right near the threshold, 0.21%, we decided to repeat the AlloSure test, and it was 0.19%. So now it's a little bit below our threshold. And the patient still had the same de novo DSA, but the MFI increased a little. We did an echo on the patient. The patient had normal graft function. And we did a biopsy on the patient, and it was negative. So then from here, we repeated the AlloSure again the next month, and it was up again to 0.25%. And here we have another de novo DSA, and the MFIs are getting a little bit out of control and making us nervous. The patient's immunosuppression at this point, he was on Tacro 8 to 10 and CellCept 1500 BID. So this is leads me to my question: what would you guys do next in this patient? Would you repeat the donor-derived cell-free DNA and DSAs in a week and see if it goes up? Would you repeat the biopsy in this patient? Would you treat the patient with plasmapheresis and IVIG, or would you add prednisone to the patient's immunosuppression? Right, good. So that's what we did. We treated this patient with plasmapheresis and IVIG. The patient's DSA came down nicely, and of course, this just happened recently, so I didn't get the result of the cell-free DNA back yet, but I can tell you that it's going to go down below our threshold, and it's going to respond nicely to this. But I think the point that I'm trying to make here is that the cell-free DNA being elevated helped us to risk stratify that these DSAs are causing damage to the graft. This is a second case. This is a 43-year-old male. He was transplanted last January. He's asymptomatic and he's just undergoing routine AlloSure. So after 1 year, our program does routine AlloSure monitoring every 3 months. So you can see at his 1 year, he had a negative cell-free DNA. And then in April, he had a very high cell-free DNA at 0.89%. And this patient had no symptoms. So we had him come in for a biopsy, and he had 2 de novo DSAs and a 2R rejection with no symptoms. And he was negative for AMR. His echo was unchanged from prior, so no graft dysfunction. We decided to treat this patient with plasmapheresis and IVIG, steroids, and rituximab. And we saw a nice lowering of the DSAs here. Eventually, they disappeared. And you can see the patient's cell-free DNA reduced back down to 0.2%. So this kind of tells us that we gave this patient enough treatment, and it was working to improve and reduce the injury to the graft before the patient had any graft dysfunction, which I think is super important. So I'm going to skip this slide just for time. So how about cardiac? These are some future perspectives on the use of cell-free DNA. How about cardiac allograft vasculopathy, which is transplant coronary disease? This is one of the most common long-term complications after heart transplant. And the data on cell-free DNA and CAV is still very mixed. This was a small 65 patient study from University of Chicago, and it showed patients with elevated cell-free DNA tended to have higher incidences of CAV. But this was another study from Columbia that showed that transplant recipients with CAV on their angiogram had the same cell-free DNA levels than those without CAV. So it showed no difference in cell-free DNA for patients with CAV diagnosed on angiogram. But in myocardial PET scans with reduced myocardial blood flow, donor-derived cell-free DNA was significantly elevated. So I think we still need a lot more data on this. A lot of these patients with CAV are asymptomatic and they have normal graft function. So it would make sense that there's no injury to the graft that's causing the release of cell-free DNA. So this is like the bane of all of our existence, is elevated cell-free DNA in the absence of rejection. So we're getting a lot of false positives on patients that we're testing further out from the transplant. So this was a retrospective review of 35 patients with cell-free DNA over 0.2% in the absence of rejection. So they tried to see what's the reason that these patients' cell-free DNA is elevated in the absence of rejection. So a lot of these patients had this early post-transplant restrictive physiology or volume overload, which makes sense because being volume overload could maybe cause some injury to the graft and release the donor's DNA into the bloodstream. De novo DSAs, as I mentioned before, was a big cause of this. And then infection. So CMV, these patients had CMV, COVID, EBV, hepatitis B. I think further research is needed to evaluate, are these viruses causing injury to the graft, or why is it elevated? This was a study from Baylor, 37 patients, 12 were positive for CMV, 25 were controls, and the donor-derived cell-free DNA levels were significantly higher in patients with CMV infections compared to those without. And lastly, malignancy. So I presented on this a little bit last year, but it was more in relation to gene expression profiling. So as time goes on, as Dr. Patel said, malignancy becomes one of the leading causes of death for heart transplant recipients, and around 11% of all deaths between 1 and 5 years post-transplant are due to malignancy. And at 5 to 10 years, it accounts for almost a quarter of deaths. So there's been a lot of work and development for years on actually checking circulating tumor DNA, which is similar to cell-free DNA, but for cancer detection, where you can measure the amount of DNA released into a person's blood by dying tumor cells. And I know the Stanford group is doing a lot of work on creating assays to look at circulating tumor DNA for patients with PTLD and trying to manage the risk before the patients develop malignancy. I think right now at Montefiore, the way we're using cell-free DNA in our patients with cancer is that we really look to try to reduce the amount of immunosuppression that they're on, and then we use the cell-free DNA to monitor them to make sure that they're not having rejection. So think a lot more work still needs to be done on this. So in conclusion, donor-derived cell-free DNA is a great tool for non-invasive monitoring of acute rejection. And in the future, we may be able to use it to differentiate between AMR and cellular rejection, detect CAB, detect infections, and mitigate the immune response in the setting of malignancy. Thank you.
Thank you, Christiana. That was incredible. And it's really our NPs and coordinators really, you know, they're also experienced now that they basically manage the patients. At least my patients, I just do what they say, and my patients do well. Great. We're going to talk quickly about two technologies that were mentioned earlier, and then we're going to have our final lecture by Scott Silvestri. So Shivank, I think who's up next? Shivank, yes. Shivank's going to talk to us about transmedics and hope.
Hi. Good afternoon, everyone. We're running a little late. I'm Shivank Madan, assistant professor at Montefiore Medical Center. And today I'll be talking to you about some exciting new technologies that have come into the field of heart transplantation, transmedics, and hypothermic oxygenated machine perfusion, or HOPE. I have no conflict of interest to disclose, but I will be discussing investigational use of medical devices. So let's quickly do a quick pulse check if you're paying attention to the talk by Dr. Patel. Of every 100 donors available for heart transplantation, approximately how many are eventually accepted? Your options are 30 out of 100, 50, 60, or 70. I'll give it a few seconds. Okay, we have more than 20 responses. Okay, so good. I think everyone was paying attention to the talks today. So as highlighted earlier by Dr. Patel, that the number of donors has gone up over the past few decades, but the number of hearts that are transplanted have lagged behind a lot, leading to this huge gap in the use of donors. In fact, the donor utilization rates over the past few decades have gone down from what it used to be 45% in the mid-90s to 30% in the more recent era. So eventually, yeah, in the current era, about 30 out of 100 donors are accepted and 70 are rejected for various reasons. Now, this was talking about the standard donor heart transport. We are always running against time. So this was an article published in Annals of Thoracic Surgery in 1978, where basically the authors described that on May 9, 1977, a donor heart became available in a city 1,000 kilometers from Richmond, describing simultaneous accession of the donor heart and kidneys. And then the donor heart was immersed in a 4-degree solution of saline, packed in a plastic bag, and transported via a chartered jet to the hospital. And then this was supposed to be, or this was revolutionary at the time. The authors go on to describe 6 adult heart transplantation with distant procurement, with a mean distance travel of about 480 miles. So what were we doing? 40 years later, in the year 2020, how are we transporting donor hearts? Again, similar. Basically, the donor hearts were being transported in an ice cooler containing ice, a plastic bag, with the preservation fluid containing the donor organ. So over a period of 40 years, nothing changed much. Now, this transporting donors' organs like this have advantages. It's a simple, cheap, easily reproducible, but there are problems. This is associated with time-dependent ischemia, reperfusion injury, cold injury. You can get barotrauma when you're transporting organs like this, and it puts limitations to organ sharing. Now, this was a nice article that summarized what's been going on, looking at recipient mortality over a period of 40 years from 1988 to 2018. And basically, what the authors showed using the ISHLT registry data was that the recipient mortality increased beyond a cold ischemic time of 4 hours and a donor age of 40 years. So then that brings us to the concept, what if donor hearts could be physiologically perfused during transport? This is, let's see if I say the name correctly, J.J. Lee Gallois, who was a French physician and a physiologist. He wrote a book, Experiments on the Principle of Life, in the year 1812, that was initially published in French and then later translated into English. And there is a paragraph in the book that I want to highlight. He goes on to describe that if one could substitute for the heart a kind of injection for arterial blood, either natural or artificially made, one would succeed easily in maintaining alive indefinitely any part of the body whatsoever. So really, I think it goes on to describe the first concept. And now 2 centuries later, we finally got that device. This is, as Dr. Patel showed in his previous talk, this is the TransMedics organ care systems, the OCS heart, which is a normothermic ex vivo perfusion system for donor hearts that can allow continuous perfusion for donor organs at a near physiological state, which minimizes the organ ischemia that I described earlier. It has an aortic line through which you can perfuse the blood into the aorta and perfuse the coronaries, and has a pulmonary artery line to drain the blood. From the right side, there's an LV vent, a blood reservoir, an oxygenator, and a monitor. And there are several things that you can monitor when the donor hearts are being transported on the system. You can measure the mean aortic pressure, which is usually maintained between 60 to 90. You can check the flow through the coronaries, the flow through the aorta, what is the oxygen saturation of the blood, what is the hematocrit. You can check and control the blood temperature. You can measure arterial and venous lactate. And you can even pace the heart if you want to. So really perfusing the heart at a near physiological state when it is out of the body. So then coming back to that question that I showed you earlier, that recipient mortality increases when the ischemia time goes beyond 4 hours. So can ex vivo machine perfusion break the 4-hour ischemic barrier? Now, this was, most of us who work in the field of transplant know this trial. The PROCEED-2 trial, which involved 130 patients randomized to hearts that were transported either via the organ care system versus whole static storage. And the trial showed good outcomes using TransMedics OCS. The primary endpoint of 30-day patient and graft survival was similar. But I think the more interesting part, which I feel that we probably did not realize at the time, was that in the organ care system, the out-of-body perfusion time was longer at 324, like beyond 5 hours, compared to just a little over 3 hours in the static cold storage, and thereby breaking the 4-hour distance. And I think it was interesting that in this paper, they did not report the mean distance traveled between the two groups. And it was thought that the increase in out-of-body time was because probably the teams were more relaxed when they used the OCS system. So then the next question is, can ex vivo machine perfusion improve utilization of marginal donor hearts? Now, marginal donor hearts are hearts that are, there is no clear definition of how you describe marginal donors, but these are the hearts that may be rejected by various programs. So this is the OCS heart expand trial, again involving the TransMedics OCS system, where basically the trial involved what we call extended criteria or marginal donors, defining as either a cross-clamp time of more than 4 hours, or either more than 2 hours plus any of the other risk factors. And then they were able to successfully transplant 150 out of 173 hearts on the OCS. Interestingly, how they showed like the number of hearts, as you can see in the number of refusals in the OCS arm, which is shown in with the red bar, was about 51 compared to 17 of the standard group. So these hearts were more likely to be refused by the transplant programs, fitting to the definition of the extended criteria. Again, the trial showed that these hearts can be safely transplanted with good 30-day outcomes. But what about the role of ex vivo machine perfusion in expanding heart transplantation from DCD donors? I think that was probably one of the biggest contributions of this technology. Now, this is a paper by where Dr. Yodi is a senior author from last year. We're basically revisiting what is the so donation after circulatory death involves various steps. First, there is a donor that does not meet the brain death criteria. The support is withdrawn. There is agonal phase, circulatory arrest, and finally, there is a declaration of death. The challenge that has been for us historically has been that how do you overcome the problem of being unable to reanimate these DCD donor hearts? That once the donor hearts have stopped, how do you reanimate and how you do functional assessment of such hearts? Well, ex vivo machine perfusion allowed that, and now we know that we can do it using normothermic reperfusion as well. So this is the paper that came out in 2015, which was, I think, the first proof of concept of distant procurement, reanimation, and transplantation of DCD donor hearts, where the group from St. Vincent's Hospital in Sydney, Australia, described successful transplantation of 3 DCD donor hearts that were distantly procured and transported via OCS with good outcomes. This is data from our paper that Dr. Patel showed earlier, basically where we showed encouraging early outcomes of DCD heart transplantations in the US using both machine perfusion and NRP. This is the TransMedics OCS DCD heart trial with the 90 patients in the DCD heart transplantation using the TransMedics OCS and the DVD heart transplantation with the static cold storage, and really a pivotal trial that showed that this technology can be used and scaled in the US. Finally, earlier this year, we saw data from the TransMedics Organ Care Registry, Heart Perfusion Registry, that reported good outcomes with the OCS DVD heart transplantations and the OCS DCD heart transplantation when compared to the standard cold storage technique for DVD that I previously showed. Now, so far we looked at the TransMedics OCS, which is a normothermic ex vivo machine perfusion for donor hearts. Now let's change gears. What about hypothermic oxygenated machine perfusion for donor hearts? This is the HOPE or hypothermic oxygenated machine perfusion, which was also referred to as the non-ischemic heart preservation in the earlier preclinical in the animal models. And basically, in this device, you have a donor heart chamber. There is a perfusion pump, and the cannulation is more simpler. There is an aortic cannula that cannulates the donor aorta, and then the donor heart is put in the preservation organ chamber, and you're perfusing the donor aorta to perfuse the coronary in a continuous manner. You will note that the difference from the TransMedics is there is no pulsating heart. There is no pulmonary artery cannula collecting the blood. So this is much more simpler. It allows perfusion at a hypothermic 8 degrees Celsius, which is oxygenated, supplement with nutrients and hormones. It includes erythrocytes from the blood bank, not from the donor. And the mean aortic pressure is much lower as compared to the transmedics at about 20. The coronary perfusion flow is lower, so I feel it's a more gentle, slow, continuous perfusion. This is the phase 2 study of the non-ischemic heart preservation, which is the same thing as HOPE, where the authors from the Skane University Hospital, Sweden, went on to describe the 6 successful heart transplantations using this technology in comparison to the static cold storage. And eventually, Ex Vivo, the company, bought the patent from this group. And I think more interestingly, what they showed was that now this figure looks at the CKMB levels after ending the preservation with the Ex Vivo machine. And it shows that the hearts that were perfused using the NIHP technology had lower CKMB levels, leakage, after the end of the preservation, indicating a lower injury to the donor heart. This is a trial that came out last year, hypothermic oxygenated perfusion in heart transplantation, or NIHP trial, where basically the patients were randomized to receive hearts either through the HOPE perfusion system or the static cold storage. The HOPE group had better outcomes, but it did not reach statistical significance. And importantly, what the authors went on to show was that the rates of severe PGD was much lower in the HOPE cohort compared to the static cold storage. So again, indicating to what I showed in the previous slide, that probably there is less myocardial injury that's happening at the time of transport. This is data that we presented at ISHLT and should be coming out soon, looking at the overall trend in use of ex vivo machine perfusion for DBD heart transplantation in the US. And this shows that the usage has gone up from about 1% in early 2020 to about now over 10% in the early part of 2024. The limitation of this is that this includes both the Transmedics OCS and the HOPE technology. So we are not able to distinguish between the two, but there is a slow and gradual uptick for DBD. So so these are exciting new technologies that have made the field of heart transplantation exciting, but there are a few unanswered questions and challenges that still remain in machine perfusion. We don't know. We don't have any clinical data to compare which is better, normothermic versus hypothermic, which is a better perfusion. Does pulsatile or non-pulsatile flow during perfusion, does it matter? We don't know that. What about how do you reduce the myocardial edema? Are there any strategies? When you perfuse donor hearts on these ex vivo machine perfusion systems, over time, they tend to develop myocardial edema. And we really don't understand how to mitigate and reduce this to increase the perfusion times. Is lactate the best biomarker? We don't know that. There is a lot of, there is some animal model data that mitochondrial flamin mononucleotide may be a better marker of mitochondrial and tissue injury for these hearts. So should we be checking for other things? And is machine perfusion better than a controlled hypothermic storage? I know I showed you earlier that ice storage, ice cooler box is not up to date and is not the latest technology. But now we have Paragonix device, which is controlled hypothermia. Is it as good as the machine perfusion? We don't know that. And Dr. Saeed, in the talk following this, is probably going to try to convince you that Paragonix is as good, if not better, than ex vivo machine perfusion system. So with that, thank you.
Saeed is going to walk us through the Sherpa pack, which is the device that we use the most.
Thanks, Ron. I think it's a good lead into this talk. Okay, so a couple of questions before we get into the Sherpa pack. So what is the longest reported ischemic time for successful heart transplantation utilizing controlled hypothermic preservation with the Sherpa pack thus far? 5 hours, Siobhan talked about breaking that 4-hour barrier. Now we're beyond it. So 6 hours, 7 hours, or 9 hours. And this is always moving, but this time I'm going to pause it there. So, wow, 9 hours. Well, we're not quite, at least reportedly at 9 hours yet. You know, the report so far is at 7 hours. The second question is, what percentage of heart transplant programs in the US are using controlled hypothermic preservation, i.e. Sherpa pack? Is it just about 5 to 10% of the programs, 20 to 30%, 31 to 40, or close to half? Oh, it's a little bit more than the top one there. Now we're nearly half the program. So a lot of programs are using this device that I'm going to talk about. So, you know, what's the issue here? The bad guy here is really just primary graft PGD, primary graft dysfunction. This is the problem we're all worried about, as Snehal had mentioned in his talk. We don't want after transplant for this to happen because this actually portends a poor prognosis afterwards. There's very few things that hurt patients after transplantation in the first year, and PGD is one of them. We don't want this to occur. And this is data from the UNOS database when they started capturing PGD as a variable the last couple of years. So now this is a lot of patients, not just single center stuff. You can see PGD is definitely a risk factor for survival. And what are the predictors of PGD? So you can go there. A lot of these things are not modifiable. The one thing at the bottom is ischemic time. As we reach beyond, you know, getting donor organs from further away, we're going to increase the ischemic time. And ischemic time is the factor that correlates to PGD. So what are the ways we can keep the donor organ safe while it is ischemic and being transferred over for transplantation? So while it's stored, you know, and is ischemic, the usual way of storage, I know Siobhan just talked about the normothermic approaches. The usual way has been this cold static storage in ice. But the issue is when the organ is on ice, the temperature is actually not stable. This is the oldest study I found where they measured temperature in the donor heart every few minutes. And you can see, although we want to target the temperature around 4 to 10 Celsius, it doesn't work that way. On ice, you know, the temperature fluctuates, and you can see it actually drops over time as it's measured in the right ventricle or in the septum. And a lot of injury starts to happen. You can see the electron microscope there, microscopy at time 0 versus just at 2 hours. There's myocyte swelling and edema starting, partially related to this fluctuance in temperature. So enter the Paragonix device, which is shown there, the controlled hypothermic preservation device, and some of these were in the room back there. The industry was. So this has a feature of having just controlling that temperature, right? So it doesn't drop while the heart's preserved and being transferred over for transplantation. And also, it's not in direct contact with ice. So that contact itself could lead to damage. This is as opposed to the cooler there where the heart's sitting in and the temperature is not controlled, and there is also a risk for trauma. So this is the Paragonix device. The other two devices Siobhan discussed about, I'm not going to go into those, he already did. So again, the main benefits of this is temperature is controlled and there's no direct contact with ice. As this device has been rolled out, there's the Guardian registry, which keeps track of how it's used and the characteristics and the outcomes. And Dr. Silvestri is part of the database. I know he's here. And Dave D'Alessandro as well has published a lot of these papers. So I was just going to show some of the results from the registry and how we know this device is actually helping. So this was a comparison of two groups, ICS, which is just ice storage, and then the static controlled temperature storage, the Paragonix device. So you can see between the two groups, this is a registry, but overall there's fair matching, except in the Sherpa pack Paragonix column, there's actually a greater ischemic time, and the distance is also greater as well. And you can see now on the outcome table, which is table 2 there, that there is a decrease in PGD, especially the severe form of it, right? It's 10% versus 5%. So 50% numeric decrease in severe PGD, which is remarkable. given that the ischemic time was actually longer. Now, this was a multivariable analysis here, which shows the same thing after controlling for many other factors. The only thing that shows improvement in severe PGD was the association with use of the Paragonix device versus ICE. This data at the bottom didn't show survival improvement yet. It just showed that improvement in severe PGD. But as further cases have been collected, this was just presented at the ISHLT meeting a couple of months ago. With the greater sample sizes, now we're beginning to see improvements in survival at an early period. So, again, if PGD is less, so eventually survival will also be better. And the mechanisms of better survival were related to cardiac reduction in cardiac complications. Another paper was published with the use of this device in patients that have LVAD explantation. These transplantations tend to be of even greater risk for having PGD. There's explant of the LVAD, just a greater ischemic time. And so what happens when that, just in those subset of patients, so similarly, with a similar finding, you can see the two groups with the cold storage and Sherpa pack, and these are just LVAD patients. And again, we see the outcomes table there in table 2, that severe PGD is reduced in the patients that had LVAD explants. Now, the magnitude of reduction is even greater. It's 14% in the ICE versus 5.4% with the use of Sherpa pack. The registry also looked at, this was a recent paper that was published from it in a subset of patients that were these extended criteria donors that Shivank had mentioned. So these are donors that are considered marginal, so overall at greater risk for having PGD. And these are the different characteristics of these donors. You can see the proportion of these characteristics were greater with the Sherpa pack, but this was just including these higher risk donors. And you can see even in this subset, the risk of severe PGD is less with use of the Sherpa pack. It's 13.9 versus 6.2. So again, in a marginal donor subset, the Sherpa pack tends to produce better results as far as severe PGD. This was also stayed consistent after the control for other factors in a multivariate analysis. Finally, this was a new study. I thought it was interesting to get into the mechanism of how this could be happening. It's not, some of it is just the common sense. The temperature is controlled. There's no, the temperature is stabilized. There's no direct injury. But these authors, they actually conducted this randomized study. So the patients were randomized, the donors, to get coli storage or Sherpa pack usage. And they had biopsied the RV prior to transplantation. This is a proteomic analysis, which just shows that with usage of this device, there is different protein expression in the donor heart. So a lot of different molecular mechanisms are actually being changed through this methodology. And the authors then went on to further show what pathways are activated. And there are several protective pathways as far as myocyte injury that are more expressed in the Sherpa pack recipients versus cold storage. This was the question I had asked earlier, what is the longest reported time utilizing the Sherpa pack? And this was actually a 3,000-mile journey, a 7-hour ischemic time. The temperature graph there, which is data that's put out by the device, you can see how the temperature is maintained, right? So this is different from that early study, which measured the different temperature in ice, where the temperature just kept dropping. But in this device, over this 7-hour period, the temperature is well controlled and flat. And after transplant, the authors showed that there was a rapid reduction in inotropic use consistent with no PGD. This is another study which showed now in DCD, procured through an NRP technique, not the transmatic device, but NRP, in a situation where the functional warm ischemia time, which we really don't want to be more than 30 minutes, but in this case, it was extended. It was at 43 minutes, but after NRP procurement, the donor organ was then stored in the Sherpa pack and eventually was transplanted and had no PGD. So this is just some evidence that, as we go beyond the boundaries of NRP procurement, Sherpa pack may allow us to do that. Early evidence. I'm not going to get too much into these authors actually did not utilize this donor organ after procurement, but they were actually able to put it in the device and get a coronary CTA, which we cannot do for DCD donors sometimes. So there's some evidence here that imaging can be done afterwards. So in conclusion, controlled hypothermic storage after donor heart is associated with less PGD, as we saw with those studies, and better survival after heart transplantation. And it may allow for expansion of the donor pool by consideration of organs with longer ischemic time and also these marginal donors. I think more studies are needed, as Shivank was also pointing out, which strategy is more optimal and would have better outcomes. And whether, this Sherpa pack can just be used in even a DCD, DPP approach rather than putting it on machine perfusion afterwards. So I know a lot of the experts are here and I'd like to see what their thoughts are on that. Thank you so much.
Great. Thank you, Omar. We are ready for our final speaker, Scott Silvestri, who is a heart surgeon, is currently in Tucson, Arizona, but has been in the field of transplantation and mechanical support for the past, I'm going to say, no offense, 30 years, like me, 25 to 30 years. And is really one of the leaders. He's on the board of the International Society of Heart and Lung Transplantation. And I've known Scott for a long time, so does Danny. But we were at a meeting recently, and we started to talk about DCD, over dinner, I guess. And there were so many insights from that discussion that I said, please, if you can join us from MonteHeart and give us your thoughts, your insights, all your experience, and some professional work that he's doing in the arena that's not direct surgery, that would be amazing. And we're very happy that you said yes. And sorry, a little bit delayed, but I'm going to say there are maybe 50, 60 people in here, and I just checked 107 on Zoom. Wow. So you do have an audience. Thank you. Perfect.
Thank you. I recognize I'm the only thing between you and the end, so we'll keep going here. Let's see how this works. So here's my slides to go here, and it's a privilege to be here. This is a phenomenal seminar and symposium, and it's a pleasure to be associated with Dr. Yordi and Dr. Goldstein and the staff here to see what you've done. My disclosures, aside from that, like I think Dr. Sims, I am a Mets fan as well, and I apologize. I was born in the Bronx, but my father was a Dodger fan, and so we became Met fans, and I was at all the World Series so far that they've been in and won. So here's a good question. There aren't that many. It's not like the Yankees. So what is the most important information you would want when you are evaluating a DCD heart for transplantation, especially one using OCS NRP? So here are the things. Let's give you a little bit of time to see what comes out of this. Let's see. I don't know how to tell what they're.
Click next.
Click next. All the above. Yes, so all the above. I think all those factors are certainly important. And some of the most important things to the surgeons on this, aside from the quality of the organ, are will the donor pass? And is it worth sending a team or paying for a team to go because of the logistics? And then, of course, that impacts everybody on the service and the operating room because you need a team to come in. And the logistics of it are that you're going to burn your team with this if it's a great heart. And sometimes the really, really great hearts are in patients who will not become donors because they simply won't pass in the time. So we've seen a slide or a version like this before, and that we know transplants have gone up. Interestingly, this is the inflection point. I like to say that the inflection point occurred when I was the chair for the heart subcommittee at UNOS, and we changed the allocation system. As a penalty for being involved in that process, I get sent nearly every manuscript to review about the negative implications of the policy change, and I take my punishment by reviewing them all and going there. But as also noted, the DCD count has gone up and the door has been opened to DCD. And that's, I think, very, very important. The pool has gotten deeper. We can see that this has opened up a tremendous possibility. And as others have said, the enabling technology that we've been given has allowed a lot of creativity. And unfortunately, the data hasn't really caught up with the creativity yet, but we're going to get there, I think, pretty soon. So here we go. What is your belief regarding the success of heart transplant using DCD with machine perfusion compared to NRP? So this is a pre-question. All DCD hearts with machine perfusion require equal or better outcomes than NRP. DCD hearts with machine perfusion provide worse outcomes. Insufficient evidence. I do not believe that DCD hearts should be used for heart transplantation. So I'll click ahead. I see there are 3, 4. Now I see where to look, where we're looking. Again, this goes back to my quote, when we have data, let's look at data. When we're going to go with opinions, let's go with mine. All right, so we have a number of people answering, and insufficient to determine a clear comparison. And that's probably true if you want to be strict about what information there is there. And part of the problem is we didn't collect the data from the beginning, and it's a cautionary tale to the amazingly intelligent young physicians on this team and other teams that often we approach information and new processes and our old systems are insufficient to capture. I was on the NIH DCD and Xeno working group, and we made a list of the variables we thought needed to be captured. And interestingly, still, UNOS is not capturing all of the variables. As we talked in the side, there are very smart people who are going and figuring out back ways to put the groups into different categories to then calculate it. And probably right now, in terms of knowing whether it's NRP, OCS, in terms of the numbers, the best way is to look at the Transmedics annual report or report of earnings, because they will give you accurately, we believe, that they will give you accurately the number of heart DCDs that they're doing. The distribution has changed dramatically. Again, this is data that has been presented, 4,572 hearts transplanted in 2024, which was a negligible change from 2023. And you can see that the DBD hearts are actually going down, despite the fact we have a better understanding and clear clinical leadership as to which hearts can be used. There's a risk aversion which persists, which is incongruent risk aversion on the brain dead side with the risk love that we have on the DCD side, or the idea that we're going to take hearts from Tampa to Anchorage, Alaska, or if you're Pascal or Prince of La PTA, you take 5 hearts from the Caribbean and transplant them in Paris, right? It's a French colony, so you can use it. But the point is that our behavior isn't always congruent in 2 different domains. And this is a little bit for program leaders. There are 2 aspects to consider briefly in this talk, and that's the impact on heart transplant programs with the first mover advantage and the established market, and what happens to second movers, third movers, and late adapters, and also the opportunity. So what happens to the total market and the established market with disruptive technology? I like to think outside the box and outside of just medicine, and you can see that if you're first mover, you have a private party, and everybody in the original trial, when I was in Florida, we came up to Long Island and took a heart that was 18-year-old blood type O in a 6-foot person from Florida, from New York, Long Island to Florida. Now, when has that ever happened in the history of heart transplant, that a beautiful 18-year-old heart? And quite frankly, there weren't enough centers in the trial that were interested and could go there. And so we wound up getting the heart. That was a first mover advantage. Now, with approximately 90 of the 147 transplant centers in the United States doing DCD, that would never happen again. You probably are not going to New Jersey for a blood type O DCD 18-year-old at 6 foot at this point, because the competition the market has shifted. And the opportunity when you look at these technologies, or you look at access to these technologies, because you don't always have to acquire the technology, you have to acquire access, whether you use Uber Transmedics or Uber Silvestri or whatever you use to get this. Access is important. Timing when it fits for your program and your program needs is important, because there's no reason that patients in the Bronx or in Staten Island or Long Island shouldn't have the same advantage that patients have in New Jersey or in Connecticut or Boston for that matter. And so it's important. And of course, the use case for this is distance, marginal donor use in DCD, and we'll talk about DCD. We've gone over these technologies, you've seen it, and thankfully you've also seen the ex vivo pump, which is the latest technology, of course, that's currently in trial in the United States, and I'm one of the investigators. And you can see that it's a very simple, it has a cartridge, it has solutions, it has proprietary solutions, you can handle it with one. Here's an NRP case that we did with Duke, where we put the heart on ex vivo after NRP, and you can see this is a fellow who did it with me, and we put it on and connected it, and it's very simple to use. You don't need a team from the company, you don't need a team for anything, you don't need 4 perfusionists and a bigger plane. And so I think that ultimately, if these are equivalent technology, and I believe it will be, you'll see that this pump becomes very much a significant part of the landscape of transplant moving forward with the information. There is something that's really important about this that we'll talk about in a minute. You've seen some of this data, and I won't go over this with the HOPE study, with the initial data showing that the outcomes are at least equivalent, with some aspects which are improved and statistically significant in small aspects, inotropes and others, and survival not statistically different, but meaningfully possibly different. So I'll go to this. When evaluating patients' eligibility for heart transplant from the wait list, what factors should be prioritized in deciding whether to accept a DCD heart or NRP heart? And so here are some of the factors that you could look at. By the way, do you list all of your patients for DCD here? And do you consent them separately? No. Do you consent them separately? No. So you believe that they're equivalent based on the data and data. Yeah. So there's an interesting case in Florida, which you may or may not know about TransMedics. A patient from Florida was transplanted in Minnesota and with the OCS, and they weren't consented. And this is going to be settled by the courts, not by the medical literature. And you can see all the above. And I think most people would agree that all those factors should be placed in there. Interestingly, Dave Keserowski's DCD paper, which was presented at the AATS, not this year, but last year, the advantage in the blood type and level of patients were blood type B and status 4 patients. It was not in blood type O, and it was not status 1 or 2, because those patients get offers anyway, and the competition, the market, if you will, is very competitive for that.
So just to make a point, we used to consent the patient specifically.
Yes.
But with the data that came out, now that the retail is equivalent, no longer for that, just for the audience.
Well, as we were talking about, you were in the car, we were talking about this and said the consent includes, risk benefits, alternatives, options, and other imponderables, right? And that falls under the other imponderables sort of conversation, but I think it's right. And looking at the comparison of DBD, brain dead donors versus DCD, it's a different process. And the times are slightly different. And so when we talk about these, we talk about warm ischemia and other factors. Just because we write times on the board and we put them into UNOS doesn't mean they represent what we think they represent, right? In The Princess Bride, I don't think you know what that really means. And that is very, very true in this process. And so when we talk about DCD donation, fortunately, we've reviewed some of these factors. We have agonal time, we have withdrawal time, we have functional warm ischemic time, and we have different times that are impactful and we're measuring, but they're not always measured the same. For example, functional warm ischemic time can be defined as a systolic blood pressure less than 80 by some centers, systolic blood pressure less than 50, other centers, and a saturation less than 80, maybe. And by the way, the SATs are never accurate in the withdrawal process because usually the donor becomes somewhat vasoconstricted and the SATs disappear or go to zero. I have watched a patient remain a patient and not pass with SATs of 0 through the whole 2-hour process of waiting and a blood pressure of 100 or a blood pressure of 60. So a lot of this data, you have to be careful when we analyze it because a lot of it is garbage and it just is filling the forms and going from there. So we still don't know what we don't know, and that's important because, again, we're still not capturing all this information, although there are new forms for here, and you can see. And so there's the different interval. There's the differences in that, and I think we're going to get some really good data comparing NRP with OCS because I think we'll have some metabolic information on the hearts directly in some new studies that are going to be performed, looking at lactates, plateau lactates, and other metabolic parameters of recovery on NRP. Because I can't even tell you how long a patient should be on NRP, how long a heart should be resuscitated, and when we should come off. The Vanderbilt criteria is 30 minutes, assess and make a decision. Other places go 45 minutes. Sometimes they go back on, sometimes they come off. So we don't even know. We don't even have lactates or metabolic data to say that the heart is better after 30 or not. Or at what level of lactate extraction on a beating heart would you want to stop reperfusing? If you knew that this heart after 35 minutes with, let's say, a catheter in the coronary sinus, that the lactate had gone down to under 2 and stayed there, you might say that the heart is sufficiently resuscitated and you can make a decision. Or if the lactate is still trending down, you would want to keep going like the liver. We don't even know what we're supposed to be looking at, which is really important because when we talk about assessment of these hearts, we have criteria. And in general, by the way, we took a 63-year-old heart the other day on DCD, which I believe is the oldest heart out there. It was transplanted in a metropolitan New York area hospital, and the patient did very well. So far, has been discharged after 12 days in the hospital. A greater metropolitan New York area hospital, I'll say that, on maybe the other side of the river. But the assessment is important. When we do a DCD, and I'll show you some images, we bring an echo, we can put a swan in, we can measure mixed venous SATs. Yuli taught us that if the cardiac index in some of these borderlines is high, right? And I quote this paper all the time, that we know that the outcome is generally good. Now, is that generalizable to these patients? Maybe, maybe not, but we do know that when the index is high, that the hearts are performing better, and having a high mixed venous in an NRP at 30 minutes with a saturation with the PA can be very helpful, as well as putting a catheter into the PA and measuring PA pressures and seeing what the RV is doing. We do a lot of these things when the lung team is looking at lungs, but so it's easy to convert a DCD heart using echo and parameters into a DBD assessment, which is something we're all comfortable with. If I give you PA pressures, a cardiac output, and I give you a mid-PAP level EF, you'll feel comfortable making a decision. Again, because on one of my jobs, we're providing this service to other transplant centers. I'm not telling people what to do, but I'm giving them the data so they feel comfortable. And with the technology we have, the whole group can look at it and make a decision. It's not just the surgeon at 2 o'clock in the morning. It can be everybody, including the NPs, if they want to be on those as well. But the other part is when you go for the ex situ hearts and the direct procurements with either OCS or ex vivo, you're relying on biomarkers. And as has been pointed out appropriately, we don't really know what the biomarkers mean. For those of us who were in the OCS trial, they said, well, we want to extract lactate. Okay, but then we want the lactate to be lower than 5 or 4. But then someone said it doesn't really matter. And I don't know what to do with these hearts when they come back. I don't know what to do with lactate. I don't know what the prognosis is. If you talk to the first author on all these papers, who's a friend of mine, he says, I ignore the lactates. I'm like, well, what do you do? He goes, I kind of look at the heart. I'm like, I'll show you that. So this is a DCD, and then you can see this is off of bypass. You can see that the donor has been cannulated and resuscitated. And I think most of us would say that that heart looked pretty good. Let's see if I get that to play again. That you can look at the heart, and the surgeons are used to visually inspecting the hearts. And this is a typical sort of images you might get on a secure. And here's our echo probe. We're being a transesophageal echo with us everywhere. If we don't have that, we can put a transthoracic, and we can fill the pericardial cavity with saline. We can put a transthoracic probe on the heart and give you looks at that. And then you can see the hemodynamics. This one is a little bit tachycardic. And you can see here, but you get a good view, and you would say that this heart is moving well, right? This heart is moving well. And again, so I am not an echocardiographer like my brother. And so you only get so many views. I can only get my team as surgeons to give you 2 or 3 views at the most. And then you can see there's another one over here, looking at the hemodynamics first, or at least the blood pressure and the heart rate, off of bypass, off of ECMO, and then looking at the heart down at the bottom, and ideally we get all these views into one so people can look at it, and you get an idea of whether a tachycardia is reasonable or not. I would say that what we generally like is we like really angry hearts, right? I don't know if you've ever been out there, the hearts that are really vigorous and they look angry. So the tachycardia doesn't bother me. And I think certainly, Danny, you would use that heart, right? That's a heart that you would take all day. Like you show that heart to someone, they're like, okay, we accept it. Like, don't you want to know the hemodynamics? They go, oh, we don't care. Just bring the heart. When are you going to cross clamp? We can start, right? And you can see what the heart looks like with our crappy echo machine. I think we got this on eBay. I'm not sure, but we actually have a couple of these. And then so also, look, it's not all roses. This was a patient we did the other day where a colleague of mine asked us to go, and we did it, and they actually backed out after 1 hour of agonal time and 30 minutes of agonal time. So this was 45 minutes, but we still went on because the other organs were going to be used, and we wanted to see if anyone would want the heart. And interestingly, it was 5 minutes from the standoff from incision to reperfusion. And there was a 2-minute standoff. I think it was Louisiana. So the total time, the agonal warm ischemic time was 7 minutes. And this is what the heart looked like. And I don't think anyone would want that heart, right? I don't think anyone would want that heart, even after we cardioverted and tried to resuscitate for a while. That heart just didn't resuscitate. And again, we just don't know. And so in the beginning, we were just obsessed with getting on ECMO as quickly as possible, because we thought, the Spanish data said that if you go beyond 10 minutes, you start to get apoptosis. And a phenomenal study. I was actually the editor for the journal that brought it out. I was very proud of that study. We've cited it and used it, but we don't know. So then again, so we get back to the OCS for DCD, and these are DCD OCS. And you can see that, and you guys have done this, that looks like a pretty good heart, right? If you get that video from Transmedics or your team, and you get that heart, you say, that looks pretty good. It has pacer, but it's not being paced and it looks good. And then 4 hours after perfusion, they show up in your operating room and this is what it looks like. And I have to tell you, receiving that heart is a very lonely feeling. Because, all of the excitement and all of the people who've been on the chain for the last 12 hours to help you make that decision, and now you're going to put this heart in. Would you use that heart? You say no.
Sometimes you're stuck if you know.
Well, sometimes you're really stuck.
Yeah.
Would you advocate using that? I mean, it just looks terrible, doesn't it?
It'll probably recover on ECMO for 48 hours.
Yeah, it'll probably recover on ECMO. It'll probably recover on, I just want to say that to you, Nose. Well, we thought it would recover for that. So the assessment, again, is what we've talked about is biomarker-based triage, and we don't really have the data yet. Although there are, as suggested, there are some markers which are promising and I think will be helpful, but we just don't know yet. And that's, I like to quote David McGiffin, the Australian who was at Alabama for the longest time. He's like, mate, we just don't know. We just don't know. And then ischemia reperfusion injury mitigation. There are pharmacologic agents, and they talked about one at Budapest at Semmelweis about some experiments that they were doing with PDE inhibitors and others, hypothermic flush, antioxidant cocktails. The possibilities are endless. The problem is, if you've ever gone to a store where they have 1,000 type of jeans and you just need one pair of jeans, there's too many choices. Which one do you pick? And how do you pick and how do you know which one it's going to look? And so I usually just turn to my wife and say, pick something out, please. And so we know that the data on this, and this is the data from the original, that DCD in general has equivalent survival, but has challenges in terms of PGD, but the PGD does not correlate necessarily. But ironically, again, looking at the trial, patients who had PGD with OCS DCD were status 3s and 4s. They weren't the sickest patients, which was fascinating to see. So we've gone over this. Wow, this is not projecting as I would like. So the question is, what's important? This is, let's see if this one, so not projecting well. So I will have to just talk through this. Data from Vanderbilt, which was presented at ISHLT, which Brian Lima was kind enough to share with me for this talk, basically showed that what we thought about the ischemic time, the functional warm ischemic time, shouldn't be more than 30 minutes, which was classical thinking, actually turns out to be the agonal warm ischemic time of 10 minutes as a cutoff is a better discriminator for PGD in these settings. And that when you had a longer functional warm ischemic time of 30 minutes or under, if you had less than 10 minutes of agonal warm ischemic time, the PGD rate was relatively the same statistically. But the minute you go above 10 minutes of agonal time, that's time from death, time of death to reperfusion, that time, it goes up dramatically when your functional warm ischemic time is greater than 30 minutes, but it also goes up stepwise for those under 30 minutes. So that's the discriminating factor. So if it takes too long to get on either OCS or NRP, you should use that heart with caution, especially if there's other information such as non-extracting of lactate, or the heart didn't perk up well, despite the fact that it's a young donor heart. And then when you layer on other comorbidities, a 48-year-old heart or a thick heart or an older heart, it's probably best to walk away from those in the absence of other information. And this is an area of evolving evidence. And I would pay attention to Brian Lima's work with Asha and the Vanderbilt team, because they have the largest number of patients and they have the granular data, which is helping us understand what decisions to make. And then lastly, you can see this was a multi-center trial, multi-centered registry group looking at comparison of DCD hearts, 500 NRP versus DPP. And we can see that the numbers are numerically different, but not statistically different. And I think that with more information, we will see it is likely, in my opinion, that TA-NRP will work out compared to OCS. And we don't know where ex vivo layers in this. And that we can see that these, not only does survival have a tendency, but there's an increased use of MCS ECMO in these patients as well. And I think that that's coming out. I'm going to leave you with this, the idea. So we talked about HOPE, but the HOPE trial and the ex vivo, and now there are 5 patients that had ex vivo for DCD for direct procurement. So now this is more analogous to TransMedics direct procurement as opposed to NRP. But with the ex vivo device, 5 patients, none of the patients died of cardiac graft function. There were 5 Four of them survived. 5 of them had cardiac survival. 1 of them had a complication unrelated to the graft-to-graft function and died. But again, this is data which is evolving. This data was in the is in the U.S. trial and somehow was agreed to be presented separately to this. And you can see, and then lastly, the question of less cold. So now we have intentional cooling, that is the Sherpa pack, and the question of what's the right temperature. In the Guardian database, there is no real difference between the hearts which were accidentally or accidentally on purpose at 10 degrees. Some people are breaking the device or putting less ice in so it doesn't get as cold, Johns Hopkins, and others are using coolers which are not approved to get to 10 degrees, but the data in the Guardian registry, which was presented at the ISHLT, didn't show a real difference in terms of survival or PGG. This is Vanderbilt data looking at their reusable 10-degree cooler. Again, not cleared necessarily by the FAA because there are things on these devices, which batteries and other things, but they show that the cardiac index and vasoactive inotrope score were improved, lactates were improved, and so there's some signal that these are better, especially at longer times. And then when they couple this with the DCD process with TA-NRP, so NRP at Vanderbilt, they noticed a greater impact as well. And so I don't base anything I do based on this evolving data yet, but I'm aware and I pay attention to other papers that come out to see if there's a signal there that may be helpful. A lot of people think it's mitochondrial resuscitation or preservation, and there are other agents to add, and that the lesser cold as a consistent temperature, not as a temporary point on the way to a colder temperature, may be helpful. What Asha says is the hearts simply feel better coming out of this cooler at 10 degrees. They're more supple and they don't feel frozen. Many of us who've been doing this long enough remember if you go for a long ischemic time with ice, you get these things that come out that are heartsicles. The heart is literally frozen and you get freezer burn or something like that. And those hearts generally, depending, can have challenges. So I'll leave you one last question. Which of the following statements is correct regarding the comparison between OCS and NRP, generally associated with improved perfusion, NRP associated with more favorable graft function, lower rejection, OCS and NRP, similar outcomes in terms of survival, and OCS is only effective in specific cases. So let's see what we got there. This is the last question. It should be close to the last slide. No, maybe one more after this. Almost there. Let's see. You keep going. Okay. So associated NRP. And so while I believe that that is likely true, I think at the current time it's most fair to say in a rigorous fashion that the results are relatively similar at this time, even though there's been several papers which are suggesting there's a signal, but we wait for larger single series or robust databases to help us understand the differences. I think NRP is certainly cheaper. So further innovations, alternative perfusion, combination technologies. There has only been one NRP to OCS case, and I think it was done by mistake. It's not because Transmedics won't actually allow that to happen at the current time. And that there's other, adding AI and looking at these to help us understand at what point should we walk away from a heart. There's a number of new solutions that are being developed similar to STEEN or similar in that they can be used for longer times, much longer times, and viability assessment biomarkers, whether we look at things like conductance of the heart when it goes in and when it comes out as a marker for changes or edema. And then, of course, we have to understand value-based data, and that is how much can we spend on these hearts. In 2023, we went to $1 billion total expenditure in the United States for heart transplant. In 2025, we're probably going to be close to $2 billion. We doubled in 2 years, and that's money that is getting harder to come by. Just ask Elon Musk. And so the cost-related change, and so I'll leave you with this. Challenge associated with OCS. OCS is less expensive due to the reduced need for transport. OCS is a higher upfront cost, and the cost difference is negligible. NRP incurs more costs related to additional monitoring and perfusion time. And so OCS is higher upfront cost, and that's true. And remember, it is a for-profit technology at the current time. There's no generic equivalent. There's no way to do it, although many people, including some people in Boston, are working out ways that maybe this could be done in a different way without that machine and done with normal machines there. And I'll end with a thank you. It's truly been a privilege to visit and come back to my home borough. Thank you.
Thank you, Scott. This was, as I expected, really amazing, and I was getting a little bit sleepy, but he completely woke me up. So, and there's always something new to learn. Any questions from the audience? Danny, I'll give you the mic because they can't hear you.
Terrific as always, Scott. I have a lot of questions. Number one, is there a role for ICE anymore? So your donor is in, I happen to get a donor from Newark or from, actually my same OR. Can we still use ICE or not? That's question number one. Number two, for your crystal ball, where does this field 10 years from now? Are we going to have comparative studies in the technologists? Is every paper is compared NRP with this shows the advantage for NRP. And some is significant now. So you think OCS is going to be around for a while? So we start with those questions.
So number one, I have a slide that it wasn't about, someone asked me to give a talk about preservation in general, and I have a slide with a skull and crossbones. ICE is dead. ICE is dead. Anyone who's using, and we even for shorter periods of time. So when we started using, so I started using Sherpa Pack when it first came out. And Dwayne Davis, who's my boss, only let me use it for 2 hours or longer. And the data was pretty clear to us that the shorter times will benefit also. And we know about the paradox of the 1 hour, that the short ischemic time with a 1 hour, less than 1 hour, had worse outcomes than 2 to 4 hours. And so I think the intentional cooling, homogeneous cooling, the temperature remains to be seen. I think 8 to 10 is ultimately going to be where we wind up, especially for longer hauls, because the cooling is going to be more homogeneous. The warming is going to be more homogeneous. The role of warming hasn't really been studied. How do you warm these hearts? So when you do it off ex vivo or you do it off of transmedics, you arrest the heart with cold and then you bring the heart up. But I think there's going to be if we don't go as cold, I think we're going to have to study how we rewarm the heart. How you rewarm the heart and how I rewarm the heart may be different. I mean, maybe you wrap it in a cold saline sponge. Maybe you put ice in the pericardium. Maybe they do it differently in Prague than they do it in the Bronx. That they do it differently in Boston. And so if there's a variable in the process, we should understand what the impact of that variation is. And I think that's going to be very important. The second question is, I think there's going to be consolidation and understanding of what's important in this area in 10 years, and there'll be different competing technologies. I think there'll be better solutions. We'll have better biomarkers or ways of assessing the heart's viability in the preservation we have. And I think at that point, we're going to be looking at 10 years from now, 12 to 24 hours of preservation for these hearts that come out. And what that's going to give us, paradoxically, is that's going to give us a more efficient market for the United States transplant system and maybe partnership with Canada or others. And what that means is if you need a heart in the Bronx, that you can get a heart in Alaska, and not just because you are willing to take the risk do you get access to those hearts. Or my favorite place to go for a heart is Puerto Rico. Right, and we talked about this, right? So my family is actually Puerto Rican, and the Puerto Ricanos, and so I've gone to Puerto Rico a number of times to get hearts, and the reality is all of those hearts have worked beautifully, right? Because most of them are young, and so the flight time and everything to come here is about 6 hours. Well, with the ischemic time, it's about 6 hours, and even it was for us in Philadelphia. In Orlando, it's a lot less. But 6 hours, those hearts work really beautifully in Sherpa or other technology, and so the answer is that you'll be more comfortable going 6 or 8 hours. So if you have an AB, you can go to New Mexico or you can go to California because there may be no ABs listed between here and there, or you can send the heart in Florida to Toronto, or we once took a heart out of Toronto to Florida for an AB who was a young woman who became a nurse who's a hypertroph. And so I think in 10 years, we will have a more efficient market. We'll have more effective use of heart donors because as was pointed out, and I forget whose slide, that transplant is still epidemiologically negligible, right? Whether we do 4 or 8 or 10,000 heart transplants, it still is terribly small compared to heart failure. Sir.
Scott, could you comment on the 10-minute hyperoxygenated perfusion protocol that the Vanderbilt folks are using? Are you aware of that?
Yeah, I am. I don't think they've given us enough information yet to say, but I think it's everything old is new again. right?
Yeah,
And
it
so,
used to be an old
yeah,
one.
so Danny Morelli taught me how to do that when we reperfused, and we reperfused with a filter, and we gave staged oxygenation to reperfuse the heart to avoid injury. I think here's the beautiful thing. I think everything we do is going to be studied in a way that will have some idea of what at least an ideal or close to best practice may be. And a lot of the opinion in the surgical process will give way to data and general agreement. We'll find other things to argue about. But I think that there are so many aspects, and taking every component of the operation, like a work process, and saying, what do we know? And nothing, okay, well, let's study it. What do we know probably, or what do we know yes? For example, do you give plegia when the heart comes back? Do you give plegia when the heart comes back immediately, or you give between every anastomosis? Retrograde or antegrade? Yeah, and so Stephen Boyce gives it retrograde. I do none of the above, and then other people just hook it up to a balloon and start perfusing it right off the bat, and they do the left atrium. And then do you do all the anastomosis? Do you do some of the anastomosis? Right? And so there's so many things. Like, you think you have a good surgeon. Now, I know you're a surgeon. I trained you a surgeon, so you do have a good surgeon. But the components of the operation that they choose to do and not do is a part of whether your assessment is they're a good surgeon. Do they get good outcomes? And it can be accomplished a number of different ways. I mean, so the left atrium, so half of the PA, connect the aorta and perfuse, or perfuse right away with blood out of the pump and reperfuse the heart as soon as the left atrium is done. There are so many ways to do it.
Do you think the beating heart transplant makes any difference whatsoever?
Repeat the question.
Yeah, so the question is, does beating heart transplant make a difference? I have not done it, but I can tell you that Mani Dineshman, who's a close friend of this program and ours, he swears by it, and he's not part of the people who started it and has no sort of agenda in it. And he says that the PGD that he has seen goes down dramatically. But now again, it's an ecosystem. You have to use OCS. And so it may be that if you use OCS, continue not arresting the heart and continuing to perfuse may be a way of mitigating the damage that we see with the perfusion. And then the other factor is, against the IFU, a lot of people, and so I don't want to attribute this statement to anyone in particular because they're not here, but some have said, we think that they over-perfuse on transmedics and we perfuse at lower rates because it's coronary perfusion. We think that leads to more edema. And so they're not going at the recommended rates and they're running their transmedic teams themselves. So there's all of these things like secret knowledge, and none of it is studied. And so it gets to be a really, really interesting field where it's impossible for a thoughtful person to do something in the best interest of their patients without data to guide them. So we all agreed that DCD and brain dead are probably equivalent, right? We agreed on that. We don't know, is 10 hours of the Sherpa pack the same as 5 hours? Because when we take that heart, we're sort of saying to our patients, we don't believe that we're behaving beyond the usual limits of risk that we have consented you for. And that's an important concept. And I'm not sure that that's true in all circumstances here. Or I'm not sure we have data I could show, let's say, to a lawyer and a judge or 6 people in the jury box to say that clearly it's the same. Because maybe it is, maybe it is.
Doc, can you tell us what's happening in the US in terms of acceptance of the NRP vis-a-vis the ethics around it? Is it expanding or not?
Yeah, so it's definitely expanding. So I think there are pockets. So it's interesting, you would think, and of course this is not going to happen. This is one of the things we said on the DCD, the NIH DCD working group, is that there really should be some societal education and acceptance, and the society should be educated. But that's not what's happening. What's happening is each individual hospital and each individual transplant center is deciding whether they're going to do it. And some OPOs are deciding at their level not to accept that risk. Now, that position is no longer going to be tenable. I don't think in 2 years for the OPO to say, we're not going to do TA-NRP, for example. And I think they have punted some of those decisions. Now, it's an interesting circumstance because you could take a pool of the transplant programs in the New York City, and some of them still cannot do NRP in their own hospitals, right? Some of them that you guys have spent years of your lives at, it's not approved for NRP, which is insane.
They'll take it up.
They will take NRP organs. They will take them, but they won't allow it to happen. And so that's a kind of an incongruency that's, yeah. So livers, hearts, and lungs they'll take, although for lungs, they want to do direct recovery in general, but across the way, they will take the organs. I know because they come to Philadelphia all the time, but they won't let you do it in their hospital, and they're not allowed to do it in their hospital.
That's unethical.
Well, it's something. It's probably something. You're right.
Same issue. Scott knows.
Yeah.
We have a dissonance in our own system.
Yeah.
It's something to work on.
Stop recording. No.
This is fascinating stuff.
Yeah.
Thank you. I have a lot of other questions. Well, thank you.
Perfect.
Yeah, we just had a discussion just to close it out with ISHAT about what you just said. Do you have a good surgeon? Do you not have a good surgeon? I mean, as a simple cardiologist, you often reduce, the party line is that heart transplant is often done by junior surgeons, right? And it's a simple operation with 4 connections or something like that. But what you said, the ecosystem of making, and this is something I was thinking about this regarding ISHRT, maybe even in listening beyond this.
So I have
plenary to have this to show how important this this operation still is, and everything that comes with it, especially in the day of DCD, DBD, OCS, etc. Be a great topic.
So, and I agree, and I have a symposium proposal I actually sent to Danny to get some feedback on about team function and dysfunction and looking at this. But so I will challenge you and I'll say, I'm welcome to, if you guys want to come back for another year, I look at it like, I'm a surgeon, what are my deliverables, right? And what's my minimum viable product? I mean, think about it like a business. I am a surgeon with a reputation and a skill that I offer. What are the things that I can do? What are the things that you can do? What are the things we can do together? And so there are 3 things that I think as a heart transplant surgeon, I owe the team that are my primary responsibility in the operating room. Number 1, the patient can't be bleeding. You can't leave the operating room with the patient bleeding. And that's a surgical problem. And that may be managing and interacting with anesthesia, but that's a surgical deliverable. Number 2, the patient has to leave the operating room with adequate hemodynamic performance and or support. You can have a problem and have PGD, put the patient on ECMO, put an impella in, put a balloon pump, make inotropes, whatever your cultural tools are and your thresholds are, you need to leave the operating room often at 2 o'clock in the morning or 3 o'clock in the morning when the skeleton crew is here with performance at said levels, not 5 inotropes, 2 pressors, and an index of 1.7 for the ICU and the cardiologist to figure and then call you up when you're tired because there's a level of ownership. Right. And that's very, very important. And the third part that I think is an important deliverable, which I know you do, is I used to take a picture of the operative field before the chest was closed, a video. I take a picture of the hemodynamics and the echo, and I put it on our secure text chain through Teams. So I want you to know what it looks like when I was done. And I have to hold to that. And if I didn't like how it looked, I would sign out to the cardiologist. I'm a little concerned about the RV. Let's reassess in 2 hours. But if we get to the ICU and the performance is terrible, I don't want you to think, oh, it was like that. We're doing nothing. I want you to say, well, the heart looked really good. Are we bleeding? Or is this compression? What is the issue? And so in the digital age, in the AI age, we have to transmit the information in a way that allows people to make decisions moving forward as if they were there. And to me, those are the surgical deliverables of any process.
Great, thanks. We should adopt those. And you just set the standard of excellence for next year, which was really amazing. We're going to close out MonteHeart 8. The activity code, if you need it, is 27RYES. I want to thank again our guest faculty, Scott Silvestri, Ivan Etuka, and Mandeep Mer. You really enriched our team enormously. And also, I have to say, very proud of all our other speakers. Our team really put on a great performance at every level. So thanks very much. Great meeting. See you next year.
Oh. Thank you. Well done. Have a great day.